esteemed panelists, presenters, and our chief guests. With that, I would like to welcome Dr. Sudhagar sir and listen to his words of encouragement and wisdom. Thank you.
Good morning to all the dignitaries, friends, faculty. I have been following the excellent work by JeevaRaksha Academic Conference. The state of Karnataka has always been in the forefront of providing high quality universal health coverage to all its residents. The Arogya Karnataka was first of its kind in the country when initiated across the state. Having an efficient ambulance system and one of the best healthcare infrastructures across the country, the government is keen to see high quality, evidence based emergency care provided to all the citizens in the hour of need. The need for trained doctors and nurses to provide state of the art emergency care has been brought to the forefront by the two peaks of COVID-19 pandemic affecting millions of patients across the nation. I am proud to note that the country's largest health university, RGUHS, along with the highly regarded NGO, Swami Vivekananda Youth Movement, came together as early as 2013 to initiate the Jeeva Raksha project in association with University of Utah, USA, to fill this gap. The pioneering effort in conceptualizing the world's first comprehensive emergency care and life support training for doctors and nurses, coupled with structural training program across the state, has already benefited hundreds of patients. The government is proud to note that the RGUHS-JeevaRaksha program have been conducted in other countries like Morocco and Kazakhstan and widely appreciated. The emergency care modules have also been now adopted in the nationwide training programs for the PHC doctors. In view of the raging pandemic, we are having this conference in the online format. It's heartening to see the global medical community together to discuss and educate on the different aspects. I'm sure healthcare professionals will benefit from the experience of esteemed who will also like to be app to the world. This app connects common citizens to the thousands of trained Jeeva Rakshaks across the state and has been successfully tested in the district of Chitradurga. This will ensure much needed care during the golden hour of medical emergencies and trauma. The concerted and passionate efforts made by RGUHS and JeevaRaksha Trust will make Karnataka the leader in state-of-the-art emergency care in our nation, and I am honored to be supporting this venture. Jai Hind.
Thank you, sir, for that inspiring message. I would now like to invite Dr. Prashant, Dean of Basaveshwara Medical College Hospital, and his team to show the work that has been done in an exemplary fashion in the district of Chitradurga in taking the knowledge and the skills that have been imparted to the candidates in transforming how emergency care is delivered at a community level. Over to you, Dr. Prashant and team. Thank you.
myself, and our Honorable Minister of Health and Family Welfare and Medical Education, Dr. K. Sudhakar, for giving us the opportunity and resources to make Taluk-based emergency care happen by providing ambulances and a paramedic staff who can respond to any sort of emergencies and use of telemedicine to get an expert help at the patient side within the community itself. It has been a great honor to be chosen by our Honorable Vice Chancellor, Dr. S. Sachidananda, as a part of our University of Health Sciences, a JeevaRaksha project, a first ever is to Nayak, the CEO of RGUHS-JeevaRaksha Trust, in giving us the responsibility and an opportunity to train the community members of Chitradurga in providing basic care support and towards the
Welcome back. So that was Dr. Prashant and his excellent team in Chitradurga, working with the district commissioner, the DHO, and other functionaries in the state in delivering the emergency care, the skills, the knowledge, through to the community with the help of Rajiv Gandhi University of Health Sciences and JeevaRaksha app, where information from the ground can be transmitted across to the hospital within seconds, as well as when an emergency happens, the patient's location can be sent across within seconds, and Google Map can be used to get to the patient wherever remote the patient has had the emergency. With that, I would like to now invite our Honorable Vice Chancellor, Dr. S. Sachidananda, to give Hello, I think I was absent for a few seconds.
Yeah.
Can somebody give me a thumbs up if you can hear me?
Yeah, I can hear you.
Yes. So, thank you, sir. So I was just about to invite our Honorable Vice Chancellor, who is also helping us out by giving feedback regarding the audio and video issues. Thank you so much, sir, for coming on Sunday morning and gracing us with your benevolent presence. And we are eager to hear your keynote speech inaugurating this conference. Thank you so much.
Thank you, Ram.
Over to you,
Thank
sir.
you very much. Thank you. Am I audible? Am I audible?
You're
Yes,
audible,
sir.
sir. Yes.
Yes.
Okay. Thank you so much. I thank Dr. Sudhakar for taking time off his busy schedule and sending us a message for this conference. I also recognize the presence of the RGUHS-JeevaRaksha Trust family members, the duo of Dr. Balasubramaniam, Dr. Vijay Bhaskar Reddy, and our own Dr. Ram, Dr. Harini, Dr. Haripriya, and all others speakers who have obliged to spend their time, to spend their expertise, and to share their views on this emergency care life systems, which is the need of the hour. Just to begin with the story, Dr. Sudhakar highlighted all these things. Our journey started somewhere in 2013 almost 7 years ago when I was the registrar evaluation. And with the help of University of Utah, we started this program, Emergency Life Support System training programs, because RGUHS is a pioneer in organizing such programs. And the whole idea was conceptualized, and we started training our faculty members. We need to have a pool of trainers who would carry on with the emergency life support trainings programs to further to the students and to all the stakeholders. So our first step was to create a pool of trainers, master trainers as such, who would carry on with this job. And it took us almost 4 long years to establish a pool of around 800 to 1,000 faculty members who are willing to participate in this program and also work as trainers. Rajiv Gandhi University of Health Sciences took the owners of training all these doctors through the Swami Vivekananda Youth Movement doctors, as I mentioned earlier. The team got together and they started training them with the support of University of Utah. The whole program, the module was conceptualized by University of Utah, and this is the only very comprehensive module that is available across the globe, wherein all the emergencies are clubbed together and the training is given for all the 7 or 8 common emergencies that we see in any casualty. So that is the importance of this. And going further, Rajiv Gandhi University of Health Sciences, in its 25th year of Silver Jubilee celebrations, also saw to that it was made compulsory for all the interns, especially the medical, dental, Ayurveda, and nursing students, nursing interns, to learn this, to get trained in the emergency care life support system. And the training now has been completed for all the faculties across the state, in almost all the faculties involving medical, dental, nursing, and also Ayurveda. And we've also made it compulsory and mandatory for at least the medical students as of now, both UGs and PGs, to get trained in this particular thing, and until then they'll not be given the completion certificate. So the importance of such a rule or regulation is to see that every doctor who passes out from Rajiv Gandhi University of Health Sciences is confident enough to face any emergency situation which he may likely to face in the real life situations. So that is what is important. And we have seen the fruits of this particular program. Many have come back to us saying that they have been able to save many lives, help many people in the times of emergencies and distress, and they are very satisfied about it. In fact, many students who get trained always express that this sort of a practical training was one of the best that they could have ever imagined, and also they were happy to have undergone this particular training. And today we are also launching the app, JRT app, which has been very successfully tested at Chitradurga. I thank Dr. Prashant for and his whole team for getting involved and testing this app. And this app will be launched throughout the state, and depending on the success, probably across India as well. And with all this good work that is being happening in the Rajiv Gandhi University of Health Sciences, along with the JeevaRaksha Trust, we have also got national and international recognition. Many, even the government of India has recognized this particular program, and we have received appreciative letters saying that this program is very well conceived, and we already implemented it at your state and also at the community level. So there is always a demand for such emergency training. We have been now not only looking at healthcare workers, but we are also looking across further, training police personnel, ambulance drivers, and even public for that matter, or any volunteers who want to undergo this training, because whatever we learn in this training will definitely come of use at dire situations. So with that in mind, JeevaRaksha Trust never kept quiet during the COVID pandemic also. We have been very active during COVID-19 pandemic, wherein the emergency crash course for healthcare workers, training them in ICU management, training them in handling COVID-19 cases have also been planned. Apart from that, we are also now got involved with home isolation and patients, telemedicine, telecounseling, and telemonitoring such home isolated patients. So all these are activities that JeevaRaksha Trust has been doing, and we have a very talented pool of faculty members who are always willing to train youngsters and also other volunteers on one hand, and second, they'll also be participating in this JeevaRaksha app, which will definitely save many lives in the future. And the utility of this particular app is going to be tested in the coming days, and I'm sure this would definitely help us in saving many lives across the state and give us the opportunity to see that the patients in distress are addressed immediately. I congratulate all the JRT team for the good work that they're doing. I'm sure this program would grow and reach greater heights and greater recognition. And one day we may be able to sit back and say proudly that we have done a work which is very satisfactory, which is very useful, and which is very necessary at this point of time. At the same time, this is the first ever conference that has been organized by JeevaRaksha Trust, RGUHS-JeevaRaksha Trust, in its 20 as a mark of its Silver Jubilee year. And also, we are proud to say that the emergency nurses training in emergency care was first of its kind across the world. That has also been organized, and about 150 nurses also have been trained. So with all this positive note and a bright future, I wish RGUHS-JeevaRaksha Trust a very bright future and good days ahead, so that whatever objective this trust has been formed will be achieved by imparting knowledge to all those who are interested in undergoing this program. Thank you so much. I thank JRT team for giving me this opportunity. Thank you very much.
Thank you very much, sir, for a comprehensive update on the activities that has been happening over the last few years from 2013. And you being a shepherd right from 2013 really has helped us. And we could hear your passion and your commitment towards emergency care and improving training as well as saving lives in communities. Thank you so much. With that, our inaugural function is coming to a close. So I would like to once again thank our dear Minister, Dr. K. Sudhakar, for sparing the time and giving us a good message, as well as inaugurating the conference and inaugurating the JeevaRaksha app. I would like to thank our Honorable Vice Chancellor, Dr. S. Sachidanand, for his presence and his blessings and message. Thank you so much for all the panelists who from different parts of the world have logged in so early in the morning to be a part of this inaugural function, all the delegates, as well as all the supporting team. And I want to particularly mention the core members of JeevaRaksha Trust, Dr. Vijay Reddy, Dr. Mahendra, Dr. Ramakrishna Reddy, Dr. Sitaram. There are quite a few of our senior members who've been part of the journey right from the beginning, who's also chosen to be part of this journey today morning in the conference. Thank you so much. And we'll be switching now on to stream 1 in this link. And stream 2 will be going on to another link which has been shared with you in the chat box. So those of you who want to go into the case presentations and the poster presentations, etc., please click on the link which has been shared. That is stream 2. Both the streams will come back together at 2 o'clock after lunch, when we will have the main stream running through with the talk on stress amongst the COVID frontline warriors and how to deal with it. The simulation presentation involving experts from Singapore, Malaysia, India, that is happening after that. And the very well and long awaited panel discussion with experts from across the globe who has had to deal with the COVID pandemic at different levels, from right from the front line in the slums of Mumbai, all the way to dealing with the problems at the top, at the WHO level. So we have got an eclectic bunch of excellent experts from across the globe, and that will be starting at 4:15 p.m. So looking forward to your presence with us throughout the day. Thank you so much. Thank you. That is the end of the inaugural session. Thank you so much. Jai Hind.
Yeah, good morning, everyone. We are in stream 1 over here, and the timeline for stream 1 goes like this today. We'll be starting with Dr. Sandhya, who will be giving us an update on ICLOR resuscitation guidelines today. This will be followed at 11:15 by Dr. Vijaya Karanam, who will be giving a talk on alternative learning strategies during the pandemic. This will be followed at 12 p.m. by Dr. Atul and Dr. Arunas, who will be doing a session on simulation training beyond the borders. And at 12:30, we'll be having a session on building resilience in rural India during a pandemic by Dr. Sitaram MR. So the first session is by Dr. Sandhya K, and I'm glad to introduce her. She is a professor and in charge of Department of Anesthesia in Bangalore Medical College and Research Institute, Bangalore. And she has been very active in gaining other qualifications like PhD in cell biology and postgraduate diploma in hospital and healthcare management from IGNOU, as well as she has 14 publications to her credit, of which most of them are international. She has been a major part of as a lead anesthetist in liver transplantation team. She has won a state TN Jha award in 2002, and she's vice president of the HICC. So she is also a quality manager for NABH and also a nodal officer for NQAS. Okay, she is also gladly a master trainer and senior instructor for our RGUHS-JeevaRaksha programs. Over to you, Dr. Sandhya. Please start your session. Thank you.
Thank you for the kind introduction, Dr. Rajshekhar Maitri. Could we have the recording of the presentation, please? Warm good morning to all the delegates present in this virtual conference of the RGUHS-JeevaRaksha. It's indeed an honor and privilege for having been given the opportunity to present my topic on the 2020 update on the ILCR resuscitation guidelines. I congratulate Team JeevaRaksha with the RGUHS in its constant effort to keep us updating with what is going on worldwide, to help us understand the latest guidelines in helping everybody across the world in saving more lives. The International Liaison Committee of Resuscitation, all of you have heard of the AHA, and we very keenly wait for the guidelines which come to us every 5 years to understand what are the latest recommendations, what is in, what is out, but a few words on what happens in the background to come up with these guidelines. The International Liaison Committee on Resuscitation, the ILCOR, was formed in 1992. It was basically formed to give a forum, to give a platform for liaison between principal resuscitation organizations worldwide, so that we put in data from all the corners of the world and to come up with a common guideline which is going to be applicable across the globe. The committee is multidisciplinary in its membership, and the name was chosen in 1996 to be relating to the treatment of the sick hearts, basically a cardiac arrest scenario, that is the ILCOR. The mission of the ILCOR remains to promote, disseminate, and to advocate international implementation of the evidence which can be used both for resuscitation and first aid, collecting the consensus summary of scientific data from across the world. Resuscitation for ILCOR defines all the emergency responses necessary to treat sudden life-threatening events affecting the cardiovascular and the respiratory system, with a special focus on sudden cardiac arrest. At present, the International Liaison Committee on Resuscitation is represented by the American Heart Association, the European Resuscitation Council, getting inputs from the Heart and the Stroke Foundation of Canada, the Australian and the New Zealand Committee on Resuscitation, with inputs from the Resuscitation Council of the South Africa, the Inter-American Heart Foundation, and the Resuscitation Council of Asia. So they collect systematic reviews, scoping reviews, evidence updates from all these organizations, and they compile data, they compare it to the previous updates, and either reiterate or reinforce the guidelines which have to be continued based on these evidences, or provide improvisation to the previous update, or get away with few recommendations which might not seem pertinent based on the evidence and the updates. So the International Liaison Committee Resuscitation gave the latest update in the 2020, and the guidelines, the changes in the guidelines were pertinent to three important groups. That is, they updated the first aid recommendation. There were mild changes in the algorithm updates for the pediatric system of care. And we also had a few changes coming for the adult BLS and the ACLS system of care. First, we look into what were the recommendations for the first aid providers for an out-of-hospital emergency situation. Out of the hospital, if you find a patient with a glaring evidence of a limb weakness, either one or both the limbs or one half of the body, with the evidence of, with or without evidence of one-sided facial weakness, with speech disruption, a diagnosis of stroke should be made and emergency service alerted or shifted to the nearby medical center for further management. If it is not a trauma situation, any patient complaining of chest pain, pinpointing towards the precordium, is assumed to be cardiac, and immediately the patient is given to swallow oral aspirin 325 milligram. And if you quickly elicit allergy of aspirin or related medications, so it is recommended not to administer aspirin. Instead, wait for help or shift him to an emergency service as soon as possible. And in the hospital setting, how do we recognize a case of hypoglycemia? A diabetic or a non-diabetic who suddenly presents with sweating, dizziness, complains of hunger pangs, confusion, presents to you with elevated heart rate, could be suspected to have symptoms of hypoglycemia, and if available, should be administered glucose immediately. There's no harm in taking his glucose levels up rather than missing a diagnosis for hypoglycemia. So there lies the importance of emergency administration of oral glucose. If the patient improves over the next 10 minutes, it is okay. Otherwise, if the symptoms do not improve, or if you see worsening of symptoms, he could be shifted immediately, call for help and shift to an emergency medical center. In a trauma scenario, if you experience a life-threatening bleeding situation, most important, like we see in the trauma guidelines, the first step would be to control the bleeding before you initiate other resuscitative steps. If we talk about a site of bleeding in the limb, a direct pressure would help immediately. If the application of direct pressure does not help, immediately apply a tourniquet with whatever appliance is available nearby. Where should the tourniquet be applied? It is 2 inches above the wound. Tighten the tourniquet till the sign of bleeding has stopped and immediately call for assistance. The last topic which they have highlighted is hyperthermia, though it is not relevant to our continent or our Asian subcontinent. In order to complete the recommendation, I would like to highlight a few points about the management of hyperthermia. With increased ambient temperature, you suspect a case of hyperthermia or heat stroke when the patient presents to you with history of nausea, vomiting, giddiness, confusion, a rapid high respiratory rate, and an increased temperature. So what do? We immediately immerse the victim in cold water and continue to keep the victim immersed until the temperature is less than 102.2 degrees Fahrenheit. So this is with respect to the recommendation for the first aid providers. Quickly moving on to what has been updated in the pediatric basic and advanced life support. So cardiac arrest, as we know, we do not talk about cardiac arrest in the infants. How we talk about in adults? The most commonest cause of arrest in a child outside the hospital seems to be respiratory. Very rarely we see cardiac arrest among children, but it's more common in infants and small babies. Overwhelming majority of arrest is attributed, almost 81%, is due to secondary to respiratory failure. Most commonest cause of respiratory failure in these children could be a sudden infant death syndrome. It could be a medical cause. Any medical, the child could be ailing from any medical condition, allergic reaction to any medication, or anything present in the atmosphere. Trauma contributing to about 10% of these cardiac arrests, of these respiratory arrests. Airway restriction either due to choking to a foreign body, airway blockade due to a foreign body, drowning, or intoxication. Evidence has showed that children who experience out-of-hospital cardiac arrest have a survival of 26% if they reach the emergency department as soon as possible and care is available immediately. So how do we improve the survival rate is an ongoing challenge, and ILCR is in its constant pursuit to review research to understand what can be done to improve the survival rates. The old guidelines said that if you have a palpable pulse of 60 or greater, but there is inadequate breathing, start to give rescue breaths at the rate of 12 to 20 per minute. That is one breath every 3 to 5 seconds until the spontaneous breathing resumes. So the new guidelines now defines what is a palpable pulse for us and how many rescue breaths should be given. There is number of rescue breaths have changed for us. One set of CPR now comprises of 15 compressions and 2 breaths for us. So the new guideline says that for infants and children with a pulse, but the absence of respiratory effort, it is reasonable to give one breath every 2 to 3 seconds, that is 20 to 30 breaths per minute. So the number of breaths has increased and the recommendation has gone in favor of any pulse instead of more than 60. So while providing CPR to infants or small children, it's recommended to perform 15 chest compressions followed by 2 breaths, considering as one cycle, and should be continued until more sophisticated life-saving measures are available. Prior to this, the recommendation was to give 30 compressions and 2 gentle breaths. So it is 15 chest compressions and 2 gentle breaths with the latest guidelines. So a look at the algorithm. If you have an unresponsive child without normal respiration, quickly call for help, call in a AED or a defibrillator, and quickly do a pulse assessment. It would not take more than 5 seconds to do this. If you have a weak pulse, so no definition of a rate determining what a pulse is, you just have a weak pulse, start administering one breath every 30 seconds. And if at all you feel that the pulse is going low after you assess after a cycle of 2 minutes, you could add on chest compressions. After initial assessment, if the child has no pulse or you're unsure, begin the cycle of 15 compressions to 2 breaths until your AED arrives. Immediately apply the pads if AED arrives. If it's a shockable rhythm, administer a shock. If it is not, resume your cardiac massage. So the change in the pediatric guidelines, to summarize, is one cycle consists of 15:2 instead of 30:2, and you don't wait to determine the rate of the pulse. Having a pulse, no respiration, start with your rescue breaths. No pulse, start with your cycle of 15:2. Moving on to the adult basic and advanced life support. What are the recommendations made? What did we get off compared to 2015 guidelines? As we all know, the in-hospital and the out-of-hospital chain of survival had 5 primary components linked. They were closely linked with 4 links. The whole idea of having a chain of survival is to lessen the time from recognition of an emergency cardiac or any other emergency event and how quickly the patient would get care and get transferred to a hospital for more advanced care. So what changed? The first and foremost change that has been made, based on which a lot of recommendations and guidelines have been added, is a 6th component to this chain of survival, that is recovery. All of us know CPR focuses, cardiac massage basically focuses on the return of cardiac activity. But have we thought what happens to the quality of life, the survival, the neurological outcome? You could not have a patient in a vegetative state, though you have revived the cardia. So it is important to give a functionally active patient back to the society It is quality CPR, what we are focusing on in this latest recommendation. So we're focusing a sixth component linked by a fifth chain has been added to the chain of survival, that is recovery. So what's the rationale behind adding this sixth component? So it has reiterated that support is needed during recovery, not only during cardiopulmonary resuscitation, it is during recovery to ensure optimal physical, cognitive, and emotional well-being and return to social functioning and to resume their normal roles, active social roles. So it has to be initiated from the time of picking up the signs of a cardiac arrest, continue during the hospitalization, and continue as long as it is needed till you send the patient back to the society. So let's look at what are the updated recommendations in order to improve the quality of CPR. So I told you guidelines are either updated or reinforced. So early CPR, cardiac massage has been reaffirmed. Quality CPR is the highlight of this recommendation also. Survival rate of 10% goes up for the outside hospital cardiac event when somebody starts a CPR immediately. So provision of CPR is the hallmark, is going to continue to be the hallmark of a cardiac arrest scenario management. So updated evidence of analysis of over 12,500 patients reaffirms. So it reinforces the importance of starting chest compressions, that is quality CPR. During manual CPR, rescuers, they have reinforced, should perform chest compressions to a depth of at least 2 inches or 5 centimeters for an average adult. Not too fast, not too hard. Chest compressions greater than 2 points. That's, I said, stick on to 2 inches and 5 centimeters. They say not too harder also, not more than 6 centimeters. This has to be avoided. This has a class 1 evidence and the level of evidence is B. So it is reiterated that it is not too hard because you're going to cause more harm by either causing a physical damage or reduced venous return, reducing the quality of your CPR. What about the rate? It is reasonable to perform chest compressions at a rate of 100 to 120 per minute. Class 2 evidence for it. So it is not faster than 120 and not harder than 5 centimeters. So it is recommended that lay persons, this is for BLS, that they initiate CPR for a presumed cardiac arrest. You presume, you don't waste time to assess if the patient has a pulse, rhythm or whatever. But if you find the patient is unresponsive and there is a high suspicion of a cardiac arrest, do not waste time in initiating CPR. Because evidence, what's the rationale behind this? The risk of withholding CPR from pulseless victim far exceeds the harm you do from unneeded chest compressions. They say the harm because of unneeded mechanical chest compressions is far, far less than the chances of the patient surviving if you initiate CPR immediately. So the BLS algorithm reinforces that. Just check verify if the patient is unresponsive with an abnormal or absent respiration. Call for help, call for AED and defibrillator immediately. If the person has a weak breath, if the patient has a pulse and a weak and is not breathing adequately, administer 1 breath. This is an adult every 3 seconds. And if you feel the pulse is weak, add on your chest compressions and assess pulse only after completion of a cycle of 2 minutes. If the patient has no pulse, begin CPR cycles of 15 compressions and 2 rescue breaths, the same as the pediatric guidelines. And once we know the importance of defibrillation in the adult cardiac arrest setting, so as soon as the AED arrives, check if the rhythm is shockable or no, and apply shocks if the rhythm is shockable, and resume CPR without checking the pulse. Resume CPR for the next 2 minutes before reassessing your rhythm. If your rhythm is not shockable, resume your CPR, and only at the end of 2 minutes are you going to do a pulse check to assess your rhythm. These steps should continue until more advanced life-saving measures are available or either the patient shows a return of normal circulation. So BLS reiterates on early CPR. Check if the patient doesn't have a pulse, no breathing, initiate a cycle of 15:2 without further delay. So our BLS guidelines says that you have an unresponsive patient. I told you, administer 5 to 6 breaths and assess pulse every 2 minutes. Start cycles of your 15:2 resuscitation. Sorry. What are the other recommendations in improving the quality of our CPR? They've added that it is recommended to monitor physiological parameters such as the arterial blood pressure or the EtCO2 whenever feasible to monitor and optimize the quality of CPR. So what do we mean by it? Our ventilation or the quality of return of circulation is assessed by measuring the arterial blood pressure and the end-tidal carbon dioxide likewise. It not only helps us to detect if there is a return of spontaneous circulation, after resuscitation, it could further be used to guide us in using the vasopressor therapy. So targeting, while doing CPR, you need to target your compressions to at least get an end-tidal carbon dioxide of 10 mmHg, at least 10 mmHg, but ideal would be something greater than 20 mmHg. And this can be used as a useful marker of CPR quality. So what is the rationale behind coming with these recommendations, reiterating the physiological monitoring of CPR quality? The guideline resuscitation registry shows that there is a higher likelihood of return of spontaneous circulation when the CPR quality is monitored. You know you're giving a cardiopulmonary resuscitation and a cardiac massage. Without assessing the quality, if you continue to do so, I told you have a very poor outcome at the end of your CPR. So it is prudent to use a monitoring during the process of resuscitation so that getting a feedback, you could improve your quality of CPR, improving the chances of a good neurological recovery. But the ideal target in terms of numericals has still not been given by the committee as far as the recommendations go. With respect to the timing for another change, the next change that has come in is early epinephrine administration. Epinephrine administration, no doubt, it has continued through all the guidelines that it has to be administered, but the only changes that have been incorporated is with respect to the timing of your epinephrine administration. So for a cardiac rhythm, in an adult, you would immediately, as soon as the AD arrives, you would check if it's a non-shockable or a shockable rhythm. The moment you detect that it's a non-shockable rhythm, you need to administer epinephrine as soon as feasible. So it has a class 2A evidence for it. For a cardiac arrest with a shockable rhythm, there is no doubt that the patient should receive defibrillation, after which epinephrine can be administered if the rhythm does not respond to your shock. What is the rationale behind emphasizing that epinephrine needs to be brought up the guideline, up the recommendation? It's because epinephrine is found to increase the chance of return to spontaneous circulation and also survival, leading to a recommendation that it should be administered early for patients in cardiac arrest. Class 1 recommendation. Any drug that increases the rate of ROSC and survival but is given after several minutes of downtime likely increases unfavorable neurological outcomes. So again, we are talking about recovery and the quality of life post CPR. So it says that the chances of ROSC and survival and a good neurological outcome depends on how quickly you can get the spontaneous circulation back. So early administration of epinephrine has seen to have a major role in it. So major beneficial approach seems to be in continue to use a drug. So I told you they retain few recommendations. So it is recommended to continue to use epinephrine, which has shown increased survival, but it is also focused on shortening the time to the drug for all the patients. So by doing so, we're going to have a patient with a favorable neurological outcome. And the other change which has been done in the recommendations for antiarrhythmics is amiodarone and lignocaine are now seen as equivalent antiarrhythmics in a cardiac arrest situation. And in the last, coming to the guidelines, at the end of the guidelines, a further step has been added to consider the appropriateness of continued resuscitation. You need to assess whether it's appropriate that you continue with your CPR efforts or no. Coming to the recommendation that has come, that has been suggested in ventilation during a cardiac or a respiratory arrest. So during a cardiac arrest situation, they have recommended that it is reasonable for a EMS provider to use a rate of 10 breaths per minute, not more than 1 breath every 6 seconds, to provide asynchronous, that is not synchronized with during continuous cardiac compressions before the placement of an advanced airway. If an advanced airway is already in place, it is reasonable for the provider to deliver 1 breath every 6 seconds, while continuous chest compressions, no interruptions in the chest compressions whatsoever. So not more than 10 to 12 breaths per minute is the recommendation for your ventilation. What about in a respiratory arrest situation? If an adult victim with spontaneous circulation with a good pulse requires support, it is reasonable to again provide a respiratory assistance in the form of ventilation at the rate of 1 breath every 6 seconds or about 10 breaths per minute. The recommendations which are got away in these guidelines, let's have a look at these recommendations. By double sequential defibrillation, after the 2015 guidelines, based on case reports, there came a recommendation in 2019 that you apply 2 different paddles at different sites and you give a sequential defibrillation. These case reports show that the success rate of defibrillation is more when you give a double sequential defibrillation. That is, shock delivery by 2 different defibrillators near simultaneously. This came as a new technological approach in 2019, but the systematic reviews by the LCR reveals that the usefulness has not been established. So the RCT suggests that changing or repositioning of the pads might be as effective. Reposition your pads. This could be as effective as your double sequential defibrillation. This went on to say that your double sequential defibrillation could cause more harm because of the increased energy given by both the defibrillators or causing physical damage to the defibrillators. So instead, with a single defibrillator, you can reposition your pads. So to highlight what has been added and removed in our guidelines, epinephrine comes over here if it's a non-shockable rhythm. If it's a shockable rhythm, of course, administer shock and epinephrine comes down the guideline. Amiodarone and lignocaine with the dosage mentioned in the right corner continue as equally efficacious antiarrhythmic agents. And as I told you earlier, considering the appropriatedness of continued resuscitation, these are the 3 changes made in the adult CPR guidelines. What are the other recommendations made in the management, patient management? New evidence suggests that there's some uncertainty about the efficacy of the intraosseous route compared to the IV route. First is the difficulty in establishing an intraosseous route of administration. The second is the uncertainty of the drugs acting likewise. So a class 2 recommendation is for the first attempt to establish IV access for administration of drugs in the cardiac arrest situation. IO intraosseous might be considered if repeated efforts at IV access are unsuccessful or is just not possible. So it would be the last resort. Otherwise, intravenous scores over intraosseous for drug administration. All of you know ultrasound has creeped into our operation theaters, ICUs for all the procedures because safety takes priority over everything else now. So what is its role? Let's review what is its role and what are the recommendations when it comes to point of care ultrasound in a resuscitation setting. The committee recommends that it can be used. Cardiac ultrasound can be used for recognition of a cardiac tamponade situation. When a tamponade is the cause of the arrest, it can be used for recognizing this condition. Likewise, it is to recognize a potential reversible cause of cardiac arrest. After you've done your 1 to 3 step of resuscitation, you need to look into whether it's a reversible or irreversible cause. Otherwise, continued CPR would not help as long as you don't reverse this condition. So there comes in the role of ultrasound where you need to recognize if it's a reversible cause of cardiac arrest. And you can see if there is if you have a pulseless electrical activity, you can use an ultrasound to see if there is some amount of cardiac motion happening on. So it suggests to use the point of care ultrasound for prognostication, but it's a level 3 evidence, level 3 recommendation. So recommendation does not preclude the use to identify a potentially reversible cause, but it goes on to say that it should not be associated with interruptions in chest compression. Why so? There is no sonological finding whatsoever with so much of high sensitivity for clinical outcomes to be improved. When you compare that, you're going to do an ultrasound terminating your cardiac massage cycle. So they're saying that there is no such a clinical condition which takes to say that you stop your chest compression and use your cardiac ultrasound for guidance. But still, it could be used for the prognostication, to see cardiac motion, and also to check for your reversibility of the arrest situation. This is with respect to the adult ACLS guideline, and also changes in the patient management. There are two more major guidelines added along with the ACLS guidelines. First is the opioid overdose. Again, not very pertinent to our country or the subcontinent, but for completion's sake, let me highlight the guidelines. So two new guidelines have been added, I told you. First is the opioid. So they reiterate that there should be no delay in activating the emergency response system while awaiting the patient's response to naloxone. So your sole criteria will not be naloxone and your idea to reverse the opioid overdose condition, but you should focus on emergency response, activating the emergency response system, and no further delay in your CPR measures. So standard resuscitative measures should take priority over naloxone administration, and you should focus on providing quality CPR, compressions plus ventilation. So when you suspect opioid overdose, call for help, call for an AED. If the patient is not breathing, does not have a pulse, start your CPR and follow your adult resuscitation guidelines. And meanwhile, you can administer naloxone simultaneously to see for the response. The second major guideline which has been introduced is for a cardiac arrest in a pregnancy situation. Why was it needed? What was the rationale? It is because a pregnant lady has a very poor reserve when you talk about oxygenation. There is very less time for which she could withstand hypoxemia. Ventilation and oxygenation are very important in the setting of pregnancy because of an increase in maternal metabolism and also low functional reserve, due to which there is a very high risk of fetal brain injury from the resulting hypoxemia. So they recommend that when you recognize an arrest situation, it's very important to recognize a team planning and executing your role likewise. It should be done in collaboration with the obstetric team, the neonatal team, the emergency, the anesthesiologist, the intensivist, and the cardiac arrest services. There is a class 1 recommendation for this. Provision, they focus on provision of high quality CPR and also to increase the venous return. As all of you know, in obstetrics, the recommendation is to cause a left uterine displacement so that you release aortic cable compression and help venous return. If you find a pregnant lady with a fundal height above the umbilicus and you do not have return of spontaneous circulation, with the usual resuscitation measures, you've given left lateral uterine displacement, so it is prudent to prepare to evacuate the uterus while the resuscitation team continues with their CPR, a class 1 recommendation. So to accomplish delivery early, within 5 minutes after the arrest, it is if a patient is already ready for delivery, if at all there is no return of spontaneous circulation within 5 minutes, immediately prepare for a perimortem cesarean delivery with initial BLS and ACLS continuing. So this is the algorithm which has been given for obstetric care. A cardiac arrest in a pregnancy in an in-hospital setting. Initiate a high-quality CPR. Meanwhile, assemble the medical cardiac arrest team. So consider what could be the cause of cardiac arrest so that you could divide the team to perform obstetric interventions and to perform and the maternal interventions is towards return of spontaneous circulation, focusing on high quality CPR. So what would the obstetric team do? Continue with your left lateral uterine displacement, quickly detach fetal monitors and prepare for perimortem cesarean delivery. If at all there's no return of spontaneous circulation in 5 minutes, immediately consider perimortem cesarean delivery team, and meanwhile also alert the neonatal team to receive the neonate. Meanwhile, the maternal intervention team continues with high quality CPR with all efforts to get the maternal return of spontaneous circulation as quick as possible. After talking about the recommendations for and the changes with the resuscitation algorithm, we go on to see what are the recommendations with term to post-cardiac arrest care. This again re-emphasizes on the sixth component of a chain of survival, that is recovery. So what are we doing in order to improve the quality of recovery? So the critical component of the chain of survival, that is recovery, it demands that a comprehensive, structured, multidisciplinary system of care should be implemented in a consistent, it should be a continuum of care involving a multidisciplinary system for the treatment of post-cardiac arrest patients also, following revival from a cardiac arrest situation. So it has also come up with a new algorithm which defines there is the initial stabilization phase and additional emergency activity, what has got to be done on an emergency basis after your return of spontaneous circulation. So this guideline on the post-cardiac arrest care has re-emphasized the need not only to revive the patient and also prevent further hyperoxia, excessive administration of oxygen, hypoxemia, and hypotension. So what do we need to do in order to maintain all these? Adequate blood pressure management, monitoring for considering the neurological damage the arrest could have caused, monitoring for and treatment of seizures so that you improve the quality of neurology, and a targeted temperature management is re-emphasized. So the changes in the algorithm include that the target oxygen saturation which needs to be maintained is 92 to 98% and separated out as an initial stabilization and emergency intervention, I told you already in the guideline. So the initial stage stabilization phase would include to manage the airway, manage respiratory ventilation parameters in order to prevent hypotension, to manage the hemodynamic parameters likewise. So in the post-cardiac arrest care algorithm, what if the patient continues to be comatose? So we need to prognosticate the patient, know what is happening. So we need to obtain a brain CT, do a continuous EEG monitoring. Meanwhile, when we are investigating the cause, we could continue with other critical care management systems. So they've also added guidelines on the reversible etiologies. And what has happened in the algorithm, they've removed the drugs and the dosage details on the right and added the reversible etiologies instead. And there's also an added section on initial stabilization and a continued management with additional emergency activities on the right. So this is what I talked about. The guideline, the post-cardiac arrest algorithm includes an initial stabilization phase and a continued management and additional emergency services. So when we look into what is there in the initial stabilization phase, we need to, I told you, we need to manage the airway, manage the respiratory and the hemodynamic parameters. So what are we doing? Early placement of advanced airway so that ventilation is taken care. Start with 10 breaths per minute, maintaining a saturation of 92 to 98% and a PaCO2, arterial carbon dioxide of 35 to 45 in order to improve your neurological recovery. And coming to hemodynamic parameters, the recommendation is to maintain a systolic blood pressure of more than 90 mmHg and a mean arterial pressure of 65 mmHg. And to make a diagnosis if there is a reversible cause and if some emergency management could help in recovery, we do obtain a 12-lead ECG. If a STEMI is present or unstable cardiogenic shock, you could use mechanical circulatory support if required. And then we check if the patient is following commands. Awake, that is a good neurological recovery. If we feel we need to do anything here with respect to a cardiac condition, then they could immediately be shifted to a cath lab for further procedures. That is, if the patient is awake, neurological recovery is good. And other critical management, care management occurs simultaneously. If the patient is comatose, again, we are going to investigate what is wrong there. And side by side, the critical care management continues. So as I already mentioned, the drugs which were mentioned before which were used to maintain hemodynamic parameters have been removed, and then continued management with respect to additional emergency services has been added here, along with the reversible causes of cardiac arrest. So what happens in these patients who remain comatose? We need to prognosticate who needs to be actively intervened and try that they further don't deteriorate. Again, this involves a multimodal approach and is not based on a single finding. This has a class 1 recommendation. So evidence-based guidelines is to be followed in a systematic manner in order to facilitate multimodal prognostication. Specific guidance has been given based on when do you need to do your clinical examination, when do serum biomarkers need to be done, electrophysiological tests and neuroimaging. When is the ideal time this has to be done? But they say that prognostication, you delay the prognostication till adequate time has passed after your administration of drugs so that it's not confounded by the medications you have given during the stage of cardiopulmonary resuscitation. And to perform multimodal neuroprognostication, a minimum of 72 hours should have passed by after return to normothermia. You would have done targeted temperature management, maintaining hypothermia following cardiac arrest. So you have to wait for a minimum of 72 hours before you perform these neuroprognostication interventions. So we have also been given a diagram, schematic diagram, which will guide us what needs to be done at which stage. Clinical management continues, TTM, rewarming, return to normal temperature. Imaging, you could, in a deeply comatose patient, you could get a head CT, which progresses to MRI. And then your electrophysiological studies has to wait for some time. Clinical examinations go side by side, pupillary right reflex, the corneal reflex, and then serum biomarkers likewise. You could do your neuroprognostication only after 72 hours after normothermia and decide whether the patient could have a favorable recovery or no. So if we go on again to see why, what are they talking about? The sixth component of the chain of survival, that's the recovery and the survivorship. Recommendation are critically important to this concept because there should be a structured assessment for anxiety, depression, the post-traumatic stress, and the fatigue. Not only the survivors, the caregivers undergo. There is a class 1 recommendation that we need to strongly look into these factors. The cardiac arrest survivors should have multimodal rehabilitation assessment, and they should be treated in hospital for the physical, neurological, and the cognitive impairments before you discharge them from the hospital. So a revival from your cardiac arrest is not your goal, but see to it that there is a holistic improvement in his recovery, and you send back a socially viable person into the society. The cardiac arrest survivors and the caregivers should receive comprehensive, multidisciplinary discharge planning also. It should include medical and rehabilitative measures which are going to continue long after, and how do you see to it that they return to their active and work expectations. So to summarize, what do we have the changes by the committee with respect to visual aids and algorithms? A sixth link has been added to the chain of survival. The role of epinephrine early administration has been one of the change, and 2 new opioid-associated emergency algorithm has been added for both the lay rescuers and the trained rescuers. A new diagram has been added to perform and inform neuroprognostication. A new cardiac arrest and pregnancy algorithm has been added. The major changes when we talk about the algorithm as such is the use of real-time audiovisual feedback. Reiteration is on to maintain quality CPR. So you get a real-time audio and a visual feedback whether your CPR is going well. In order to continue maintaining the quality of CPR, you need to measure a few physiological parameters, that is the end-tidal carbon dioxide and the arterial blood pressure. The routine use of double sequential defibrillation is not recommended anymore. Intravenous Sorry for the interruption. Intravenous access is the preferred route of administration during the ACLS resuscitation. Intraosseous is acceptable if IV is not available. Care of the patient after return of spontaneous circulation requires close attention to oxygenation, maintain your normal blood pressures, evaluate if any percutaneous coronary intervention could reverse the cause for the arrest situation, do a targeted temperature management, and multimodal neuroprognostication. There should be a formal assessment for support for the physical, cognitive, and psychosocial well-being. Most important, but not the least, is deep debriefing for the lay rescuers, the EMS system, and the hospital-based healthcare workers to support their mental, and it can be very mentally traumatizing post-arrest situations. So to support the mental and health being, very important to have a debriefing for your own healthcare workers. Maternal resuscitation with preparation for early perimortem cardiac delivery, if necessary, to save the infant and also to improve the chance of further resuscitation of the mother. So these are with respect to the adult BLS and the ACLS guidelines. Keeping in mind the current COVID-19 global pandemic, ICLR has brought about interim measures and recommendation in order to focus on the safety of our healthcare workers in particular. So what did ILCOR do? It undertook a systematic review of evidence until March 2020 from rescuers who were providing care to COVID-19 cardiac arrest situations, and they've told there is no recommendation with respect to the patient treatment guidelines. So what are the changes? It is the insights and interim measures focus more on the treatment providers or the rescuers so that they themselves do not contract the infection and take it to the community in large. So they've suggested a few modifications in our guidelines to check for, when we check for responsiveness routinely, we look and feel if the patient is responsive, and we also feel for breathing, not only look, we feel for breathing. So what they recommend is when you're assessing breathing to see if the patient is breathing spontaneously or no, look for breathing. Do not open the airway or place your face near the victim on any circumstance, and call the EMS immediately if the patient is not responsive or breathing normally. We call few procedures has a high risk to aerosol generation, putting the healthcare provider into risk. So what are these? Chest compressions and cardiopulmonary resuscitation have the potential to generate a huge aerosol. So they suggest that the lay rescuers can consider only compressions and public access defibrillation. This is given as a good practice statement. Consider rescue breaths only if there is a highly motivated healthcare providers in children, not in adults. Healthcare professionals should use PPE for all the aerosol generating procedures during resuscitation. Healthcare, before donning your PPE, we know the risk, we need to consider the risk-benefit ratio. We know that defibrillation is considered to be a non-aerosol generating procedure. And we also know the chances of survival is very high in an adult if we defibrillate at the right moment. So they advise that the healthcare providers provide defibrillation before, it takes some amount of time to don a personal protective environment, equipment for your self-protection. So before wearing your PPE, consider defibrillation, and then you can do your aerosol generating procedures later. This is a good practice statement. Coming to chest compressions, the recommendations which followed from 15 to 19 said that mechanical chest compression is not advisable, but in a COVID pandemic situation, they reiterate on considering mechanical chest compressive devices. So they say that COVID-19 should be considered. COVID-19 situation takes precedence over the cardiac arrest, especially in a setting when the protective equipment is not available or is limited for the care provider. Emphasis on how do we manage the airway during a cardiac arrest situation in a COVID-19 patient. So what are aerosol generating procedures for us when we talk about airway management? It is ventilation with a bag and mask, or supraglottic airway insertion and ventilation, and also tracheal intubation and ventilation. So the minimum requirement is to wear a complete PPE, or in a minimum have an N95 or a compatible respirator with a face shield, glove and gown. So these are very high aerosol generating procedures, so not to be conducted without the protection of the healthcare provider. What do we do when it is about bag and mask and supraglottic airway are completely not recommended because they generate high aerosols as compared to advanced airway placements. A supraglottic airway can provide a better seal compared to a face mask. And for ventilation with a bag mask, you have to pause chest compressions for ventilation using a 30:2 compression ventilation ratio. Use two hands, both your hands, to form a tight seal so that the leak is less, and while the other person can squeeze the bag when they pause. So when you have two rescuers, you won't be doing it simultaneously. Pause chest compressions. The first one rescuer holds the mask tightly, and the second rescuer squeezes the bag. It is compulsory to use a viral filter, that is whatever is available, a HME or a HEPA, between the self-inflating bag and the airway adjunct, whether be it a mask, a supraglottic airway, or a tracheal tube. And airway and all the ventilation interventions to be performed by the most skilled provider at that moment, so that the time to provide the skill is reduced, and to strongly consider video laryngoscopy so that the healthcare provider stays away from the patient, and to pause chest compressions during all your airway interventions in order to minimize the risk of aerosol generation. So they've come up with a guideline for the CPR during to confirm COVID-19. So first comes don your PPE, and we saw in the ACLS guidelines, they've considered resuscitation appropriateness, but this comes on top. So the COVID-19 situation takes top priority compared to the cardiac arrest situation. So consider, is it important to initiate a CPR and have limited personnel don CPR and start don PP and start your CPR. If at all it is a lay bystander, consider using a AED. Shockable rhythm, shock. If it's an asystole, resume CPR, and here advanced airway is always to be considered as top priority instead of continuing with your bag and mask ventilation. The rest of the recommendation continue. Consider mechanical compressive devices, and likewise, if there is return of spontaneous circulation, you move on to your post-cardiac arrest care. So this is about the interim measures suggested by the committee for management of arrest situation during the COVID-19 pandemic. Waiting for any queries or questions on the guidelines which have been presented. And I thank the RGUHS-JeevaRaksha team for having given me an opportunity to present the recommendations. And it's a very pertinent topic considering the pandemic that is going worldwide. And I'm really thankful to the organizing committee for setting up this platform to present our guidelines on a virtual basis so that it reaches a larger audience. Thank you.
Yeah. Thank you, Dr. Sandhya. It was a very descriptive presentation, and we really got to know the difference between what's recommended now in the pediatric BLS, as well as a lot of things regarding how we should be taking care during the COVID time, especially now that we are facing this pandemic. And that makes a lot of difference for us to deal with patients who need CPR during the pandemic condition. We have a couple of questions, and a good question came out from the YouTube. It was streamed live on YouTube, and we got one of the questions from YouTube. So I would like you to take up this question. Would you please? So the question is, what do you mean by double sequential defibrillation, and how is it given?
Yes, by double sequential defibrillation, we mean that they use two defibrillator machines, one placed anteriorly, the usual positioning of the pads, and the other laterally. So they save one shock. See, we got away with stacking of shocks when shocks were delivered one after another. We got away with that, and what we said was defibrillate once, don't wait for assessment. You go on to continue your cardiac massage for the next 2 minutes and then defibrillate. By double sequential defibrillation, we mean two pairs of pads are applied simultaneously, and we delivered a biphasic shock one after another immediately. So that these were based only on a few case reports that came in 2019. But then we found that the harm caused because of increased energy and the physical damage was more. So that's why this recommendation says that no application of simultaneous two defibrillator machines. So that's called a sequential defibrillation.
Thank you so much for clearing there about it. So another question to you is, a patient who has had a history of rib fracture, having cardiac arrest, can CPR be given in such patients?
Injury, a rib fracture could cause a contusion or a penetrating injury to the lung, but withholding a cardiac massage is life-threatening. There could be a loss of life. So taking that in consideration, with the strap applied, you could continue a cardiac massage.
So you recommend the strap and then we can continue with the cardiac massage.
Yes.
Yeah, thank you. There were a few questions which you have already answered live, but I would like to take it up for the benefit of the rest of the attendees. And here happens to be a few attendees who are undergraduates, and maybe that's a question that has arisen from the undergraduates over here. What are the shockable and non-shockable rhythms? Can you please tell it for the benefit of others?
When we talk about the arrest scenario, we have basically 4 types of arrest rhythms. That is a ventricular fibrillation, and a ventricular tachycardia, which does not have a pulse. A peripheral pulse is not present, but there's a ventricular tachycardia. And the other is a pulseless electrical activity. You find some activity, ECG changes on the monitor, but there is no pulse. So there is no effective cardiac contraction. And the 4th rhythm is a asystole, complete asystole. So considering the 4 rhythms, we divide them as a shockable and a non-shockable rhythm. When we talk about ventricular fibrillation and pulseless VTAC, there is abnormal electrical activity. So what do you do by delivering the shock? We reset this electrical activity and set it into a sinus rhythm. So these 2 are shockable rhythms, ventricular fibrillation and pulseless VTAC. When we talk about asystole or a pulseless electrical activity, the cardia is already stunned. That is, it's not contracting. So you do not shock such a rhythm. If you shock, you're going to further stun and stop the heart. So this situation, you're not going to. So in the AED, what happens once you apply the pad, the AED itself picks up whether it's a shockable rhythm or not and delivers the shock if it's a shockable rhythm. In a hospital setting, we need to orient the students or the healthcare providers to differentiate between a shockable and a non-shockable rhythm.
Thank you so much for making it so simple for us and making us understand it. And definitely, yes, AEDs have an understanding about what's shockable and not shockable. That is what we need to emphasize. Yeah. One more question which was there, which I would like you to repeat the answer here for the rest of us, is how to differentiate between push fast, push hard versus push not too fast, push not too hard. Rate and depth, how has it been managed now? How do we train people in this?
Training, the NMC guidelines say that everybody should be trained UG, right from UG to PG in a simulator, in a simulation lab. So all these mannequins, NMC has, and the AHA guidelines has made it compulsory that there is a mechanical feedback device. The mannequin is connected to a feedback device. So when the performer does a CPR, it gives an audio-visual feedback whether your rate is adequate or your depth is adequate. So mechanically, I mean, audio-wise, once you do a mechanical chest compression on the mannequin, there is a click heard that will tell you that the depth is adequate. Or if it is too hard, the feedback device gives you a feedback that it is too hard. And the rate, likewise, if it is less than 100, it gives you an alert that the rate is not adequate. If the rate goes more than 120, it says that you're too fast and you're too hard. So it is compulsory from AHA and NMC to have a feedback mechanism in these mannequins so that we train the students adequately before they perform it live on the in a cardiac arrest scenario.
Absolutely. We have been finding this kind of mannequins everywhere now, and students are able to learn much better with those clickable ones, where the click makes you aware that your position and your pressure is adequate. Quality is good. So we have one more question over here that says that, ma'am, could you please tell us if ETCO2 is widely available, because it tells about the quality of the CPR?
Yes, it is not widely available because only multi-para monitors with more than 3 channels would have an end-tidal carbon dioxide monitoring. So insist all the more that these monitors are provided, otherwise it doesn't make sense. When we talk about physiological monitoring, we also re-emphasize that when available, because arterial blood pressure monitoring again is a different module, might not be available. So in order to improve your quality of CPR, we insist on providing monitors which measure both arterial blood pressure and end-tidal carbon dioxide.
Okay, one more last question. Yeah, one more last question. Like this push fast, push hard versus push not too fast, push not too hard. does it have any impact on the physical, neurological, and cognitive impairment in the patients of CPR, I mean, patients in post-CPR scenario?
Push too hard will reduce the venous return, thereby return of spontaneous circulation, or it could cause a physical damage. So not too fast, again, reduces your time to return of spontaneous circulation. So that's where the quality comes into picture. You could have a revival of your cardiac activity, but if your brain circulation is reduced, you will end up with a patient in a very poor neurological status or comatose status. So that's the reason we have insisted on quality, maintain the depth and rate.
Thank you, Dr. Sandhya. Dr. Ram is a trauma specialist, like he is an emergency medicine guy. So can I invite Dr. Ram, please, to come and answer that one question what we had on rib fracture patient and having cardiac arrest during a CPR. If you please would allow me. Thank you. Dr. Ram, please.
Thank you. Sandhya, excellent presentation, a good summary of all the new updates. Thank you so much. And by the questions, you can see that the delegates really enjoyed it. Thank you. Thank you, Raj, for bringing me in. In trauma, particularly where you get a lot of rib fractures, you might get sternal fractures. Many a time you could get open pneumothorax. And in a young patient where there is a cardiac arrest, there is a role for direct cardiac massage. So if you've already got an open pneumothorax, you can go in and actually with your hands do cardiac massage, as well as give the direct cardiac defibrillation with a long handle. Many times our anesthetists are available, aware, especially the cardiothoracic ones, that there are these long defibrillatory handles, which you can literally place on the heart and do a defibrillation. Same goes for CPR, as Dr. Sandhya was saying. Rib fracture in itself is not a contraindication for stopping CPR. If you're worried about pneumothorax, tension or otherwise, intubate the patient and just continue with your CPR, because the most important thing is to make sure the heart is continuing to work. You can repair the other things. They are not a big deal. You can manage the patient otherwise, but restart the heart and don't stop the CPR worrying about the fractures. Thank you so much.
Thank you so much, sir, for clearing the doubt regarding the fracture. Dr. Sandhya, it was an excellent presentation. Thank you so much for being with us today and kickstarting this Stream 1 timeline. And I'm glad to have you here. Thank you so much for your presentation.
Thank you, Dr. Rajshekhar, for moderating it. Thank you very much.
So do we now go to the second what session we have in the timeline? That's by Dr. Vijaya Karanam. The topic is alternate learning strategies during the pandemic. Let me introduce Dr. Vijaya to you. Dr. Vijaya Lakshmi Karanam is a consultant obstetrician at the Royal Women's Hospital, Melbourne, and a senior lecturer at Melbourne University. She qualified as a doctor in 1997 from Vijayanagar Institute of Medical Sciences, Ballari. She did her diploma in obstetrics and gynecology in 2001 from Mysore Medical College, Karnataka, and worked for a few years in India before moving to the UK. In UK, she successfully completed her postgraduate qualification MRCOG in 2005, and after completing her training and working as a consultant obstetrician in UK for a couple of years, she moved to Australia. She's a clinical researcher and has many publications and presentations to her merit. She was awarded a PhD on the subject maternal tissue perfusion and hypoxia-regulated genes in preeclampsia and IUGR. She specializes in looking after women with high-risk pregnancies, and her research interests are pregnancy complications, mainly preeclampsia, fetal growth restriction, and perinatal mental health. She manages a birth suite in a busy tertiary hospital and has vast experience in managing obstetric emergencies. Teaching is her passion. We are going to have a glimpse of it now. And she has been involved in conducting emergency skills drill course for many years, both at a local and national. Welcome, Dr. Vijaya. Over to you for your presentation.
Thank you, Dr. Maitri, for your kind introduction. Well, so just want to make sure, can you hear me? Can all of you hear me?
Yeah, you're audible. Thank you.
Yes, yeah. So disabled. So I want the host to enable me to share the screen, please.
Yeah, it's enabled, ma'am. You can try it.
It is enabled. Okay. It still says, okay, excellent. Here we go. Okay. So I've been asked by the panel to talk about alternative learning strategies during pandemic. You heard my introduction from Dr. Maitri, and you must be thinking, what am I doing? I'm not an educator, and how can I contribute towards this topic? To start with, I'm an obstetrician. As Dr. Maitri said, I work in a tertiary hospital, so I get to teach medical students. I do formal lectures, bedside teaching, small group teaching. I'm a clinical educator, so I teach my residents, registrars, and midwives and nurses on an everyday basis. I'm a researcher, so I supervise some students, both the research and honors student. But more than anything else, I'm a thirsty learner. The COVID did not stop me from attending meetings, courses, conferences, and seminars. And last but not least, I'm a parent with 2 children who've been doing online learning and classes for the last almost 1 year. So whoever has children will know what it means. We have to observe and facilitate their teaching. So I'm going to bring all this experience into today's talk. So my talk is not about giving more information or any new information. It is like my task is to encourage all of us as health professionals to think about alternate ways of learning during this pandemic. Just a bit of a background. The world has been overtaken, as we know, by coronavirus 2019 pandemic since March 2020. Most countries implemented lockdown and social distancing recommendations for fear of COVID-19 spread. Now, because of this, medical education has been affected with the halting of lectures, clinical placements, and key examinations. Most of the normal old-fashioned CME education that we had has been cancelled. And as we are currently doing, most of them are online webinars, seminars, and meetings, courses, and conferences. On top of this, we need to keep it up to date about the developments, not only in our field, as we always have done, but also about COVID-19 during this pandemic. And as we all know, the information is ever changing. And most importantly, as health professionals, we need to learn to be COVID safe and train others to do so. So these are the challenges that we are facing, and in the next half an hour or so, I'm trying to address each one of them and try to see if we can make any meaningful changes in the way that we have done things in the past, pre-pandemic. So the traditional Indian way of learning was always through apprenticeship. As we know, we had Gurukulas in the very, very past, and which including medicine was taught in that way. The modern medicine, in fact, was originally classroom-based until mid-18th century when William Osler, who is considered to be the father of modern medicine, introduced bedside teaching. And since then, it has been the main method of learning in medicine. He famously said, medicine is learned by the bedside and not in the classroom. So this pandemic is challenging this very idea and compelling us to think of alternate ways of learning. So currently we are using various platforms like WebEx, Zoom, Google Meet, Google Teams, Skype, TeamLink, GeoMeet, GoToWebinar. These are the few to mention. There are many more in various parts of the world which are being used. And of course, we are getting a lot of emails through information through email attachments and lectures. But we need to ask, are they enough? Are they able to substitute our traditional way of learning through observation? I'm not going to bore you with this, too much of information which is there on the slide. But in brief, the adult education was kind of based, the planning behind the medical education, and in fact, any university education is based behind the COBS learning style inventory, which revolves around the experience by observation as the main theme or focus behind adult learning. So when we learn through observing, through experience, and we reflect on those observations, and then we form abstract concepts because of a reflection, and then we experiment those ideas. And that's the kind of a cycle of learning. Are these online platforms enabling us to do so? Are we learning in the way that we are supposed to learn using these online platforms? Let's focus on medical education. So online teaching has played a key role in medical education over recent years in some developed countries. So a systematic review, which was done in 2016, suggested that offline teaching and online teaching are equivalent in terms of outcomes of examinations. However, what has changed? Because of the COVID-19, it is just not online teaching is not just part of the learning process now. It is the main method of learning. So remote learning is taken precedence over the bedside learning or face-to-face learning. In fact, the effect of pandemic might be longer on medical education, and online learning might stay as an integral part in future. A recent study, which is published in last year, end of last year, done by Samuela Dost, looking at perceptions of medical students towards online teaching during the COVID-19 pandemic, had some very kind of findings which are not very surprising, but quite important for us to learn from. Findings of the study: overall, students did not find online teaching to be engaging or enjoyable, with limited opportunities to ask questions. Not surprising, isn't it? Family distractions, lack of internet connection, timing of tutorials, anxiety, and lack of space are found as barriers to effective online teaching. Students also commented on experiencing a lack of motivation, difficulty in concentrating and asking questions, and lack of contact with colleagues as further limitations. The main advantage of online teaching appeared to be that it saves students on time to travel, especially if you live in a busy city, either like Melbourne or Bangalore, I guess. It provides flexibility and the ability for students to learn at their own pace. It is more comfortable, and it cuts the cost of travel, of living away from parents if they're in the not same city. It was also found to be time efficient, allows more time for students to focus on preparing for clinical placements. Some students found it less anxious doing online education and being able to be present wherever they want. So in our university, Melbourne University, the medical students get webinars through lectures. For their lectures, they get webinars. Zoom, they use for small group discussions, and they use emails, and they get presentations through emails. And Google Classroom is used to share the work. And if they're lucky enough, like this medical student who attended for the very first time in this whole year, a face-to-face in some clinical areas, which are thought to be less or more COVID safe, pre-recorded lectures and online interactive modules they have, and online simulation, which we will go in a bit of more detail towards the end of this talk. I did a little interview with 15 medical students to actually find out how they have been coping and what they feel about the online learning that they've been doing for the last 1 year. And well, I've divided into pros and cons, and the advantages they found mainly the flexibility, that's freedom to learn whenever and wherever they want, focused learning and learning at their pace. They all found it's cheaper to stay at home with their parents rather than living in the dorms, and the comfortable to use chat function to participate in discussions than in lecture theaters. They found very interesting because some of the students who are a little shy, they actually thought that they could engage better or in learning when through online platforms compared to face-to-face. And also, some of the universities, actually Melbourne Uni, in fact, invited guest lecturers from other university lecturers and professors to talk on those topics, interesting topics. So there was a bit of enhanced learning in that aspect. And of course, less or no time to travel. Then looking at the disadvantages, of course, the main one is lack of hands-on training. I mean, no amount of online training, online teaching or learning can substitute for the face-to-face experience that the medical students get by being in clinics. Some students found it difficult to get feedback through online learning, and difficulty to focus. A lot of students did mention that. Inability to complete set tasks due to distractions. Fewer opportunities to explore patient social history and its implications on health. And of course, unlikely to observe clinicians working in multidisciplinary teams has found to be of some significance to some students. And most of the elective work here in some parts of the world has been cancelled because of the COVID. So some of the surgeries, some of the procedures that they would have seen in normal circumstances, obviously they were not able to. And not able to attend face-to-face simulation courses because they're not as good as the online ones, or not as good as the face-to-face ones. And the main one, which I want to focus, is an impact on mental health. These teenagers, or just past teenagers, who are staying away from peers for many, many months, and a lot of students had minor to major mental health issues, which I think one of the topics will be covered later part of this conference today, on the impact of mental health and how the coping mechanisms during the pandemic. So I just compiled some suggestions, some from the study and some from my interview, from the outcomes of the interview that I conducted. Moving forward, in order to maximize the benefits of learning, it is better to incorporate a mixture of online and in-person teaching. This can be incorporated into an effective learning method, such as problem-based learning or team-based learning, which have shown to improve learning outcomes. In team-based learning, students are sent online materials to study and are then expected to discuss content in person in a group tutorial. So there's an element of online and face-to-face, or kind of more interpersonal skills developing aspect to it. This allows students to study at their own pace in a manner suitable to them, holding them accountable for their own learning, and at the same time, opportunity to mingle with their peer group. While students find problem-based learning or sessions to be interactive and to improve self-directed learning, team-based learning has been found to be more engaging and conducive to learning in preclinical settings due to smaller groups. So this, I thought, is a little kind of, regarding the medical student learning and teaching. Then moving on to the trainees, like whether we call them postgraduate students or fellows or residents or interns, their training and their learning curve has also been affected because of the pandemic. The residents or the interns, majority of them are posted in COVID wards and inpatient wards, and their exposure to other specialties of medicine is getting limited. So this can have an impact for the future generation of doctors that will be produced in the next few years. And the lack of elective procedures, that means they haven't had operative chances to operate or chances to assist in the surgeries, enough numbers. And for the senior trainees, like fellows and postgraduates, limited exposure to subspecialty training, like in my field, urogynecology, or in orthopedics, maybe hip replacements and loss of replacements. All those kind of elective procedures have been paused in many of the countries. So that will have an impact on training for the senior level trainees, and inadequate training in their specialty, as mentioned earlier. So these are the things that senior level trainees are, have to deal with, and we need to find some strategies to how to alter and how to provide alternate platforms for the senior trainees to learn these normally the things that they would have normally learned otherwise. Then moving on to our CME activities. So as trained doctors or health professionals, we normally get to attend some CME activities every year. And this was my last pre-COVID visit to Bangalore. Actually, it was one of the JeevaRaksha's team members are here. So you get to meet people. It's about networking, the conferences. So that element is definitely not there if you have CMEs online. Or of course, you go to an exotic place and enjoy a bit of, away time from work along with learning something new. So those aspects of CME in the past are no more. Now the CMEs are more like, okay, sitting at home on our own in front of the laptop and try to focus without falling asleep and having some coffee. And my dog gives me company sometimes when I sit in front of the computer. So times have changed. And so we all need to incorporate changes into and move along. So there's a recent study which is published in PLOS. They looked at the physicians' attitude towards webinars and online education amid COVID-19 pandemic. Some interesting findings of this study, actually. They interviewed around, I think, 2,000 people, healthcare professionals, and it's a 25-item questionnaire. It is done in November 2020. The survey was created and distributed to physicians from different medical and surgical specialties and different countries via several social media platforms. I think they use LinkedIn, Twitter, and Facebook as well. 60% reported attending more webinars compared to the same period last year. The general impression was 75% was strongly satisfied or satisfied with the most satisfaction for training courses. Interesting, isn't it? So they found courses more helpful than just the conferences and webinars. However, 75% felt overwhelmed with the number and frequency of webinars during the pandemic, which is true. 52% reported attending less than 25% of webinars they're invited to. 63% disagreed that webinars can replace in-person meetings and conferences. And so, recommendations. They came up with some recommendations as to how these seminars should be conducted. And I've gone through a couple of sources to put everything in order so that all of us can think before hosting or organizing the seminars. What can we do to make the online seminars, conferences, or webinars more how they used to be in the past, though they might not replace the face-to-face ones, but making them as useful as they could be. So the webinars should be regulated through the local regional scientific organizations to arrange for the timing, frequency, and topics in order to avoid repetition and overlapping of activities and to help limiting screen time exposure. For local meetings, a predetermined monthly schedule can be helpful in avoiding overwhelm and burnout. Say, for example, a meeting with X, Y, and Z teams is always on a Wednesday afternoon. And if you're working in different hospitals, meeting with another hospital could be on a Thursday, so that you're not constantly worried about organizing your schedules and calendars. These little things might help. Avoid non-working hours and weekends to reduce disruption of work-life balance. However, as this conference is a bit of an international one, the time zone differences still remain an important challenge, so sometimes it might not be possible. Studies have shown that the best time to hold a webinar is midweek, with a strong preference for Tuesday and Wednesday. Interesting, isn't it? I would have never thought about it. The general principles of conferences still have to be followed, and general principles of presentation when you organize an online conference. For webinars, research in the field of brain-based learning has resulted in some useful learner-centered techniques for planning the content of webinars to maintain high attention and concentration levels. So if you're doing a webinar in a particular focused topic, it's always better to limit a session to 20 minutes or less, followed by 5 minutes of discussion. Of course, it's different if you're talking about courses on conferences. For the course, it was found to provide timely assessment and feedback is very important, especially with the online ones, because if you're doing a face-to-face one, you get the feedback, you are assessed, and then it's all in one place. And we have to follow the same rules when you're doing an online course. Conferences, the speakers should be highly qualified, well-known, and respected in their field. If more than one speaker is required, those with opposing views can be chosen to make the discussion livelier. So the scientific content should be novel, updated, and non-biased. The virtual experience should be enriched with multimodal learning elements, including videos, images, and audio files, rather than merely presenting slides in order to attract and engage more audience. I guess this is no different from the online ones from the face-to-face ones that were done in the past. And also, a little emphasis on social interaction among participants is crucial, because as I mentioned earlier, networking is one of the advantages that we all had when we attended CMEs and conferences, where you meet people who think like you, and either in the research context or teaching context or general practice context. So those kind of facilities to encourage social interaction, either in the chat or Q's and E's or a parallel session towards the end of the conference, could also play an important role. So the two-way interaction of teaching must be implemented. Knowledge assessment can be made prior to and after webinars and to ensure better understanding of the subjects. An interactive Q&A session during live sessions is also beneficial. CME accreditation is important to ensure high quality of webinars, as physicians usually require a specified number of credits annually. We all know that, to maintain medical licenses. Technical issues should be addressed in order to ensure digital equity. Internet connection problems is a difficulty that needs to be anticipated, as not all attendees speakers have access to the same amount of bandwidth. A recorded version of the lectures can be kept for a specific period of time to allow for better self-paced learning. So these are a few things that about the CMEs, the seminars, the meetings that are organized for the already trained doctors that we can look into. Then moving on to learning about COVID-19. This is another topic on its own. I just thought I will show you the snapshot from the World Health Organization. This is an amazing source, actually. There is a lot of information about vaccinations, about training, about simulation courses, and a lot more than what I would have thought I'll find on the WHO website, which is really interesting. Well, the complexity of learning about COVID, as we all know, the rapidly changing guidelines, we all need to have massive adaptive learning skills to keep up to date with this everyday changing, changing guidelines that are kind of given to us. Every morning you get up and something else is new and something else is changing, and another medication is working, another is not working. So we all have to be really up to date with what is happening around us. Abundance of information, and there is a constant change as well of the information, as I mentioned earlier. And as healthcare professionals, we also have the responsibility to actually curate this information that's available and present to a diverse range of learners to share with patients and public about what is evidence-based and what is right or wrong. And we also have to develop some strategies to support the healthcare providers and build resilience and coping mechanisms during these pandemic times. So there's a lot for us to actually do and cope. So how do we learn to be COVID safe? There was no warning and there's no instruction manual for dealing with a pandemic of this size. So it's learning in progress. Every healthcare worker should get training in PPE usage. And we need to adapt all the current existing teaching, training, and learning activities to include COVID precautions. And as Dr. Sandhya has mentioned earlier in her CPR training, we have to include PPE training as part of every simulation course. And we need to develop online training courses and modules, which would change and include the COVID safety. And because of the paucity or limited availability of face-to-face training, simulation is going to be the way forward, even more than before. I thought I'll just focus on the modified simulation courses. As I said, there are lots of simulation courses for various situations that we come across in medicine. So it's not possible for me to touch on individual ones. But as a general rule, all the currently simulation courses that are provided should have modifications and include COVID safety as part of the simulation course training, which include communication, equipment, PPE, staff and psychological PPE, and planning ahead. I think if we kind of use these 5 core principles as changes into the current existing simulation courses, we would be able to address each one of them. Let's look at communication. The communication itself could be challenging because if you're not able to enter the room straight away, because before entering into the room, if you have to don the PPE, then that is the first hurdle. That's the very first hurdle, is we won't be able to communicate as we could in the past. So that needs to be included in your simulation course. So, and we need to minimize number of staff where possible, but important to call for more help when necessary. So that is another new thing that we need to introduce. When calling for help, clearly state what the emergency is and who or what help you need. It's important to allocate the team leader. I guess it's the same as before, but more emphasis on it. Then looking at the equipment and environment, there has to be some changes made in this as well, both in real life situation and of course in the simulation courses. We need to talk about an anti-room. That is, before entering the room or the COVID ward, there should be an anti-room. All equipment needs to be either disposable or should be thoroughly cleaned. Things like trolleys, pans, weighing scales, paper clips, and clipboards. We need to think about every small item that goes into the COVID room or COVID ward and to make sure that either they're disposable or thoroughly cleaned before they are reused. And contaminated equipment is to be placed in designated plastic box and to remain outside the room until transferred out safely. PPE. So all the simulation courses should start with training for PPE. So the personal protection equipment, the donning and doffing of it should be done in the ante-room. Consider extra PPE station outside the room or ward so more staff can don at once in an emergency. A PPE buddy must be allocated to supervise donning and doffing. These are found quite useful in actually real life situation because we all do things a bit wrong in the moment of stress. So having a person who could actually oversee and make sure that we are doing things correctly will actually be very useful. The PPE buddy must be competent in use of PPE and confident to speak up. Do not rush when donning and doffing. Before entering room, perform a final PPE check. And having a mirror in one of those rooms, it's very practical. Just we can have a look and see whether we covered our face or covered our nose and covered, all the exposure sites where we could get exposed to the aerosols, or we've done properly is what we're looking at. Then this aspect is a bit interesting. Staff and psychological PPE. We all know that it's exhausting to be in the PPE. So there is extra load on our cognitive senses when we are wearing the PPE. The usual tasks require more attention, so it's okay to slow down. Mentally and physically demanding in full PPE gear. We can feel claustrophobic and isolated. So availability of fluids and restroom prior to donning should be made. And with COVID-19, the safety of ourselves and colleagues must come first. Do not enter without full PPE. I think Dr. Sandhya mentioned in a previous talk as well that our safety comes first. As doctors, we are so used to looking after others first, but as they say in any of the safety instructions that are given in the flight, put your face mask first or oxygen mask first before helping the person sitting next to you, even though the person is your child. That applies here as well. Make sure that you are safe before you think about the safety of others. So there is no emergency in pandemic. It is quite contrast to what we have been taught as doctors for many years, but it is important that we have to slow down and make sure we are safe. If it is one thing that I need everybody to take home from this talk is this. So the next few slides, I'm going to talk about a little bit of online simulation training. So I'm an obstetrician, as I said. So I do simulation courses for obstetricians and neonatologists. I'm part of one of the courses called OneSim, which is here in Melbourne. In trying to accommodate this as useful during the pandemic, we have converted the course into online course, which focuses on obstetric and neonatal emergencies. So I'm sure every other simulation course could or has already been gone online. And when we are conducting online simulation courses, as I mentioned earlier, it's important to use those strategies in place and making sure the courses are not getting or as focused as they were when they're face-to-face. One of my little babies that I'm trying to work on currently is a simulation course in managing common obstetric emergencies in our regional language, Kannada. This I'm planning to make it online. So using online platforms, the course will be a mixture of pre-recorded content and live feedback in both English and Kannada. Hopefully this should be available by mid-July. And there is one course that I'm designing specifically for doctors, including obstetricians and neonatologists. And the other course is aimed for nurses, ANMs, and ASHA workers. And if anybody needs any information, I'm more than happy to be contacted or work alongside if any suggestions on this. And as a summary, the facts to consider while organizing e-learning activities. So there should be emphasis on learning and not on teaching. We all have to incorporate new and alternate ways of learning during the pandemic. And there is no preset textbook that we can get this information from. So it's a learning in a progress. I think simulation is the way forward, especially with less face-to-face learning opportunities being available, and getting feedback and constantly improving the courses should be done in order to make them more available and appropriate and to serve the purpose. As human beings, we are proved to be fittest in the race for survival. So our main advantage over other animals is our ability to learn quickly. So the pandemic will go away eventually. Meanwhile, we need to focus on finding alternate ways to continue a learning process because that's what keeps us ahead of the game. And with this, I want to end my talk, and I like to thank my two beautiful children, especially my daughter, to make this slide a pink and colorful. She said that will look good rather than my plain slides, which I guess is true. And I would like to thank the JeevaRaksha team. Some of the team members are there in this photo. Dr. Ram Nair, Dr. Vijay Bhaskar Reddy, and Dr. Vibhu, and so many others that I haven't met. And also like to thank Rajiv Gandhi Health University for supporting the JeevaRaksha team and giving me an opportunity to share my views today. Thank you.
Thank you so much, Dr. Vijaya. It was a wonderful presentation. I was hooked to it from the first to the last slide, actually. And thanks for taking us initially through the system where what we had Gurukulas to Hostler to Zoom. Wonderful. And highlighting on the plight of students during this pandemic on this online coaching going on. And I do agree with you that the major plus point in this online system is that the shy students are really coming up with questions. That's been all of our personal experiences so far. And the con definitely is of that mental health of staying away from the peer group and being in this kind of a secluded place for yourself is really, I think, is going to be a major issue in the coming few days. I just hope that the pandemic goes off away and what's of all these cons what we are having. And thanks for making the recommendations on for doing us having us scheduled all these things on Tuesdays and Wednesdays. Now I think most of us will be jam-packed with schedules for Tuesdays and Wednesdays. Yeah, I think that is one thing which I took from your presentation, that most of that will be effective if I put it on a Tuesday or a Wednesday. And I think you were spot on and on telling that we are really in the requirement of a massive adaptive learning skills for engaging into online modules. Yeah, there is no emergency in pandemic. Thank you for assuring us that. And I think we all will take care that there is no emergency. We will first protect ourselves first, then jumping into the emergency without any protective equipment. So we do have a couple of questions for you. The first one comes with the thing that with the online teaching learning going on, what is your take on lecture classes, online versus offline, as well as what are the ideal platforms for online learning for practicals or clinical classes pertaining to the teacher-student?
Thanks for asking. As I said, we are all learning together in this. I don't think there is any textbook ever written so far as to how we're going to conduct these online lessons. So lots of universities have used lots of different ways. And I was talking to my colleagues back in UK as to what all the universities in the UK have been doing, and few of my old friends from India. And universities here in Melbourne and Monash. Most of them have, the common platforms have been like Zoom and WebEx. Fortunately or unfortunately, they're all free and we are all able to access it. Some of the things which others have used is recording with the patient consent, which I don't think it is happening as much in the Western world as in India. As to say, for example, there is a dermatological condition that is quite rare and you think that students will ever get a chance to see it. So they're recording and then, communicating with the students. So that is a slightly different one that I haven't come across here, but some of my friends in India have mentioned. And so the main mode of delivering the lectures has been attachments through email. So where it's a pre-recorded lecture and you send to them. If it is an online, ongoing live lecture, so they are using either the Zoom platform or WebEx platform to deliver those lectures, which I've been doing from our Melbourne Uni. Yeah, so I think people are using different modes, but the bottom line is to make this ongoing effort to connect with students and make sure that they are being involved. And like I was asking my son, as I mentioned, who is a teenager, he's doing online classes, and he says, yes, if there is a task set and if there is a focus on the video, make sure that you are being engaged. I think that plays a role rather than just sending a pre-recorded version of the talk and then expect them to focus for the next 40 minutes on it.
Yeah. Thank you. So the next question would be, what is your opinion on augmented reality in skills training? How much of it is used in the West?
Sorry, 1 second. Can I see that? Can you repeat the question or can I see it? Yeah.
It is in the chat box. I'll tell you. What's your opinion on augmented reality in skills training? How much of it is used in the West?
Well, I'm being honest here. I don't know what augmented reality is. So if I know that, I could probably answer the next bit of it.
Dr. Ram, can you just pitch in with the clarification on this question? Dr. Ram, if you're there.
Hi, I'm here.
Yeah, please. Can you just throw some light on that question?
Yeah, augmented reality. Do you have an idea what it is exactly?
Yes, augmented reality, mixed reality, and virtual reality are different themes and strategies used in simulation training from afar. So the kids nowadays, especially the interns and the final year students in nursing, allied health, and medicine who have joined us today will understand virtual reality, because if you put up a headset like an Oculus, you suddenly get transported to a 3D different world where you can see, if you look around, different things, and things come at you. You might be shooting or you might be racing, whatever the game you're playing. The government has banned this particular game called PUBG, but this can also be played in that kind of an environment. So the video game builders have thankfully taken up this technology into medical skills training. And it started in US, as always, in the critical care training, particularly in the pediatric environment, where if a sick child is coming to you, you got a ventilator, you got all the machines in the virtual environment. How are you going to utilize that? How are you going to link up with your team? And virtual reality is where you can see things and you react. Augmented is where you do things to the environment and changes happen depending upon you turning a knob on the ventilator or you're picking up a thing. So this kind of added layers of reality being brought in. And mixed is where you actually see something which is specific for your condition, like a patient who is down on the ground with cardiac arrest, or for example, a COVID patient with mask on, struggling to breathe. So you see that patient alone in your environment. The rest of it will be wherever you are. So you might be in a clinical environment where there is no patient, but if you put the headset on, suddenly this augmented patient will come into your reality and you can have an interaction, a conversation, and do things to them. Excellent tools in training, particularly in the current times of pandemic, where the risk of you getting infected or you getting sort of intertwined in the problems of the ongoing clinical care with all the limitations that we have for other people coming in, versus getting the skills and making sure that you learn on a different entity like a skills trainer or a simulator, or even in a different reality where the patient is not being affected, you get the lessons. And the biggest advantage of this environment is that people are put through stress. So if you're sort of sitting in front of a video, you're sitting in front of this video to all the candidates out there, we can't ask you questions. You can't interact with us in the audio way. You're only putting in chat messages to us. So while Dr. Vijaya, Dr. Rajshekhar and myself are a little bit stressed because you're seeing us live, you out there are not stressed. And the shy ones, like Dr. Vijaya said, can come out with the questions. What these kind of realities do is, whether you're shy, whether you're smart, whether you know things, whether you don't, you're put in the real stress of dealing with a patient who has got significant illness. And whatever you do, whether you do the right thing or the wrong thing, it will impact on the outcome of the patient. So if you do the wrong thing, the child, as I said, will die in front of you and the parents will start screaming at you. And all that happens in that environment. If you do well, the same thing, you see the child getting better, the parents thanking you. The real stress of an emergency situation, you can be put under, and you learn a lot in that kind of a situation, as opposed to it's an experiential learning in the virtual environment with the best tools available at the moment. So a good technology to increase learning from a distance. Thank you.
Thank you, Dr. Ram, for making us clear about the augmented reality thing. I think that's a way to go forward from simulation to augmented reality, probably. Dr. Vijaya, what has been your personal journey in strategizing anything for this online simulation courses?
Well, as I said, I'm not an expert in simulation, but what my aim and focus is to make common things available more to wider population or wider healthcare professionals, rather than, yes, it is good to have technology, as Dr. Ram mentioned. If you get a feedback during the simulation course where we can actually make sure whether the training that has been provided or whether what they're performing is up to the mark, it's great. But my focus currently is to say, for example, how we conduct a normal vaginal delivery in a rural hospital in India when the patient is COVID positive. So it's not rocket science, it's not expensive, but my idea is to make it possible to have a standard where, yes, you need to have PPE, then you need to have basic glove and basic clean environment and what to do and what not to do. So that has been my current focus. And because I'm not an expert in simulation, I don't think I'm aiming or planning to do any, sophisticated simulation training courses, but to provide basic courses through online simulation to wider healthcare professionals or healthcare practitioners.
Thank you so much. Yeah, thank you so much. You mentioned about the PPE buddy, right? So do we need a dedicated team to play that role, or is that any training strategy required for them?
Yeah. No, over here, what we said, I could be a buddy for another person and he or she could be a buddy for me. It is just having another person who can actually speak up and tell if you haven't. Say, for example, if it's a very senior doctor, there is always a level of, seniority in any kind of organization. So we want somebody, not the junior most of the person, who is a buddy who cannot tell the senior most consultant, like, you have forgotten your goggles or you have forgotten so those are the very basic ones, but we all can do mistakes. So we need a person who has been told or taught that, yes, if you find somebody that they're not following the protocols or they're forgetting something, speak up and let them know. That's all. They don't have to get any additional training than the normal training with PPE, but having been taught and told that, yes, it is okay to speak up and, you have that is your responsibility.
Thank you so much, Dr. Vijaya, for being here with us today. and throwing so much of light on the alternate learning strategies what we can have during this pandemic. Thank you so much.
Thank you. Thanks again, everybody.
Yeah. At this point, I would like to tell that RGUHS-JeevaRaksha Trust is developing AR, VR, MR simulation environments in Indian settings with IIT Madras augmented reality settings with IIT Madras and Indian Institute of Science, Bangalore. The collaboration between these three are going to bring augmented reality into emergency simulations in India. Thank you. So with that, we have come to the end of the second session today. We are quite well in time, and I now request two eminent simulation heroes to come and present the next session. That's Dr. Atul Malhotra and Dr. Arunas Kumar. Can we have both of them, please? So to introduce both of them, yeah, hi. So introducing Dr. Atul over here. Dr. Atul is a consultant neonatologist, research scientist, and educator in Melbourne, Australia. Atul has a PhD in fundamental neuroscience. His research interests focus on improving outcomes of high-risk infants. He has a special interest in developing new therapies and interventions for the babies at risk of adverse brain development. He has been instrumental in translation of a number of preclinical therapies from the lab to the clinic. He has a special interest in regenerative cell therapies for neonatal conditions and is currently involved in a number of early phase trials of stem cell therapy. He's a passionate educator, especially in interprofessional simulation-based education. Through the OneSim program, he has been running maternal and neonatal simulation-based education programs in Australia, as well as low and middle income countries. Welcome, Dr. Atul.
Thank you.
And now I would like to introduce the other participant of this session, Dr. Arunas Kumar. She is a consultant obstetrician and gynecologist and educator in Melbourne, Australia. She has been a discipline lead, coordinator, and evaluator of undergraduate medical education and oversees a number of interprofessional educational initiatives. She has a PhD in interprofessional education. She also has an interest in simulation-based education and skills training and runs multiple workshops for medical and midwifery or nursing students in Australia. She co-founded the OneSim program with Atul, which she is running in Australia and in multiple locations overseas. Welcome to this session, Dr. Arunas. And over to you, both of you, to start off with this session. Thank you.
Thank you. So thank you so much for the kind and generous introduction, Rajshekhar. So what we're going to do is we're going to play tag team. So I'm going to start off with the first part of the talk and session, and then Arnaz is going to take over. All right. So I'm hoping all of you can see my screen. All right. Yes. Okay. So
the screen is visible. Thank you.
Okay. Thanks. So I'll just warn you that we are going to toggle between screen and a couple of videos. And the idea is to give you a taste of our endeavor, which is called OneSim. OneSim stands for Obstetric and Neonatal Emergency Simulation. And we have been running this for more than 5 years now. We are in fact in our 6th year of OneSim. So I'll just take you through a bit of that journey. And the organizers gave us a title to talk about simulation training beyond borders, because we do this work not just in Australia, but also overseas. We are obviously Indian, so we focus on India, but our collaborators take this program to Africa, to the Pacific Island, and the other Southeast countries. So I'm just going to take you through the journey of OneSim, and hopefully we'll open up some more avenues to collaborate with not just JeevaRaksha, but others who might be listening. So why is OneSim important? It is important because maternal mortality still continues to be a significant scourge on outcomes for mothers all around the world. In this chart from WHO, you can see the countries which are in the dark purple are the ones which contribute to high maternal mortality rates. India, although is not in the darkest color here, because of its sheer numbers in population, contributes a big burden of maternal mortality. Most of this is due to either lack of resources in the antenatal period or postpartum hemorrhage in the postnatal period. Similarly, neonatal mortality rates are also quite high in certain parts of the world, specifically in sub-Saharan Africa and Asia, including India. And if you look at the Indian contribution to the global neonatal deaths, if 100 neonates die every hour, 100 neonates die every hour in India, and that is India contributes to almost a quarter of the neonatal deaths in the world. So you can imagine both maternal and neonatal mortality is a huge burden for a number of low middle income countries, including India. So we thought, given that we were obstetricians and neonatologists as a couple, we thought we need to do things together and we need to do it as one. And that's why the one SIM comes from that. Basically, we are trying to help maternal and neonatal mortality at the same time. Okay, so we're going to start off by showing you a video of the initial one SIM experience, and hopefully that will give you an idea of what it involves. Okay, so I'm going to share a video and I'm hoping that it will work fine. Is working all right?
Yep. Share the audio.
Everybody,
we are not hearing the audio at the moment.
Okay. Okay, now let's see if it works.
And their husband and wife.
30 weeks and 2 days pregnancy, mom had severe preeclampsia. So we needed to do emergency cesarean section.
They're bringing hope to families who've experienced.
You can hear the audio?
Yes, it's loud and clear. Thank you.
Big day tomorrow?
Yes. And now they're piloting a program to bring rural Indian hospitals up to speed.
The gap we realized most of them have is that they're taught in their medical school or nursing school or wherever they come from about what is childbirth and what to expect and so forth, but there's no hands-on skills training.
Recently, they travelled to the Punjab region of India to help prevent deaths associated with complex births for both mother and child.
Very good. Go.
Using sophisticated simulation technology, they upskilled health workers, teaching them to understand the complications causing mass bleeding, uterine rupture and perinatal asphyxia, which can cause death or long-term brain damage in newborns.
Doesn't matter. Clear hona chahiye is cheez pe ki kaise dena hai. Very important. I've set up the simulator and asked the midwife, okay, just think of this as a real woman. What would you do? They were amazed. They couldn't believe that such sort of training exists.
Arunaz and Atul migrated from India 13 years ago and have experienced their home country's shortcomings firsthand.
There are personal experiences that I can draw upon where I've seen women suffer, have bleed extensively, and nothing much could be done about it. If I knew then what I know now, I probably would have been able to do something about it.
Postpartum hemorrhage is the biggest killer of new mums in third world countries. Here, it's something we almost never see, and it's easily prevented. That's why Atul and Arunaz are going back to basics, education being their primary objective.
Difficult births and babies who are compromised probably 5 to 10 times a week. We see those kind of situations 5 to 10 times a year. So it's huge. And I'm just talking about one institute.
They hope they can drastically reduce that number and expand their program to other developing nations. For Atul and Arunaz, it's also about giving back.
It was always there that doesn't matter where we may be, which part of the world, we would always go back and do something to help the women.
Sarah Arbo, SBS World News.
So that was just sharing our initial experience of one. And this video is from 5 years ago. And I'm happy to say that we have made some progress and now we are covering a lot of places. So that experience started in Punjab around 5 years ago. And now we have trained over 3,000 doctors, nurses, healthcare workers in India with the One SIM program. So I'm going to hand over to Arnaz to carry on with the One SIM overview.
Thanks, Atul. So I'm just going to go through a little bit of a theoretical background. Sorry about my throat. It's winter here and all the viruses, non-COVID ones are quite rampant. So apologies for my voice. So the One SIM, I'm just going to give you an overview with the educators. Again, if you recall, I come from an interprofessional background. And one of the reasons that we think this program works well is because we need multidisciplinary practice. And eventually, because eventually most women, childbirths will be happening in the presence of both midwives and doctors, it's important that they all get trained together. And I would say in this current context, we also want to think of the ASHA workers and all the other healthcare workers that contribute as well. So it's important to train them together if they're going to be working together. These are just snapshots from some of the education workshops that we've conducted in Lucknow. These are both medical and midwifery students and healthcare providers, healthcare professionals who are trained. So the learners here are obstetricians, midwives, and again, students, both undergrad and postgrad. It's important to involve the neonatal nurses and physicians as well. And as I said, the hospital and the community involvement is also equally important, especially the healthcare workers who are working at the ground level. The underpinning aspects of the workshop is, again, as I initially mentioned, is team-based learning, that if you are going to work together, you learn together as a team, which is where you can iron out some of the differences that you might have. And lots of times in our experience, we have observed, and you may have observed this as well, that as an individual, you might know what are the right things to do, but when it comes to team-based performance, there are issues that happen at the time, not a timely referral, or there are concerns where people don't involve the staff that's required, or may not have the resources, or sometimes just communication issues. So all these are best addressed through a team-based learning as well. These are some of the, this is a little quote, which means that we can teach large number of students in an engaged manner that fosters active and both small and large group discussion. So this is basically underpinning team-based learning through simulation. Talking a little bit about theoretical underpinning as well. So again, this gets to a bit more theoretical, and I do apologize, and will be very happy to explain this when there are further questions through the chat. But there is the Coles learning cycle. What it means is that there are concrete experiences where people are learning continuously on the job, and when there is new learning, it adds on to what's already old learning. So when you add on some new learning, there is some reflective observation, and you as a learner, you reflect on your experiences of what you've learned. But the learning journey doesn't end here. Again, it's a cycle. So you would then go home and sort of think about later, what does this new concept actually mean in my current context or clinical practice? And how does that, so you try to conceptualize that new learning after having reflected on it. And as a last step, what happens is that you go and experiment your new learning into your clinical practice. And again, the same cycle continues. There's also another, Bandura's social learning theory, which kind of interplays upon individual behavior, and what are the environmental factors, and what are your own personal factors, cognitive, affective, and biological events that affect your learning. So eventually, again, that's a cycle which gets influenced by the other factors as well. I'm sharing some of these slides from a very remote community. This is in Gudalur. So there is a hospital called Gudalur Adivasi Hospital, which runs essentially by the tribal. It's a tribal hospital, and they run on the concept that there's just a few handful of people who are, and that's like the whole staff in the second picture. And we conducted this workshop there. which was quite successful, but we've also translated into other settings as well in remote areas. So just going back to what simulation-based education offers, again, there is the concept of scaffolded learning. If you know the word scaffolding, it is the thing that you see on buildings that help to eventually form the building, right? So scaffolding learning means that you don't take people to the last step, you take them step by step, like a building goes through one floor after another after another. Again, sometimes you have a lot of theoretical knowledge, but we want clinicians to be able to apply their theory to practice. So we need to bridge that gap in between. And there's no better way of learning than it is by learning by actually doing it. So if you look at this triangle on the right, that if you apply that learning, or if you are performing that procedure, it would make a lot more sense. And of course, all of these concepts can be incorporated into team-based learning. Again, another snapshot of the OneSim workshop where there are a group of nurses and midwives and clinic obstetric practitioners who are practicing together. Just a little brief examples of what this OneSim workshop actually entails. So we start off something like normal labor, and then it'll go into more complexities, which include labor being obstructed, baby's shoulders getting stuck, or the neonatal resuscitation and women bleeding a lot later. These are some aspects of crisis resource management that I think are key to any team-based learning. And I think I wouldn't go through all of these in detail, but essentially some of the key points are improving communication, prioritize at the time what is more important, where do I need to put my attention now, what are the resources that we have currently at hand. And when I say resources, I don't mean just equipment. You have to think about what are the human resources, what is there, who is there in the team at the time who can contribute in the best possible way. Also important to understand what the limitations are. For example, in just that Gudalur slides that I showed, the nearest hospital is a few 100 kilometers away. Then they don't have the facility to transfer the woman within a optimum time frame. So they need to know that, and they would have to arrange for emergency cesarean or whatever they have to do, get the team involved, seniors in a reasonable time. Again, some of the key principles of learning in this situation would be learning in small groups and debriefing, because people need to, just as Dr. Vijaya said, should feel comfortable about asking questions, should feel comfortable about interacting and be able to contribute to learning from each other and with each other. There is some merit in big group discussions as well, but that's me standing there as a loner addressing this huge group. But again, that is just a one-way communication where, as Dr. Ram was saying, that the audience would listen, and while there is not much opportunity of two-way interaction. Helps, of course, if you're trying to talk, like a pre-briefing, which is common to all the group, or highlighting some important key messages. Just a brief overview of some of the papers we've published. One of them was in Journal of Midwifery that mainly talks about the simulation, that all the equipment gets packed away in a couple of compact suitcases and then travels from one place to another. Within 20 minutes, all of this is unpacked into a simulation training scenario. So it is something that is completely doable in any setting. I would want to add that it is important to retain that flexibility in education. While lots of technology-based learning, whether it's virtual reality, augmented learning, and all of these technologies are absolutely amazing, we can't forget that sometimes there is value in very simple learning tools, because the word fidelity or realism in simulation actually means that the simulation training is able to do the job. For example, if a plastic model of that baby or the uterus is able to teach what we need to learn, then one could argue what is the point of spending hundreds and thousands of dollars in expensive equipment when when this teaching needs very little equipment. And just sharing some of the key messages, which I might just skip through or go through quite briefly. Just one of the things that came out of it was supporting clinicians. These were some quotes from the midwifery participants who wanted to work with the doctors, keep instruments ready when the doctors arrive. We also noticed that there is a little bit of hierarchical healthcare network, and that exists. And we've been trained in India, and we are familiar and used to the hierarchy. But somewhere down the line, there are hidden messages, I think, that one needs to think of, like here it says work with the doctors, while there was another quote which I've deliberately omitted, which actually says obey the doctor orders. And I think somewhere down the line we need to ensure that we flatten that hierarchy and give respect to all those professionals that are involved in working together. Again, it's also important to recognize that there is a lot of administrative role and paperwork as well, especially for nurses, in recording birth details, checking instruments, paperwork for summaries, etc. And recognizing those all jobs as well are important. Documentation is really important as well in every step of healthcare management. This, again, doesn't get talked about much, but psychological preparation of the mother and interacting with the parents and, providing them both comfort and, maintaining that level of trust, building that level of trust with our clients is of importance, and something we can easily forget when we are very procedural oriented. So this, just to sort of acknowledge the key theme, of course, was learning in teams. And some of the quotes were, this is the first time our senior doctors are teaching us and learning a procedure with us in the same room. And it's important that, people who are working together get to learn together right from the undergraduate level. So in my previous slide where you see these are about 20 medical students competing with each other to examine the woman, the simulated woman. And it's important that they are taught together. We have had both medical and midwifery students learn together as part of these teaching programs. I'll just briefly touch upon this. Socio-materiality. It is a concept which, which sort of underpins that how, as social beings, we interact and learn from each other. And so that social, and the materiality part of it is the equipment that we use. So I would say that one is not sufficient for teaching. We need both. So it's this whole setup of social interaction. And what I was talking about initially, where I referred to as we don't need just expensive simulators, but what we do need is a team full of engaged facilitators and engaged participants. And so we, Tara Fenwick, who actually talked about this theory, explains this as engaging in learning in a constructive behavior that builds confidence and understanding of the materials. But that can't be done without meaningful interaction with other participants, which is both the facilitators who run the training, the teachers, and the participants. So through this, learners manipulate objects and draw observations and put that information together to make it more meaningful. Again, simulation, there's one beautiful thing about it that Dr. Ram also mentioned, is that ability to make mistakes. Doesn't matter how shy you are, or if you don't know something, no one's going to die, no patient gets hurt. So it's important that simulation doesn't cause an actual harm to the patient, even if you're performing a procedure for the first time. Again, it's good for confidence as well. For example, the second quote by the midwifery student who says, "My experience is limited, but I had to conduct an independent delivery in the hospital." So if we have simulation as a part of scaffolded learning in the background, maybe that midwifery student would feel a bit more comfortable when she has to conduct that birth by herself. Again, something that I've mentioned, but I cannot emphasize enough how important it is for equal opportunities for both medical and midwifery learning, or any other healthcare participants that we have as part of the simulation team. Because that learning will eventually translate into our culture of working together in a team where we have that mutual respect and appreciation for the roles that the other teams have. This is again a recent paper that we had where we interviewed medical and midwifery colleagues who we had taught and interacted with, and we interviewed them 1 year later. And the idea was to see how did that learning apply to their clinical practice. And what was really interesting was that some of them had stories to tell about how they worked in teams and were able to, manage patients in a much better way.
Okay, thanks, Anna. So I'm going to take you through a YouTube link next. And the idea is the pandemic basically made these borders much more stronger than they were previously. So we were teaching across borders, but the pandemic made obviously those borders so hard that we cannot obviously traverse them. But we continued our teaching and we still do continue our teaching in the pandemic. And we use this by doing the simulation online. So I'll show you an example, but in this photo, you can see this is a live simulation being shot through a smartphone, and it is stabilized using a gimbal stabilizing device. I would really ask people to invest in this if they're planning to run live simulation. But let me show you in action that video was actually capturing. So let's hope this video works now. So just give me a second. Just bear with us.
Hi, I'm Sarah. I'm going to be playing the role of the patient.
Hi, I'm going to be playing the role of the midwife.
I hope you can hear us.
I'm playing the role of the obstetric registrar.
Hi there, I'm Nisha and I'm the obstetric consultant.
Sarah, how are you going there?
Oh, I'm getting a contraction.
Sarah, I want you to push as hard as you possibly can. That's right. You're doing so well.
Why is this baby not coming?
You're doing so well, Sarah. That's it. Keep going.
Hi there, Nam. How are you going?
Good, Sarah. She's
excellent.
To push their head out. That's it, Sarah. Sarah, have you got another contraction or you're in between?
No, it's gone.
Just have a rest now and conserve your energy for the next one.
That doesn't look too promising. You know, this baby's head seemed to come out and
seems to be retracting.
Going back, seems to be retracting. I'm just going to press the emergency bell so that we get some help.
Sure, sounds good.
I'm getting a contraction. Can I push? Let's see what happens when you push. That doesn't look like it's moving, isn't it? Hi there, Shavi. Good of you to come.
I'll just
I
put
think
the
this is
legs
a
up.
shoulder dystocia.
Okay, sure.
I'm going to also get you to the edge of the bed if you can, please.
Okay.
We're just going to get you down all the way to the edge of the bed. Perfect, perfect. Sarah, you're doing so well. Sarah, we're going to get your legs all the way up so that we can help this baby out. Do you have a contraction?
Yes.
Okay, go on, push, push. No, this is definitely a shoulder dystocia. Sarah, I want you to stop pushing.
Okay.
Nan, would you please give me some suprapubic pressure just up here?
Yeah.
And I want you to put one hand over the other.
Yeah.
And go literally like you were doing CPR.
Yeah.
Now, I definitely can't get this shoulder to move at all. Do you want to give steady suprapubic pressure and see if that helps? I'm trying to get this shoulder to be disimpacted, but that isn't working. Now I'm just going to have a look. Sarah, bear with me, darling. I'm just going to have a look down here to see if I need to give you a cut so that I have more room, because this baby's shoulders are stuck, okay? I don't want you to push right now. I've given her an episiotomy and I'm just going to go in.
Is everything okay?
It's going okay.
See if I can.
Maybe shoulders are just a bit stuck, but things are going
We're
well.
doing
okay?
everything
all we
to
can
get
do.
I'm
baby
trying
out.
to move this baby's shoulders. I've got my fingers behind the anterior shoulder to see if I can push down on it. That's not working, so I'm going to use my other hand to see if I can move the posterior shoulder. That's not working either. I'm going to flip hands. Do you still have a contraction there, Sarah?
Yes.
Okay. Don't push, don't
Okay,
push,
okay,
don't push. I'm going to try doing the opposite thing. No, that's not working either. Let's see. I'm going to put my arm in, see if I can get the posterior arm out. That's it. Well done, Sarah. You're doing really
You're
well.
doing
Oh,
so
that's
well.
wonderful.
Baby slowly coming out.
Beautiful. Now you can give me a push, Sarah, if you've got a contraction.
Big push now.
Big push, big push, big push. Oh, well done, well done. Sarah, when this baby is born, I'm going to cut and clamp the cord straight away. Because
Can't we do
really,
delayed cord
not
clamping?
this time. I don't think this baby is going to be very happy with that.
Why is my baby not crying?
I'm just going to.
Okay, I hope all of you could see that. So just to reiterate that was done all using that gimbal device. I hope you realize the importance of how stable that picture was. This has been used in our online workshops. We still try to run out these workshops live. So we are not using the YouTube link, which I posted here. We generally run it live because that creates more excitement and adrenaline rush in the people delivering the workshop as well, so that they are not feeling very comfortable sitting and talking to the participants. So we find that is much more helpful. We have published on this experience in simulation and healthcare, and that was very well appreciated. And we published the experience of teaching this online interprofessional simulation in Journal of Interprofessional Care for undergraduate students as well. And we continue to have a few more papers coming out very soon on this aspect. The online workshop basically runs via Zoom or whatever facility you may use. And we start off in the pandemic by talking about the PPE use and familiarization, and then going on to the various models. And then we live broadcast the demonstration of those scenarios. And I showed you a snippet of that scenario here. When that scenario finishes, we would take them into a debrief room, and depending on the number of participants, we would break them down into groups. So we have small groups of 5, 10, 15 people, depending on what is our number attending. And then we would have an interactive chat and talk about what their learning was from there. And I'll just hand over to Arnas to talk about what those lessons are.
So just in terms of how these simulation, as Atul just said, it is all run through a live, but live, but through the camera. And so you don't, participants don't, so with participants, I'm referring to the people who are actually sitting online in front of their computer screens, while the facilitators are the ones who are acting out that scenario. So how it helps is that it's the debrief eventually, and that's got the real value. So lots of things you learn by observation, which you can't sometimes absorb when you're in the moment. And these were some of the comments that came out actually, that the learning is different. Of course, there is no substitute to hands-on learning, but as I said, there is this learning may have some merits in its own way, which you can't expect for people to pick up when they are in that, excitement or stress and managing situations themselves. So it's slightly different. It's learning by observation, but I think the key is in debriefing. So some of the lessons learned was adaptability, that connecting even while people are distanced, learning from observation. And again, sometimes facilitators would role model an ideal practice or do the exact opposite, that make lots of mistakes and use those as trigger point discussions for people to talk about. Again, participants realize what value it is for hands-on opportunity when you don't get it. But at the same time, online learning gives you that experience of a real life. We run similar workshops, again, as Atul said, in Africa and Southeast Asia as well. We haven't traveled ourselves there, but our workshop has traveled everywhere. So that's part of the whole program. This is a YouTube link where on OneSim education, and I really would appreciate if you wanted to go on the website, the onesimeducation.com for more detailed explanation of what we do.
Yes, I'm going to stop sharing, and we'd love to answer any questions or any clarifications on how this works. Thank you so much again for the opportunity to present some of our work.
Thank you so much, Dr. Atul and Dr. Arnaz. It was wonderful to see the efforts you have been putting and taking a long journey from what you have been starting at Punjab last 5 years back to what you have been doing now. Thanks for being here, first of all. And what I could learn here was that definitely what we think about simulation is big rooms without multi-crore equipments, and you just showed us how it could be done simply with some simple instruments mannequins carried in a suitcase, as small as a suitcase, and emphasizing on the fact that if a small plastic baby could do the job, we don't need actually such big costly equipments to teach things about simulation. Yeah, and definitely debriefing was one thing which is the key to success of a simulation process. And thank you for showing us that gimbal is one thing what we have to purchase now. We all have our smartphones, and with the gimbal, I think we are likely to record more things what we are doing. And yeah, what you have been emphasizing about people learning together, I think JeevaRaksha has also been doing a lot of it. We did have one session of few sessions of BCLS being taught to Rajiv Gandhi University of Health Sciences employees, which constituted right from doctors to even the sweepers who were working there. I mean, that was a range of candidates we had for each session, and that had to be taught in the same manner for all of them. And observantly, it was so heartening to see each of them learn it in a similar fashion, in the same way. And that led us to a lot of understanding about, yes, this is doable, workable, and definitely a way to go ahead. Thank you so much. We presently don't have any questions coming up on that. Would you like to yourself highlight on anything what you want to just tell which was not there in the presentation, please?
I just wanted to add that even though we've given the example of OneSim program and we want to develop this further, have more opportunities, some of these principles, as you correctly said, Rajshekhar, can be applied to other scenarios as well, because these are basic principles of learnings, whether it's simulation-based education or interprofessional learning, that are widely applicable. And yeah, just the take-home message that simulation or learning does not need to come with a huge price tag.
Yeah. And what I would say in addition to that is, whatever you see in your real life medical practice or hospital practice, I would try to simulate that. So if in your real life you have anesthetists along with your surgeons, along with the other members of staff who contribute to an activity, all those people should also be involved in simulation at the same time. It's very common for us to work in silos. And what we are trying to do is to break those silos. So one sim which runs in Monash, in our own hospital, we have one workshop actually in 3 days time. We have ED doctors, so emergency department, or the emergency room doctors, along with anesthetists also attending at the same time. And the idea is that they could be involved in childbirth as well at any stage, and there's no point leaving them out. So anyone who's involved in any particular field, any particular team, has to be part of those workshops. So that's the idea. So there are many take-home messages, but I think you've summarized most of them very well, Rajshekhar. Thank you so much.
Thank you so much for being here today and making this huge impact on us with your presentation. Thank you so much.
Thank you.
So we have concluded 3 sessions by now, and the last session for this morning timeline is in the stream 1, is by Dr. Sitaram MR. I hope he is already there in the list. Welcome, Dr. Sitaram. I would like to introduce Dr. Sitaram. He's been a part of Swami Vivekananda Youth Movement, a development organization headquartered in Sarguru, Mysore, for the past 30 years. He's an orthopedic surgeon by training, but has been all along been a public health practitioner and development activist at heart. He has envisaged and led the implementation of many grassroots level initiatives across key dimensions of community development, including health, education, socioeconomic empowerment, and training. Disability, water, sanitation, hygiene, environment, tribal development, culture, heritage, microfinance have been some of the key areas of interest and expertise. He is closely involved in Vivekananda Institute for Leadership Development, which is a SVYM venture which focuses on building capacities of people in the development sector, and the Vivekananda Institute of Indian Studies, the SVYM venture, which focuses on study, documentation, and dissemination of Indian culture, art, heritage, and spirituality. Wow, that's a huge thing. So as the executive director of VILD Foundation, a sister concern of established members of SVYM, he guides and oversees the activities aimed at comprehensive community development through the platform of self-help groups. He also is the managing trustee of Disha Foundation, a trust which engages in mobilizing communities for greater civic awareness and response citizenry. He has been an active promoter of networking and has been part of many CSO networks in sectors like WASH, disability, HIV, and tribal development. Welcome, Dr. Sitaram, sir. Big bio of yours to be read. Wonderful. We are welcoming you to just start your session and learn a lot from your session. Thank you, sir.
Thank you. Thank you, Rajshekhar, and it's great to be here. Yeah, that was quite convoluted. I do a certain amount of things, and when you write it out, it looks big. Can I start sharing my screen now?
Yes, sir, you can.
Yes, sir, you can, please.
Yeah. So, so at the outset, thank you, RGUHS and JeevaRaksha for this opportunity to share some thoughts on the pandemic and the concepts of resilience, with particular focus to rural communities. And after extremely impressive sessions about what happens in the clouds and the skies and whatnot, and such technically advanced talks about resuscitation in life-threatening emergencies, we come down to terra firma. So the next few minutes will be about far closer realities in rural India. I'll be just going through some concepts of resilience, trying to understand what it is, give a brief peep into what ground realities are in the rural areas. I'm sure a lot of it would resonate with all the participants here. I'm sure they would have experienced this as well. Then looking at what would help us build resilience in the context of a pandemic like COVID-19, and going forward, what would we do? What can we do? Like I mentioned earlier, this is going to be extremely simple, grassroots information, nothing great and nothing much more than common sense. But then after all, that is what we need. When we look at what we need to do in a difficult situation, common sense would be perhaps the best ever asset that we could have. I'll start with this image. We see a lovely tree, imposing large branches, huge trunk. But the question that we need to look at is, can it survive a storm? Whether it can or can't depends on the strength of the inner core. The inner core is weak, the branches break off, and how strong and deep are the roots. So if not strong enough, then the roots loosen up and the tree gets uprooted. Now that verily is resilience. When a catastrophe hits us, are we able to survive, stay rooted, survive, and not just survive, but thrive as well? So that is resilience, and that has been defined in multiple ways over the past many decades, starting from the 1970s to the more recent COVID-19 induced greater focus, global focus on building resilience. The best way to start would be to look at resilience as being something that helps us cope with a change and still continue to develop. Accept the change and still continue to develop. But going beyond just this limited understanding, I feel what at this point of time we need to understand is that it is actually the ability to prepare and plan for certain changes in advance, absorb situations when they hit us, recover from the upheavals that these situations impose on us, and not just stand there or stay there, move on to become successful in adapting these changes and grow. So that is what we mean by resilience. It is not just surviving, it's not just getting uprooted, and therefore it is not just an outcome. Storm hit the tree uprooted, outcome. That is not what we are looking at. We are looking at a process whereby we build inner strength, we deepen our roots and strengthen our roots, so that we stay on, survive, and still grow, and probably further enhance our enrichment as well. Globally, like I said, resilience has come into great limelight these days post-COVID, and across the international debates, resilience has often been discussed in relation to disasters, particularly the natural disasters, climate change, etc. And there are many frameworks that have been developed. The Hyogo framework for disaster resilience is one such. We have the UN strategy for disaster risk resilience. We have the UN Office for Disaster Risk Reduction, which has come up with what's called the Sendai framework for disaster risk resilience. The Sustainable Development Goal framework incorporates a lot of concepts of resilience for each of the 16 goals, and the 17th goal of partnership is basically about building resilience as I see it. So all these international frameworks do give us a lot of background on how to understand and build resilience. But primary thing is why. Now, like I said, it's not just about surviving. It's not just about limiting the number of deaths in a pandemic situation like COVID, but it is going some way beyond that. It's been shown in multiple disasters that beyond saving lives, building resilience well in advance helps us protect infrastructure, promote livelihoods, protect social systems, protect the environment, and lay the foundation for a better tomorrow. Now, that is what we need within a nation, within a community. It is also important to understand from the previous experience that talking about resilience as a collective globally can actually help us foster international relationships and partnerships as well. And therefore, it's time we talk about resilience, not just at a big global level, but also bring it down, demystify it, decentralize it to the local level as well. Trying to understand resilience was a great experience for me the past few months. This, like I was saying, this has been a journey in learning. And there are multiple evolutions that are now happening. New concepts are coming up. But the important thing, like I said, is that there are certain characteristics which define a resilient system, and we need to understand and incorporate those systems, which includes being open to change, accepting change, willingness to change, being dynamic, and promoting connectivity, staying connected with peers and with multiple people across the tiers, across stakeholders. So experimentation and learning, incorporating the learning into what we see and what we do. So these are certain important characteristics which are defined of late. And a reference book for that, for people who are interested, would be a book from by Oxford University Press, edited by Michael Unger, who further defines certain processes that define or shape resilience. So when an adversity hits us, there is already an existing system, ecosystem, and this response. And the process starts from trying to resist the change and persisting with our old habits. That would be probably the first response. But then as we move on, people recover, people adapt, and then comes transformation. Now, it's not necessary that these are sequential activities. It's also not true that these sequential activities occur uniformly across the heterogeneous communities that we have. So some people persist for longer, some people adapt faster. So this, this heterogeneity is inherent in each community. The faster we recover, the better we can adapt. The faster we adapt, the greater will be the acceptance of the new normal. And that is what we want. And that is the resilience that we would probably desire for in the current COVID pandemic as well. So trying to bring these concepts to the ground realities in our rural communities and reflecting on my experience of interacting with communities across Karnataka and probably interacting with organizations across South Asia who do the same thing. What has happened over the past year and a half? Any crisis, I feel, is like a mirror. It shows us up in our true colors. It exposes our weaknesses and lacuna. It also throws up our hidden strengths, our inner core that I was talking about. I feel every crisis is an opportunity. And like the Sendai framework of the UN Disaster Risk Management Office defines, it's an opportunity to build back better in terms of recovery, rehabilitation, as well as reconstruction. So let's look at it as an opportunity and see where we are, see how we are behaving, and see how we can do better. How have we done so far in the past year and a half? Now, it's been a mixture of good, bad, and the ugly. It's putting it glibly, but that's how it is. Both at the individual level, how am I as an individual coping with this? And how does the community as a collective coping with the situation? So there are some good things, some bad things. Individual responses have been driven by panic in most of the situation. There's fear of consequences leading to so many self-imposed restrictions, some suicides, refusal to comply with rules, refusal for vaccination and medications, and an unfortunate tendency towards non-science nonsense. This is unfortunate. That's how it is. But at the same time, there have been exemplary compliance situations. People have come forward as volunteers, come forward with donations, other forms of support, come up for some community service, and displayed exemplary leadership at the grassroots level, at an individual level. Even at the community level, we have the same situation. A lot of social, cultural, political, religious activities which seem to promote the spread, unfortunate. Swaying to misinformation campaigns, many times driven by vested interests. A lot of stigma, discrimination, attacks on caregivers. It's something that we have to hang our head in shame. Frontline workers facing discrimination. All this happen, negatives, yeah. But at the same time, we have seen communities which have responded in an exemplary way. Collective action towards compliance. We have had many villages which have put up certain rules for compliance, many gram panchayats which have come forward and said that in my gram panchayat, this is how it's going to be. Many grassroots level initiatives from the communities, a lot of recognition and gratitude as well for the caregivers. So this is how we have done over the past year and a half. And in the background of what the global community is thinking, and in the background of what I have seen in the past year and a half, I tried to put together some thoughts on what can we do from now on. So how can we look at the focus areas and to do, and as a sort of framework for that, I've just put it as ABCs of what we can do, what and the how. So I just try to share some thoughts along these lines. I thought this would be easy to remember and maybe easy to discuss as well. So the A of building resilience for me would start from the right awareness to build the right attitudes. What do we have right now out there in terms of information which gives awareness? Much of the information out there is just misinformation. We had the Google Doctor Day for the past many years. Now we have the WhatsApp University, which has come up, which has overtaken it. A lot of conspiracy theories going around, and any person who has a smartphone, is a member of at least one WhatsApp group, would probably be an expert in virtually everything about COVID-19. So that is how it currently is. And the rural realities, when we look at the attitudes that come up based on these awareness inputs, there is one extreme of it doesn't happen to me syndrome. I'm sure many of you would resonate with what I say now. There are people who would say that it just doesn't happen to me. And there's also this attitude that some events, how can you stop it? No, this is this temple fair. How can you stop the Maramma Jatre? No, you can't. Of course, it doesn't happen. The spread doesn't happen in such situations. So that certain situations which are safe are also imposed on individual functions. You know, my daughter's wedding. No, it's okay. My daughter's wedding. And then when something happens to me, God forbid, I feel that no, what I have is not very serious. It's just a virus, you know, it's not COVID. On the other end of the spectrum is the other group which says it always happens to me, the paranoids. We have a lot of them as well. So the simplest of the thing as well, you feel that, oh, okay, this is extremely serious. I'm already dead. I'm already gone. And you know, that sort of enhancing the panic that already exists. Given this variation in the awareness and attitude, if we don't strengthen the right sort of information to people and build attitudes in a positive way, in a proactive program, we are likely to continue with behavior which is non-compliant. So what does that mean? That means that when it as in COVID-19, when it happens to me, my response is different as compared to when it happens to somebody else. When it happens to me, the tendency is to shut myself, conceal, delay seeking care, incomplete and inadequate care. There's also a sense of entitlement. I am affected, so give me things free. Versus when it happens to somebody else, we have seen that there is a strong sense of stigma which comes to the prominence, ostracizing and ill-treating, which is extremely damaging emotionally, socially, and economically as well. Therefore, we have to look at why this behavior and how can we change this? What do we change? We have seen that there is a strong inclination towards traditional remedies and home remedies in the rural areas. True, there are some good things about it, but then it's also often disastrous. And we have had many situations which went out of hand, particularly in Karnataka. So we have all heard about that. There is also a certain tendency towards preferences. I want injection, you know, I want something else. So there is this tendency which is inherent right now in health-seeking behavior of the rural community. If you look at a typical rural village where somebody in the family has fallen sick, the first thing the relatives would do would be to visit that person and wish him well. This would happen even in the hospital. So we in our Sargur hospital have a big time trying to control the number of people visiting the hospital. Traditionally, past 30 years. Bring fruits, bring homemade food, that helps healing. So doing things together. So this is the mentality that exists. There's also a tendency for large gatherings, temple fairs, festivals. They're all big events. And family functions many times are village functions. Marriage, everybody participates. So this sort of a tendency is very much true, which is detrimental, all right, in a pandemic situation. But can we use this sort of inherent connectedness and characteristics to build resilience? I'm sure that's possible. And it's for us now to look at how we can harness this to make the communities resilient and stronger. So one of the ways in which we need to look at is to look at convergent multi-system approach. So wherein you look at not just the physical body, which is of course affected in COVID or whatever it is, but that is nested in a psychological system, emotional feelings system, social environment, built environment, and the natural environment. For a long time, our entire development paradigm has been too anthropocentric, and we need to question that, introspect, and look at a more holistic approach to development, making sure that we have a bio, psycho, socio, ecological model in each of the programs that we do. It's not just about health. If we are building a road, if we are building a dam, if we are introducing a new species for agriculture, we need to look at all these multiple angles before we go full hog, because that one advantage is all right, but then the disadvantages it causes are also to be taken into cognizance. Now, the most important thing, I'm sure all of you are experts in this, and there are going to be more talks about it, is the disease management itself as the D that I have. COVID-specific management, extremely challenging in the current day. It's evolving. Protocols are coming up every hour almost, given the time difference across the globe. New findings are shaping clinical protocols rapidly. But protocol or no protocol, what makes the protocol work is something that's far more basic, essential. That includes the basic infrastructure for healthcare. Do we have the right buildings? Do we have the right equipment? And human resource, do we have the right people? Putting in the right number of people with the right skills and the competencies and distributing them in the right way. So these are, again, questions for introspection. And unless we do that, it's going to be extremely difficult to even think of delivery of immediate care, let alone resilience. So we need to have right institutional systems and processes for smooth functioning. We cannot work with bottlenecks and red tapes at every step. So the supportive ecosystem for that, the policy, the governance, the empowerment process, that has to be strengthened. So we need to, we have a lot of work to do. We need to look at all these and draw out certain steps. And I'm sure there are more competent people to say this, but what to do at this point of time for disease-specific control would be, management would be to control the spread through safe behavior and vaccination, ramp up the testing for early diagnosis, appropriate triaging and appropriate escalation with a robust referral system, primary care and secondary care, so that the tertiary care is decongested. And now, again, from the point of view of resilience, having done all this, if we don't plan for the post-COVID surveillance, we're going to have multiple other issues. We had the black and the white fungus. There are other colors, maybe more things are likely to come up. So it's our responsibility to do a good program for post-COVID surveillance, preempt certain further escalation of problems, and that can be done only by good research, documentation, innovation, and continuous learning. So that brings me to the last of the ABCDEs in this what to do, that is existing illness management. So this is something that I'm very passionate about. I feel strongly about, because COVID-19 cannot be thought of, seen, or managed in isolation. Comorbidities have been shown to increase COVID-19 morbidity and mortalities enormously. So we all know that. NCDs are smoldering, diabetes continues, hypertension continues. And if we don't handle them well, in a few months from now, we're going to have a different type of crisis. Pregnancies can't be locked down, can they? No, pregnancies continue, deliveries come up, non-COVID emergencies continue. Now all the care is actually COVID-centric, so the golden hour concept has disappeared. So how do we build systems which will actually respond to the needs of non-COVID health situations as well? And at this point of time, we also have to look at hospitals being a safe place, hospitals not being centers for spread of disease, which is what happened in multiple places across the globe. So we need to strengthen the primary tier, focus on sub-district, sub-taluka level care delivery mechanisms, ensure that hospitals are safe, clinics are safe. There are multiple ways of doing it. We need to address that at the grassroots, ensure adequate supply of medicine and consumables, build trust. I think there is a strong lack of trust that comes up when we talk to people, especially in the government system. So we need to have some proactive steps in building that trust. Maybe the current program of doctors going to the village is one such excellent step, and I do hope that works well. So I then move on to how of it quickly. The next 5 letters will help me, have helped me put some thoughts together. First is the F, which is the fundamental needs, the basic needs. Unless the health determinants are not adequately addressed, resilience remains a distant dream. Water, sanitation, and hygiene, extremely essential in the current context. Hand hygiene became a big thing now because COVID spread through that. So hand hygiene, if not taught well in advance, is likely to be a difficult thing to pick up now. Basic food and nutrition, livelihoods, a great challenge for majority of the people now. Simple housing, there were situations where distancing became easier once you come out of the house. You put people in house during lockdown, distancing is lost. That was the reality in many rural areas and even in the slums in the cities. Education has taken a major beating. The socio-cultural connect has to be rebuilt. So unless all these are addressed, basic requirements are fulfilled, we're going to have a major problem on hand. At the same time, we have to realize that if we can spend enough time, resources, money, people on fulfilling these, that will bring in an inherent intrinsic resilience to whatever we do. Therefore, it is worth spending time, worth spending energies on ensuring that the fundamental needs are met well. Governance is the most basic requirement. Unfortunately, there has been a serious erosion of trust, of transparency, of governance across different sectors, misappropriation, conflicts, etc., jostling to find space in electronic media as well as print media. Unfortunately, health sector is the most visible in this whole fracas, So health sector becomes the most vulnerable to venting of frustrations of people. We have had so many unfortunate incidents of attacks on healthcare workers. So unless the entire governance structure is strengthened, we're going to have problems. That is where we build resilience. We have to address multiple issues, including accountability, transparency across different bureaucratic tiers, so that people find a responsive system and not just an opaque wall to which they complain. In this context, we also have to remember that we have to have an iron fist as well as a human face. The iron fist doesn't help if you don't have a human face. The migrant crisis is a good example in this regard. And also we need to look at contextually relevant interventions. What applies to Bangalore may not apply to my tribal colony in HD Kote. So we need to have that flexibility to the best extent possible. We have to empower and nurture a culture of empathy, support for the frontline workers who are toiling day in and day out. A lot of these issues are actually around communication, either incomplete communication or inadequate and incorrect communication to people. A lot of these attacks or fights come up because of that. So that people have to be empowered to communicate well. There has to be a team approach taking the community and the family on board, and a health plus approach taking the rest of the things as well, like I mentioned, at the time of need and at the place of need. So that is something we have to look at. And here, that means that we have to be inclusive. We have to identify who are the most needy of all beneficiaries. And we have to go beyond just the medical vulnerabilities like a diabetes or CKD or something like that, but to look at situations like poverty, geographic isolation, gender, disabilities. Now, that's something that we as an organization are working extensively now. Work-related vulnerabilities, the challenges that the sanitation workers face, the cleaners face, enormous amount of risk for them. How do we address that? And the social discrimination, caste-based and other things. It's time to remember the slogan given by the Sustainable Development Goal, the SDGs, the LNOB, or the Leave No One Behind slogan, and make it a part of our plan so that we build resilience for the future. J, the last point in my ABCs, is about joint efforts and approaches. Partnerships, extremely important, and this has to be a fundamental approach, not just for short-term gains, but long-term program implementation as well. And that partnership will flourish, exist only if it's built on mutual trust and respect. It cannot be I give, you take, I tell, you do. No, that doesn't work. So we have to build partnerships on trust and respect, build on each other's strengths and overcome each other's weaknesses. We have the government, the NGO, the voluntary sector, the private sector, the academia, the international agencies, all working center. Now, this is what is envisaged as the strategy even for SDGs. So that is the best way to build resilience as well. We need to communitize resilience. It cannot be just limited to a closed room discussion or a government office. It has to go down to the grassroots. So how can that happen? Now, my community connect and exposure has allowed me to explore and experiment with certain of these platforms that are already existent. Some of them are actually embedded in the health system. If we can strengthen them, that's the best way forward for communitizing resilience. We have the RGUHS Samitis at the PHCs. We have the VHSNCs, so the Village Health Sanitation Nutrition Committee at the grassroots. We have the sub-centers, which are now being morphed into wellness centers, a beautiful concept which will actually act as a nidus for resilient communities at the village level. So we have all these mechanisms. We need to activate them. We need to grow them, nurture them. Same time, we also have other institutions embedded in other departments, like the Rural Development Department has the Panchayat Raj institutions, a fantastic tool with its various committees, which, when empowered, can be responsive and resilient to any situation like COVID. The Department of Education has the SDMCs, or the School Development and Management Committees. And as an organization, we have worked with SDMCs for more than 20 years now. And our experience has been fantastic. The sort of icing on the cake was at the first wave. When the first wave hit us, I got a few phone calls from community, the SDMC members, who told me, sir, you guys were talking about hand washing 5 years ago. Now look at what has happened. Because you told us the importance of hand washing, we are able to adopt hand washing so easily. I felt so happy, so gratified that a behavioral change communication in a different context is helping us now. That is probably the best way of building resilience. We have social welfare department with the Anganwadi centers, other departments which often are left out, like the agriculture department, the horticulture. They all have what's called the FPOs, or the farmer production units. They have the water user collectives, the WOOCs. All these are community mechanisms which can be activated when we need community response. So that is something that we have to understand, because COVID is no longer a health issue. It's now a development issue, because it has affected virtually every dimension of life. And therefore, I feel those are the dimensions in which we need to build resilience. Like health, don't limit to physical health. Look at emotional, social, spiritual health as well. Education, primary education to higher education, everything is now gone haywire. Medical education, gone haywire. We don't have postgraduates for a year and a half now. So what do? 2 years, 3 years down the line, we won't have enough surgeons, pediatricians, orthopedicians. That's the sort of situation we are likely to face. Most important, basic needs, basic infrastructure. To be able to transport a gasping COVID-19 patient from my remote village to Sargur, I need the roads. I need a vehicle. If that is not there, I cannot do anything. So similarly, the economic stability and livelihoods. At this point of time, agrarian economy may not have taken a huge hit last year and to what we see this year, but they don't have any buffers. They don't have any alternatives. So what resilient systems can we build for livelihoods? Social structures and social values. We need to proactively build that. We have to promote that so that there is mutual respect, mutual support. All this can happen only when we have visionary leadership, excellent communication across the group of leaders, and a strong motivation to community. And backing that would have to be a good administrative setup, which would be institutional, which would have adequate institutional mechanisms. Now, there are a lot of lessons from post-COVID situations, particularly in the business world. And many of these are actually implantable to all sectors. As I went through a lot of articles, I saw a few of points which would be fitting very well with what we can strategize. That includes learning from our new experiences, documenting, sharing, learning, new partnerships, building new partnerships both within and outside the sector, new ways of internal organization, both repurposing the infrastructure, processes, and people, new ways of implementing, and faster development and agility to respond. So when we have these as our guiding principles, we will be able to do a better job. I'd like to finally look at the caregivers and resilience. I know there's a separate session in the evening. I just wanted to touch upon this. There have been many articles which have dealt with resilience in caregivers across different countries, Spain, Italy, etc. But there was an excellent article from India, and it has a Mysore connect with Dr. Satyanarayan Rao as a co-author, which looked at the healthcare personnel and the challenges they faced, and looking at healthcare professionals as the unheard voice and their unmet needs. So there were many challenges and needs that were identified, and the coping mechanisms that they were adopting to make this happen. This study also reinforces the need for ensuring the psychosocial health and the quality of life for the frontline workers themselves. So unless we build resilience in the health system, rest of the resilience will again not really be a feasible option for us. So in spite of all the negatives that have happened, I feel proud to belong to this fraternity of medical professionals, which has had a sterling response in the face of adversities. So I take this opportunity to lay before their feet the heartfelt appreciation for them. Everybody, every frontline worker has done a fantastic job so far, and hats off to them. I'd like to end with a nugget of wisdom, the Subhashitas, which talks about resilience. For me, that probably symbolizes resilience. It says, the weak run away from adversities fearing failure. The average start, but then they discontinue because they are afraid of what might happen. It's only the strong-hearted and the brave who continue despite repeated attacks. So first wave came, second wave came, come third wave, we are not going to back away. The tough get going when the going gets tough. And I'm sure the medical fraternity will live up to the challenge and make the community a safe place for the whole country and globally as well. Thank you for the opportunity again. I'm going to stop sharing now, and any questions or interactions would be welcome. Thank you.
Thank you, Dr. Sitaram, for this wonderful session. I mean, it showed how much of expertise you have been having in different fields, what you have been working, and bringing it down for us to show what are the dimensions of resilience, what we need to have for this. It was an elaborate session where we looked into all the aspects of what problem we have been facing and what is a way forward for it. Thank you. We've been running late because it's already 8 minutes past the lunch session. I'm so sorry I have to conclude this at this point. Thank you so much, sir.
Sorry,
and we'll be joining.
Very sorry, I overshot.
No, sir. We'll be coming back at 2 o'clock sharp as per what answer has been put on the chat box, that both the streams will now be clubbed into one stream, and it will continue in this stream one only after this lunch break. Okay, then we'll see you, all of you, after the lunch break at sharp 2 o'clock. Thank you.
Thank you.
Basaveshwara Medical College, Chitradurga, would like to thank our Pujya Swamiji, Dr. Shivamurthy Murugaswaran, and our Honorable Minister of Health and Family Welfare and Medical Education, Dr. K. Sudhakar, for giving us the opportunity and resources to make taluk-based emergency care happen by providing ambulances and a paramedic staff who can respond to any sort of emergencies and use of telemedicine to get an expert help at the patient side within the community itself. It has been a great honor to be chosen by our Honorable Vice Chancellor, Dr. S. Sachidananda, as a part of Rajasthan University of Health Sciences, a JeevaRaksha project, a first ever institution to roll out RGUHS-JeevaRaksha app. I would also like to thank Dr. R.K. Nayak, the CEO of RGUHS-JeevaRaksha Trust, in giving us the responsibility and an opportunity to train the community members of Chitradurga in providing basic care and life support, and making sure that they are also a part of the journey towards the excellent state of the art and emergency care of from home to the hospital. Dr. Vijay Bhaskar Reddy, with his commitment and passion and a great teaching style, has been instrumental in creating many a trainer and provider in the district of Chitradurga. We would like to remember and thank Dr. Reddy's contribution to the team BMCH, ably led by Dr. M.M. Kausar, a skill lab coordinator, and Dhanashri Sikhi, the MU coordinator, as well as our medical superintendent and the nursing superintendent and other staff members and faculty involved in the program. They have played a vital role in making this a reality. This is a dream and a project which should not have happened but for the infinite and wholehearted cooperation extended by the Deputy Commissioner of Chitradurga, the District Health Officer, and all other staff members working in healthcare and the friends of Chitradurga district. Once again, can I express what a privilege it is for the BMCH and our patients as well as the district of Chitradurga to be chosen by our Honorable Minister Dr. K. Sudhakar and all other esteemed team members of Team RGUHS-JeevaRaksha as well as the local district administration to be able to be the first district to roll out RGUHS-JeevaRaksha app. Thank you one and all.
Good morning to all the dignitaries, conference faculty, as well as dear delegates. I have been following the excellent work done by our Rajiv Gandhi University of Health Sciences in the field of emergency care education, and I'm extremely happy to be inaugurating the first ever RGUHS-JeevaRaksha Academic Conference. The state of Karnataka has always been in the forefront of providing high-quality universal health coverage to all its residents. The Arogya Karnataka was first of its kind in the country when initiated across the state. Having an efficient ambulance system and one of the best healthcare infrastructures across the country, the government is keen to see high-quality, evidence-based emergency care provided to all the citizens in the hour of need. The need for trained doctors and nurses to provide state-of-the-art emergency care has been brought to the forefront by the two peaks of COVID-19 pandemic affecting millions of patients across the nation. I am proud to note that the country's largest health university, RGUHS, along with the highly regarded NGO, Swami Vivekananda Youth Movement, came together as early as 2013 to initiate the JeevaRaksha project in association with University of Utah, USA, to fill this gap. The pioneering effort in conceptualizing the world's first comprehensive emergency care and life support training for doctors and nurses, coupled with a structural rollout of training program across the state, has already benefited hundreds of patients. The government is proud to note that the RGUHS-JeevaRaksha program have been conducted in other countries like Morocco and Kazakhstan, and widely appreciated. The emergency care modules have also been now adopted in the nationwide training programs for the PHC doctors. In view of the raging pandemic, we are having this conference in the online format. It's heartening to see the global medical community coming together to discuss and educate on the different aspects of COVID-19. I am sure the healthcare professionals and students attending this event will greatly benefit from the experience of the esteemed faculty who will be presenting updates on emergency care and disaster management throughout the day. During this session, I would also like to reveal the JeevaRaksha app to the world. This app connects common citizens to the thousands of trained JeevaRakshaks across the state and has been successfully tested in the district of Chitradurga. This will ensure much needed care during the golden hour of medical emergencies and trauma. The concerted and passionate efforts made by RGUHS and JeevaRaksha Trust will make Karnataka the leader in state-of-the-art emergency care in our nation, and I am honored to be supporting this venture. Jai Hind.
How many has logged in? Is there any way maybe?
Dr. Varun, can you hear me?
Yes, sir. Can you hear me, sir?
Good afternoon. Yes, we can hear you loud and clear. Dr. Chandrasekhar, can you hear us?
Yeah, I can hear. I think I can hear.
That's fantastic. Thank you, sir. And I've got Mr. Ravi Shankar, technical help, Mr. Bala, technical help, Dr. Rajshekhar Maitri, and Ms. Jinsi. Ms. Jinsi, are you coming in as a panelist and can you hear us? Just message, please. Thank you, Ravi. This side. Just the side. So we should be going live. If we are all not already live, then we will be going live. I think we are live. Okay, Varun, it's 2 o'clock. I think you're good to go. You can take over. Thank you so much.
Yes. Hello, everyone, and a warm afternoon for the healthcare professionals and students who are a part of this conference in emergency medicine themed Beyond Pandemic Being Prepared. As per the latest statement released by the WHO, 7 in 10 of the healthcare workers are feeling burnt out in their job. But this relentless pandemic is still marching stronger. Who else do you think is better in putting things into perspective? I would like to introduce Dr. Chandrasekhar H., Professor and Head of the Department of Psychiatry, Bangalore Medical College and Research Institute, to give his valuable insights on burnt out in frontline workers during pandemic coping strategies. He is the Secretary of World Association of Psychosocial Rehabilitation Indian Chapter and functioned as a member secretary to Karnataka State Health Authority, India. He is a well-known psychiatrist and an academician. He is in one of the treating team at the Victoria Hospital, Bangalore, which is dedicated COVID hospital as per the real norms, and has an experience in managing more than 9,000 corona cases. Sir, I would like you to take over this session.
Thank you, Dr. Varun, for a nice introduction. At the outset, I wish everyone very good afternoon, and I hope all of you had a good lunch after excellent morning sessions. And I would first I'll start my screen sharing. Is it visible, Varun, my screen?
Yes, sir. Your screen is visible. It's clear.
Okay.
Yes, sir. You can please put it on a slideshow. Thank you so much.
Yeah. I think it's quite visible. Yeah. So at the outset, I thank this organizing committee of RGUHS-JeevaRaksha Conference 2021 for organizing such a nice conference. And I thank you for giving me this opportunity to speak out my feelings during this pandemic, and of course, looking at various healthcare workers. And we treated right now, I think last month it was very hectic. Victoria Hospital has treated 12,000 patients. So to start with, I just want to show the photograph of Victoria Hospital. This was started in 1900. The building you see behind Victoria Hospital, which is a multi-storied building, this is where our COVID patients are treated. So we have had 12,000 patients. We have a lot of deaths. Thousands of doctors work day and night, and we were also able to take care of their mental health and other needs during this pandemic. So I just want to start with announcement, which you see before takeoff and before landing in every flight. Like, that's what we call a safety announcement. Please put on your own oxygen mask first before assisting others. Unfortunately, very few airline passengers use oxygen mask correctly when they are needed. So same thing is happening among healthcare workers. So during next 20 minutes, probably I am going to tell why it is happening. So objective of my presentation is what is professional burnout, prevalence of professional burnout among healthcare workers, causes, consequences, can we prevent this burnout, and what are the interventions we can certainly improve from especially this RGUHS-JeevaRaksha, what recommendation it can make. I'm trying to present during this. Right. So stress among workers. Existing healthcare systems are really stretched during this pandemic. We know maybe now last 1 week it is slightly less, but still it is very stretched. And this battle has become long drawn, almost 2 years. Healthcare workers starting from doctors, nurses, lab technicians, attenders, everyone is suffering or fighting with the war almost 2 years, and frontliners have become particularly vulnerable to mental stress. So as such, there is no clear definition, ICD-10 definition of professional burnout, but amongst many articles, they say professional burnout is characterized by loss of enthusiasm for work, feeling of cynicism, low sense of personal accomplishment. These are the main characters. In addition, it is always associated with thinking of early retirement, alcohol use, and suicidal ideation. So I just have a few slides regarding prevalence, some of the meta-analysis I went through. So this study by Scott Yates during 2019, almost just before, beginning of this pandemic, they found evidence of burnout among 42% of US out of this, 15,000 US physicians. And another important finding was 50% among them were 45 to 54-year-old. That's peak of their life, peak of the practice. So that is time where you have a burnout. And alarming 14% had reported suicidal thoughts. And surprisingly, only 1/3 of them had requested for any attention after suicidal thoughts also. And it had reduced the clinical productivity and increased physician turnover. So this is one more study. I just want to show you the slide. Maybe you can read, this is a Medscape National Physician Burnout and Suicide Report 2021. It was again around 15,000. It was through a questionnaire this report was made. And it is very interesting to find that the most burnout doctors were from the critical care, rheumatology, infectious, urology, and pulmonary medicine. And of course, even dermatology, plastic surgery, oncology were relatively less burnt out. This is a very interesting finding. And second finding, what I am trying to show here is 29% of those who have had burnout had no impact on life, 24% had moderate impact on life, and most importantly, almost 50% of them had strong and severe impact on life. So it is certainly requires some attention by us. So some of the statements I just recorded through some of the publications were, The joy of practicing medicine is gone. I hate being a healthcare worker. I can't get out. I can't tell you how defeated I feel. The feeling of being punished for delivering good care is nerve-wracking. And again, because of increased computer, I no longer a healthcare worker, but a data manager, data entry clerk and a stenographer. I became a doctor to take care of patients. I have become a typist. So another person, like, every morning I'm facing COVID-19 pandemic since 2 years. Please get off our back so that we can move forward from whatever specialty we have. So define a burned out healthcare workers. I would say healthcare workers who is having stress is like an angry, irritable, impatient, has increased absenteeism, decreased productivity, and provides a very low quality of care. This is the definition ultimately I want to make. So I have few slides regarding causes of physician burnout. So after going through various meta-analysis studies, we have had quite a good number of studies regarding physician burnout. Most important thing they found was an imbalance in the relationship between effort and reward. That means this is more important than COVID-19 or anything. Like, for example, excess bureaucracy, long working hours, lack of respect from colleagues and the staff. This appear to be very important because increased computerization of practice, insufficient compensation, and lack of clinical autonomy. So interestingly, the same study which I told before is looking at what contributes most to your burnout. Again, it shows similarly too many bureaucratic tasks was the primary cause of burnout. Then spending too many hours at work, 37%. Again, same. Lack of respect from administrators, employees, colleagues, or staff. Again, contributed number. Of course, it's number 3. And surprisingly, what I saw among healthcare workers who are quite used to stress, these are the most important thing. And surprisingly, I found stress from treating COVID-19 was only 8%, low in the M. So for healthcare workers, these things, lack of control, autonomy, increased, like this is one thing, which I saw very much in our hospital. In the Victoria Hospital, we see most of our healthcare workers absolutely no control what happens to the patient, no lack of control on system, and very difficult. There are no beds. Most of the patients are very serious. So this appear to be major. And COVID, I conclude in this that healthcare workers by and large are able to manage my patient, but other aspects are more important in causing the burnout. So this is a similar finding. Did your burnout begin before or after the start of COVID-19? This question was asked in the same survey. They found majority of them had this burnout before, and afterwards only 21%. That indicates that those people who are in a vulnerable situation are likely to have a severe burnout following stressful work. So specific challenges because of COVID-19, what I am mentioning here is worries about risk of infection to self and their families, adequacy of protection, long working hours, being in quarantine, isolation, and separation from families. These were some of the challenges because of COVID-19. What are the consequences of this burnout? So most important physical consequences which have been clearly proved in one study was the burnout will always affect the hypothalamo-pituitary axis dysregulation. This dysregulation again can cause abnormal glucose metabolism, which so many other consequences. So a person with burnout is got increased risk of coronary event. This is a physical consequences. When we look at the psychological and social consequence, so the stress can transfer itself into more persistent illness, like especially stress can become depression, anxiety disorder, or increased substance use, in turn again causing a lot of complications. And the stress consistently is linked to reduced competency at work. See, you are under stress, naturally your competency at work would come down. And you cannot apply leave, you cannot take rest. Stress faced at work from such a burnout person can worsen the mental distress. And the mental distress in turn can become a mental disorder. So this is a vicious network. Like, if you are not giving attention to burnout, it can have very bad consequences. So other results in medical errors, low quality of care, higher cost, and overall worst outcomes will happen if proper care is not given. So this study again, as I told before, like, this question was asked to the 15,000 physicians. Have you ever felt suicidal or attempted suicide? And as I reported, 14% of them have had thoughts of suicide, but 1% of them had attempted suicide. 1% of 15,000, you can feel what are the consequences of so many people attempting suicide. So this is a very bad consequence which may result because of burnout. So with these figures, I just want to talk about prevention of this burnout and of course what intervention we can make. So most important prevention we should follow is, like, every healthcare worker should have awareness about mental health and stress. If first thing is identifying your own stress. So please understand what is depression, what is anxiety disorder, what is a substance use, what is obsessive. So I think first thing is awareness about mental health. Team meeting can also be used to discuss common mental health issues, ensure clear protocol for diagnosis and treatment. So this is another thing, the management should have a protocol. If one of the healthcare workers falls ill, there should be a protocol about how he is going to be taken care of. He should not be another person in this department. Ensure good quality communication and accurate information update to all the healthcare workers, which is known to prevent burnouts. And the administrative matters, which include, we should always focus on long term, like, marathon, ensure as much training for their staff to fulfill their roles. Mix and match, like ensure that juniors with limited experience work with their senior colleagues. Ensure staff rotation from jobs of higher stress to lower stress and vice versa. That is another general measures which can reduce burnout. And I would suggest some of the individually focused interventions, like, have a good self-care, take care of your health, take care of your family, have good sleep, have good exercise, have good physical activity. If you are religious, pray. If you have got some hobby, you follow the hobbies. Then have a buddy system at your workplace. Like, if you have friendship with the colleagues of work, you can share your feeling, tell your difficulties. So buddy system is another thing which reduces burnout. Relaxation, the abdominal breathing, which is something, which is always proved to relax you during work and in between the base. Have a routine, breaks and adequate sleep is very important. Follow sleep hygiene. Don't go for alcohol, medicines to get good sleep. Keep in touch with relatives and friends so that, that will also reduce your stress. So some of the intervention, before I talk, I just feel like, most of this burnout, they stemmed out of this, what we call as triple aim, like, care, health and cause. This is Don Berwick proposed in 2008. He spoke, to improve the health of the community. All healthcare institutions and departments simultaneously pursue 3 dimensions of performance. Like, most important is improving the healthcare of the population. That means preventive, promotive, and curative aspect. As far as curative aspects is concerned, enhance the patient experience of care. Like, The minute a citizen comes to the hospital, he should be immediately given care. He should get the best quality care, and the best person should give him care. That is the like, and most importantly, reducing the per capita cost of healthcare. In fact, this triple aim is something, which really cost the healthcare workers. Some of one or two studies has said, so this is what we should look at. And so this, along with triple aim, we are looking at burnout as a system problem, not an individual disease, and must be addressed with systemic solution. And I suggest system-based intervention in addition to those targeted to affected individuals also should be given individual personal attention. And I would always recommend that we will not achieve the goals of triple aim unless we add a fourth goal, healthcare and welfare of the healthcare workers. So what we can do as far as this computerization is concerned, implement team documentation rather than allowing the doctor only to document everything. Use pre-visit planning, roles allowing nurses and medical assistant to assume responsibility of what are clinical decisions taken, standardize and synchronize workflows, co-locate teams so that physician work in the same space. These are some of the strategies known to reduce the work burden on the physicians and reduce the time spent on non-clinical tasks, because most of the people who have joined as healthcare workers want to spend more time with the clients than with the computer. Decrease the time spent on interacting with computer, EMR documentation. Meditation and mindfulness training are certainly known to work. They say mindfulness training in a way which you relax each part of the body with breathing and all, known to help you. And one reference said wholesale adoption of Buddhist philosophy is fit for healthcare workers, so that you will never undergo stress, because this philosophy will never make you under stress. And one more suggestion made in of the thing, follow Abraham Maslow's hierarchy of needs. You start with basic physical needs, then go for safety need, then mental health needs, respect, appreciation, connection, and process changes. So if you follow Maslow's principle, probably your stress you will be able to face better. And at the same time, I have seen a lot of barriers to change. Many physicians and healthcare workers feel that, seeking treatment could affect their medical license. They feel, once they take, they will become unfit. It's not a fact at all, because all psychiatric disorders are just like any medical disorder. You have a lot of protection, fear of professional consequences, limited time to seek medical care, stigma associated with treatment of is another thing. So similarly, this study also shown, why have you not sought help from burnout or depression? They said symptoms are not severe enough. 52% of them refused any intervention because, they said they can manage themselves. And 46%, they also felt the same. And 40% too busy and do not want to risk disclosure, 20%. And of course, very few said they did not trust mental health professionals. So to conclude, I would say that burnout among healthcare workers is almost half of them are burnt out. First step I would suggest is to recognize their burnout and try to alter your lifestyle. That itself will reduce the stress. And most importantly, share your difficulties. You share difficulties with friends, relatives, and especially your boss. You should always communicate about your feelings. Help is available. Break the barrier and take help. And to conclude, I always talk the last lecture from Randy Rash. He's a computer professional and he was diagnosed as pancreatic cancer. He had only 6 months to live. During that time, he gave series of lectures and in a book also, and it became very popular. It's very nice in this context. So it says people are more important than things. That is what you should realize. Decide if you are a tiger or heron. That means, even a tiger roars in the deathbed. So that's why you should be. Never underestimate the importance of having fun. Work and play well with others. live with integrity, tell the truth, apologize properly. If you wait long enough, anyone will show you their good side also. Show gratitude, don't complain, just work harder. This is a excellent suggestion, what I thought, more meaningful for healthcare workers. So he is the person, Randy Pass. I'm just telling his message only to conclude my speech is put on your own oxygen mask before assisting others. Thank you very much for the patient. Yeah, I'm ready for the questions. I just end my slideshow.
Yeah. Thank you, sir. Such a wonderful talk you have given. It was such a precise and concise information regarding one of the most challenging topics, I think, of this session. You made it very simplified and made very good efforts in this slides. And especially you're emphasizing on the triple aim, which is very important that it is including even the healthcare workers' mental state. So let's go into the questions, sir. We have a question for you. Mr. Shivaswamy, he has a question. Any data regarding the incidence of burnout in India? Because most of the data which you shown in the slides were the topics, the incidence was outside India. So any data regarding the Indian statistics?
Yeah, I think we had very few local publications, mostly about patients having stress during COVID. But only one publication showed that 15% of healthcare workers, mostly the nurses and paramedicals, had undergone stress. And one study had shown the receptionist, the person who is going to suffer more during this, especially from private sectors. And that was not a, it was a just like a letter to the editor, something like that. Of course it is quite common, but no major publication regarding this stress. That's what I identified.
Okay, thank you, sir. We have one more question, Dr. Shivangi. She has a question for you, sir. How can hospital administration help in preventing burnouts? As we all know, it's a team effort, but nobody knows, or in fact, nobody has a set protocol in the hospital how to prevent the healthcare workers from having a burnout.
No, what I would suggest, like, good training before they go in for duty, good meetings, and then try to give them, make them aware about mental illness. All those things would certainly help, which we have done planning in Victoria Hospital. It certainly helped. It made many people access the psychiatric department, and we averted many tragedies.
Sir, can you share an experience regarding a healthcare worker without naming how during this pandemic they had a burnout and how you helped them out? So it will be nice for us to know about it.
Yeah, there were many referrals. One referral, especially, we had more referrals from anesthesia, pulmonary, OB department, and all. I think one nurse also, we have had few attempted suicide also among them. One was very important. I don't like, I am being targeted. I am giving more work. My friends never help me. Like, by the time I finish my work, I'm exhausted. That's what. So what we did, we posted in a different hospital. Then she had a buddy system and she improved. So some people had a panic attack mainly because of this wearing a PP and all. What we taught was we actually trained them in relaxation techniques, breathing exercises. We sent the videos of breathing exercises in the among the groups. That also helped many people manage this PPE during this pandemic. So there were plenty of expenses.
Okay, I have one more question from Dr. Satish regarding there are now in COVID, most of the hospitals are using pre and paramedical staff. Is this the reason for them, those doctors under undue stress because they're not practice the clinical medicine as much as a clinician?
So this is one important finding in many references. Like, you have to define responsibility of each paramedical person. See, of course, doctors can be always, of course, everyone should work together and then their responsibility should be clearly fixed. They have to do their roles clearly and fix the responsibility so that, the the senior most person would be leader, would be doctor, who can use his skill more in diagnosing a condition, doing intervention. So that is something, Dr. Satya, I really appreciate this question. I think this is not happened in many of our hospitals. So I really appreciate this question. This should happen.
Okay, we have a couple of minutes left. Last minute, we'll take on the last question. Sir, we want to know, is there any way or a quick screening tool available so that healthcare workers, we can know whether we are into this burnout, or is there any easier way to find out that the person is going into a burnout?
You see, we use this PHU. So primary health questionnaire, something like that. That questionnaire was administered to all the healthcare workers in one of our studies. We were really able to identify PHU, and the second one is GHQ, general health questionnaire. If we administer to our healthcare workers, we will be able to identify them early and make some interventions.
Okay, sir. I think I have a minute. I can take one more question. Rest questions will be answered directly will be given to the email to Dr. Chandrasekhar. So how is this that most of the doctors are posted for night duties? And we all know that night duties are very stressful, can't even take some relaxation. Is it one of the cause to be very concerned about, and how to manage doctors post night duty, how to relax them, and sleep is the only thing which relaxes.
So we suggested sleep hygiene for those people. Night duty is part of our job. We are supposed to take. So what I would suggest, let them sleep 6 hours. What we use, the skill of sleep hygiene, make a nice dark room, silent, cool, dark room, and switch off their mobile, sleep during daytime for 6 hours, have a light dinner, reduce coffee and tea, and again go back for your duty. I think you will not be stressed. Night or day, both we should be able to work during COVID times like this.
Okay, sir. Thank you for your valuable inputs. I think it has made a lot of difference for our healthcare workers. I really appreciate that you've taken time and given us such a wonderful talk. Thank you, sir.
Thank you. Thank you very much. Thank you.
Okay. Yeah, thank you, sir. Moving on to the next one. Simulation modeling solves real-world problems safely and efficiently. It provides an important method of analysis which is easily verified, communicated, and understood across various disciplines. I would like Dr. Lulu Sharif Mahmood, a very well-known expertise, to give a clear insight and simplifying this complex system by demonstrating a COVID-19 case scenario, emphasizing the importance of simulation in our medical training. Dr. Lulu is a professor in anesthesiology and head of Simulation Center, Father Muller's Medical College, Mangalore. She has a master's in anesthesiology and is a certified healthcare simulation educator, advanced level from the Society of Simulation in Healthcare, SSH. She holds a fellowship in Foundation for Advancement of International Medical Education and Research to support foreign medical graduates and also help medical students in interprofessional educational and research activities. She is an active member and a senior instructor of Rajiv Gandhi University RGUHS-JeevaRaksha Emergency Care and Life Support. Ma'am, I would like you to voice over this important session of this conference.
Thank you so much, Varun. The question of the decade now. Am I audible?
Yes, ma'am, you're audible.
Yes, thank you so much, Varun. So glad to have Varun with us, who's moderating. Varun is an associate professor in emergency medicine and intensivist at KIMS Bangalore. He has an academic background in critical care medicine with a European degree in intensive care. He is also a member of the COVID task force for the COVID death audit in Bangalore, and he has very gracefully accepted our request to address any queries related to the state government protocols on COVID. So thank you so much, Varun. Now, moving on to my co-facilitators, my dear friends and international faculty, Dr. Ashoka. Yes. So you can see him waving there. Yes, thank you, Ashoka. So Ashoka is a consultant anesthesiologist and a simulation program director for the anesthesia division at National University Hospital and associate at the Center for Medical Education, National University of Singapore. Along with Naren, they are board members of Pan-Asia Society of Simulation. And he is also, he has a keen interest in postgraduate exams, simulation-based postgraduate and undergraduate education and interprofessional education also. He is also the director of for Masters in Health Profession Education for the Academy of Medicine, Singapore. And I'm really happy to collaborate with him. It's a fun team, the three of us. So thank you, Ashoka. We're happy to have you all the way from Singapore. Moving on to Naren. Naren is a United Nations consultant for simulation training centers. He's a simulation faculty, a medical educationist, and presently the director of Phase 1 Simulation Center at Taylor's University, Malaysia. He has a master's in medical education from University of Dundee and an MBA in hospital administration. Currently, he's working on cultural consideration and simulation-based education, and he has a comprehensive learning module for undergraduate medical students on usage of high-fidelity simulators. He's our go-to man for all the educational theories and simulation concepts. So I hand it over to you, Naren. And as you move to your slide, I would like to acknowledge the presence of our Honorable Minister of State, Health and Medical Education, Dr. K. Sudhakar, and our Honorable Vice Chancellor of the University, Dr. S. Sachidanand. Sir, thank you for all the support and for encouraging simulation in the state. Over to you, Naren.
Thanks, Dr. Lulu. Hello, Dr. Ashoka and Lulu. I think we are good to go. So just give me a thumbs up so that am I audible enough? So if that is the case, then we move on. I'm coming straight to the point. Now, what are we going to do in this session is what I'm going to start off with. So here we are trying to introduce some of the components of simulation which is possible within the time frame that is given, which could be a briefing, a hybrid, what kind of environment that you need, what kind of simulators that you need, what is a debriefing, basic concepts of it. Now, how can you use simulation as an added teaching learning activity to basically replicate certain scenarios which each and every medical student or any particular practitioner would want to learn? Because the environment here, when you go through a simulation, is very safe. So that is also being awarded here. So we have picked up the current talk of the town, talk of the world, which is basically a COVID patient's journey from the ward to an ICU. In fact, he is recovered as well. So you can have a look at it, and this is what you will be expecting from this session. Next, there are certain disclaimers which we would like to share. Whatever that we share within the time frame, it is not like we are an expert and we know a lot and we are here to share about simulation and the COVID. We are just sharing what we know. That's one. Second thing is, how can you use a scenario which could be COVID or any form, so that you can actually promote simulation-based education or training in your curriculum, and how can you incorporate them? And we have captured some videos, we have some PowerPoints as well simultaneously in order to show you how exactly it can be done. Now, the last one is one of the most important part, which as Dr. Lulu has said, before we begin, I would like to share some objectives. By right, we are not supposed to have quite a lot of objectives. I've just listed a few so that you know what is expected of this session, because it goes based on the video content that we have. So here, first and foremost, we wanted somebody who the participants need to recognize asymptomatic COVID patients progressing to respiratory failure. Second, we want them to do what they have to do, which is escalating the patient to the next level. Then, most importantly, when you do such things, the relatives also need to be brought into play, which is called as informed shared or decision making. And when you hand over a case to any particular person, we follow the ISBAR concept. Next one is, while in the IC, whatever guidelines that you have, wherever you are, whichever assessment that you are trying to make, you need to follow a certain set of guidelines which is given to you, basically they have gone through some goods and the bads and they have formulated something. So it is well to appreciate that. Next, when you plan for a discharge, there could be a guidelines again. So bring back the guidelines. And throughout the whole process of the simulation, how effective are you going to communicate throughout the whole thing matters most actually in all simulation sessions. Now, what do we do? What are we having for you at this point in time? We are not in a simulation center. We are all remotely placed miles apart. So what do we have is we have a set of video clips. We have 3 main video clips for you, plus a PowerPoint presentations. And these video clips are basically, one of it to begin with will be the pre-brief. Then we will stop that video stops. Then we play the second video, which is actually the scenario, which is basically what you can watch. And after which comes the debriefing part. So these are the main videos for y'all to appreciate what is happening in the video where people are talking. If you want to get to hear what they have to speak very clearly, I would recommend basically you can use a earphone or a headphone for y'all so that you can clearly hear what they're trying to say. Why am I saying that is people are dressed in PPE and they were not that kind of an audible probably for some. So I wish that you people grab your headphones or earphones and you can hear them better. So while you grab, now let me go back to the video for you all to play with. And is it audible? Just give me a thumbs, or somebody can unmute and say whether it is audible. Audible loud and clear. Okay,
Yes, it's
so
audible.
I'm going to play the video from the beginning. There you go, ladies and gentlemen.
Good afternoon. Hi. You are busy today? COVID duties or online classes? Online classes. Oh, online classes. Yeah, okay. So thanks for coming today. Why we are here is because, university sent a circular that, we need to be prepared for the third wave. So they want all the non-clinical and non-critical care doctors and nurses, and mainly our faculty only, to be more competent and confident in recognizing, moderate to severe COVID cases and managing appropriately, even learning the intubation skills and, connecting to ventilators. So with that in mind, they have asked us to conduct trainings. So we thought, okay, we'll use simulation as a modality and, try to make you all a little more confident in handling those cases. How many of you all have participated or heard about simulation before? Okay, Dimpy has. Once participated. Okay, well, my first time. Okay, Prajwal first time. Okay. So what is our plan is, like I will give you the case scenario. Okay, I will give you all the roles. Now, both of you all will be ICU doctor and nurse. You can be in your own role, and you all can be the ward doctor and ward nurse. And once I give you the scenario, you all will be immersed in that scenario. You perform to your best of the capability on whatever basic training is happening in our hospital. So whatever the guidelines are there. You can always have a look at it. And once you'll perform, we will come back here and we will do a debrief. And we'll just try to see, what are the gaps where we need to concentrate on in, further trainings required for you all. So is the process clear on what we are planning to do for the day? Yes. Okay. So now regarding, I know all of you are faculty, teachers. So I want you all to be comfortable. So we have whatever you all perform, we are not targeting any of you all. It's more on your what actions or tasks you're doing, which we want to improve. So we need to follow the ground rules of maintaining confidentiality, with mutual respect. And we have an interprofessional crowd here, like nurses and doctors sitting here. So we have a consent for confidentiality agreement as well as consent to video. So we will be recording the session for further trainings and debriefing. If you are comfortable, please do sign the confidentiality. What happens here stays here. It won't be used to target you all in any way. So that is one. Another thing I wanted to tell you is we'll try to make the scenario as real as possible, but you all need to think that it is a real scenario. The simulator is a real patient, so that you can give your best performance. So you need to actually have some fictional contract. We both will have that. Suspend your disbelief that it's a mannequin. So then we will be able to perform. I will definitely take you into the room and orient you to the mannequin and the equipment, and you all are clear with your roles. So as you would do in the hospital, please perform.
Now, the modalities I'm using here is for the initial scene, I will be the simulated participant as a patient, and you can do all non-invasive procedures or may check my BP or conduct oxygen and all that. And you can speak to me. If any non-invasive invasive procedures are required, we will be using the simulator. And if there's any response from the simulator that you're not getting, like when you auscultate or whatever, you voice it out loud, and from the control room, I will give you the response. So just to make you comfortable. And as the scenario unfolds, I will keep you all updated on when the scenario is changing. We can go accordingly. So the main goal of this session is recognition of a COVID patient who is critically ill and how you'll manage it. I will also look into a little bit of your teamwork and communication skills. And we have one of our confederates who will be participating as the simulated bystander. So she will be available, and you will have to, in case you need to talk to her, she will come. Okay? So are you all comfortable? Yes. Any queries, any questions? No. Okay, so we'll go and see the equipment. Okay.
There ends the first video, and currently I'm going to play the second video, which is basically the scenario as such. Again, I repeat, it is the scenario. The participants have been briefed and pre-briefed, and now they are going into the scenario, and the video clip is going live now. Before I go, is it audible?
Sister, I can't breathe, sister. Katija, I have started the oxygen. You take a deep breather, so you will be all right, okay? You take deep breath, Katija. No, I put oxygen now. It is increased oxygen. Okay. You can't. Yes, ma'am. Yes, ma'am. What happened? Ma'am, Katija's SpO2 is dropping. It is 83. So I started now with the accelerometer. Now it is oxygen is increased. Okay, fine. What was the SpO2? SpO2 is 83, ma'am. 83. What about the investigation? That investigation 2 days back it is sent. I thought now after you giving orders only we will send it. Katija, take a deep breath, Katija. I'll be okay, my sister. Yeah, you will be okay, Katija. Don't worry. I can't breathe. Sister, you start with enoxaparin and inhaled. Okay. I write the orders. Okay. And just call the ICU. Okay. And see if beds are available. Okay. And inform the patient party. Okay. Let other things go as it is. Okay. And just call the ICU and inform the patient. Okay, nice. Katija, patient party. Katija, patient party, amma. ಹೌದು. ಕತಿಜರಿಗೆ ಸ್ವಲ್ಪ ಉಸಿರಾಟದ ತೊಂದರೆ ಕಾಣ್ತಾ ಉಂಟು. ಈಗ ಕೂಡ ಸರಿ ಇದ್ದಾರೆ ಅಮ್ಮ. ಸ್ವಲ್ಪ ಉಸಿರಾಟದ ತೊಂದರೆ ಕಾಣ್ತಾ ಉಂಟು. ಒಂದು ವೇಳೆ ಜಾಸ್ತಿ ದಮ್ಮು ಕಟ್ಟಿದ್ರೆ ಅವರಿಗೆ ಏನಾದ್ರೂ ಐಸಿಗೆ ಶಿಫ್ಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಬೀಳ್ಬಹುದು. ಒಂದು ವೇಳೆ ಐಸಿಗೆ ಶಿಫ್ಟ್ ಮಾಡಿದ್ರೆ ಅಲ್ಲಿ ವೆಂಟಿಲೇಟರ್ ಎಲ್ಲ ಬೇಕಾದ್ರೆ
ಮಾತಾಡಿದ್ರು ಒಳ್ಳೆದಾಗಿ ಚೆನ್ನಾಗಿ ಮಾತಾಡಿದ್ರು.
ಇಲ್ಲಮ್ಮ ಈಗ ಕೂಡ ಮಾತಾಡ್ತಾರೆ ಸರಿ ಇದ್ದಾರೆ. ಅದು ಸ್ವಲ್ಪ ಉಸಿರಾಟದ ತೊಂದರೆ ಹುಷಾರಿದ್ದಾರೆ. ಅದು ಸ್ವಲ್ಪ ಉಸಿರಾಟದ ತೊಂದರೆ ಕಾಣ್ತಾ ಉಂಟು. ಇಲ್ಲಿ ಯಾರು ಜಾಸ್ತಿ ಆದ್ರೆ ಐಸಿಯುಗೆ ಶಿಫ್ಟ್ ಮಾಡ್ಬೇಕಾಗ್ತದೆ. ಮತ್ತೆ ಅಲ್ಲಿ ವೆಂಟಿಲೇಟರ್ ಎಲ್ಲ ಬೇಕಾದ್ರೆ ನಿಮ್ದು ಸಿಗ್ನೇಚರ್ ಎಲ್ಲ ಬೇಕಾಗ್ತದೆ.
ನಿಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಆಕ್ಸಿಜನ್ ಎಲ್ಲ ಉಂಟಲ್ಲ?
ಆಕ್ಸಿಜನ್ ಈಗ ಆಕ್ಸಿಜನ್ ಹೋಗ್ತಾ ಉಂಟು. ಹಾಗೆ ನೀವು ಇಲ್ಲಿಯೇ ಕೂತೀರಿ. ಒಂದು
ನೀವೆಲ್ಲ ಹೇಳ್ತೀರಾ ಆಕ್ಸಿಜನ್ ಇಲ್ಲ ಮತ್ತೆ ಬೇರೆ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ನೋಡಿ ಹುಡುಕಾಡ್ಲಿಕ್ಕೆ ಅದೆಲ್ಲ ನಿಮಗೆ ಟ್ರಸ್ಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗುದಿಲ್ಲ. ನಮ್ಗೆ ಉಂಟಲ್ಲ ಎಲ್ಲ
ಆಕ್ಸಿಜನ್ ಉಂಟಮ್ಮ. ನಾವು ಐಸಿಯುಗೆ ಶಿಫ್ಟ್ ಮಾಡಬಹುದು.
ಚೆನ್ನಾಗಿ ನೋಡಿ ನನ್ನ ತನಗೆ
ಸಿಗ್ನೇಚರ್ ಬೇಕು. ಇಲ್ಲಿಯೇ ಕೂತೀರಿ ಆಯ್ತಾ?
ಓಕೆ, ನಾನು ಅಪ್ಪನಿಗೆ ಹೇಳ್ತೇನೆ.
Ma'am, I called to ICU. Morning, beds were not free. Now one bed with the ventilator is free. They told we can shift the Katija. Okay, fine. Ma'am, I spoke with patient party. Patient party is ready for shifting, but patient party looks like very violent, ma'am. You need to be little careful. Okay, the patient party looks violent. Call MS and ask him to activate the crisis management and ask him to give little more security. Let him what is the condition here and shift the patient to ICU. Okay. Okay. Ma'am, we are going to receive a patient. We are going to shift Miss Khadija from the ward. I received the call. Now the patient will arrive. Looks like the patient needs intubation. As soon as the patient comes, I'll let you know. You will be here, no?
Yes. In the meantime, keep the ventilator and the intubation set ready.
Okay. Yes. Yes, ma'am. Khadija. How are you, Khadija? Are you okay? Are you okay?
Doctor, ಏನಾದರೂ ಮಾಡಿ.
Okay, ಮಾಡ್ತೇವೆ. Yes, well, this is Mrs. Khadija. Just now doctor is taken her own tour. Okay. And told us that all the investigation we are not shifting to ICU. Okay. Told to start the medication.
the file? Yes. Let's maintain the patient at a deep of 10 centimeters of water. Okay. Continuous keeping monitoring window. And let's keep the FiO2 at 100. Okay. So that let's see the saturation. Yes. And once the ATP report comes, then we will titrate. Okay. Let's maintain tidal volume at 8 to 10 ml per kg. Okay. Now what else we need to do? Continuously monitor the BP, heart rate, SpO2. Okay. Then daily we need to see the ECG. Okay. And every 2 days do the D-dimer. Okay. And also let's do a chest X. Okay. Right? Yes. Ma'am, the BP. Give me the date, sister. Yes. Secure the BP seems to be dropping now, ma'am. It's 70 systolic. Oh, is it? I think that the patient is going into multi-organ failure. Okay, ma'am. So let's continue monitoring the BP. Okay. And in the meantime, I will inform the physician. Yes.
Ma'am, this is about Khadija patient.
Jyoti. How is she doing?
She's fine, ma'am. Today is day 4 and she seems to be improving. Her FiO2 is also minimal.
Okay.
She's maintaining saturation.
Okay. Then I think we can prepare for extubation.
Okay.
Okay. So check if the patient party is outside.
Okay.
Sister, I think. Okay. So inform them that she is doing well, but don't give a guarded prognosis. Okay. And also don't go alone. Take someone along with you when you are informing the patient.
Yes, sure.
Okay.
Yes. Thank you.
So there ends the second video. Now, before I take you into the third video, let me just speak one word about 1 or 2 sentences about the second video, which is basically it had 5 different frames. Initially, it was a COVID ward. Then it was escalated to wherein before escalation, where it was a attender being updated about the status of the patient. Number 3, handing over to the ICU. Number 4, activity within the ICU, and the last is the recovery phase. So about 5 phases comprises what you saw in this video. I'm going to the third video, which is the debriefing, in which you get to watch what had happened, and it'll be Dr. Ashoka and myself who will be going through the whole scenario with the participants. There you go, ladies and gentlemen.
Starting with the debrief session, we have our facilitators, Dr. Ashoka and Dr. Naren with us, along with our participants. So over to the facilitator, Dr. Ashoka.
All right, so good evening. Thanks for joining from every part of India. And yes, it's a virtual event. And today we are here to discuss how the scenario went, what we could use to learn in terms of how we use this for a teaching, how we use this for learning the concepts of an acute care management as it moves between frames, and also probably some other elements that we have. So to have a round of introductions from the scene that we had, let's clarify each other's role in there. So while the names on the boxes that you see might be different, we are going to identify them as people. So let's have the hand of Vilma, who was the Yeah, correct. Thank you. So she was the ward nurse in the scenario, the first interaction, correct? And who spoke to the ward doctor, Dimpy. Yes, so that's the image. You could use your tele eyes to zoom on her. And then, so she was the ward doctor. And so they had the first frame of discussion. And the scene moved to the part where Dimpy, the doctor, felt the details have to be communicated to the patient. And so after the initial discussions, the plan is that it moves to the next round of the scene where we have the ICU nurse, Jyoti. That's right. So it says Mrs. Sandra Jyoti, which is actually our ICU nurse, Jyoti, who makes the initial discussions and the collaboration of the plans with the ICU doctor who takes charge. That'll be Prajwa. That's great. Thank you. So the two physicians are in that room, and the two nursing teams, after the situation is managed, they are back in the other screens there. So that's usually the case, right? Only when there are complaints, they will be in the front row to receive it. Okay. So yes. So let's possibly, let me also introduce Dr. Naren, who my co-facilitator. Yes. So he looks at educational perspectives, he's a simulation director. He conducts sessions where does it reach the outcomes is how he looks at. My background is in acute care, which is anesthesia and simulation. And we'll look at certain aspects of the scenario itself. Okay, let's go to the first frame where we had Wilma, our ward nurse there, and Dimpy, our ward physician. They were having a discussion. So at that point in frame, so we had a patient in prone position. The patient was wincing. Thank you, Dr. Lulu, for being the patient. That actually helped us to know that there was somebody who was breathless, and there were some discussions. So can we hear from Wilma, the first responder? What made you think that you needed to call the ward doctor Dimpy to be in the scene?
The patient got admitted 4 days before. During admission, she was all right. She was even though COVID positive, there was no much signs and symptoms in her. Breathlessness was not present. Every 2 days, we send the investigation. Even the investigations were normal, just 2 days prior. But when I was checking the SpO2 to the patient, every 4th hourly we check in the ward. So when I was checking, it was 83. Then I asked the patient was looking a little breathless. Then I asked her, she said that she's finding difficult to breathe. So meantime, I put her into the prone position. I thought she was in the nasal prone, so that may not be enough because since morning she was a little breathless. So I started oxygen with the nasal prones. So I felt it is not enough. So I put her in the non-breather mask.
Excellent. I think, yeah. So you were indicating that there was a plan on your end, which is part of the protocol, and how you see that when patients have COVID positiveness and then the symptoms were changing, especially saturation when it is being monitored, we have the way of enhancing their lung oxygenation and function by turning them prone, as long as they are comfortable and communicating. So you indicated that there is a point that this patient may not be able to put on with just a nasal prong. And your thoughts are from that point on, you want to choose a higher level of oxygen providing device. So how do you go about that as a decision? You don't need a physician usually for that. You manage it yourself, correct?
Yeah, I manage it myself, but I inform the physician later. Once I started, I informed the physician.
Correct. Yeah, so you're the first responder and you are able to review and report, but assess and co-manage. Like as you are managing it, then the physician gets a cue, basically to keep them informed that this patient might go south, right?
Yes.
Right. Okay, so at what point do you think there was a need to call Dr. Dimpy from the ward to actually get to be reviewed or updated?
Because SpO2 was less. Usually in the COVID patient, when the SpO2 goes beyond, below 90, we have to inform the physician because patient might go for a respiratory attack for any time. So I felt it like patient was not that good, like how he was before when they admitted. Looking so, yeah. So I felt like I informed the doctor. So if there is any further orders, I can then carry on.
Yeah, thank you, Ilma. So at this point, Dr. Dimpy, so when the information was coming in, what was running through your mind or what was the scene presented to you at that point?
The patient was sinking, the patient was going bad. So I thought take a look and decide on whether the patient needs to go to to be shifted to ICU. That was going on in my mind when I went there, and when I saw what Sister Vilma had done, she had put the patient in the position and changed it to the mask. Still, the saturation was not maintaining, and the patient was breathless. Even the BP was 100, so even the BP was 120 earlier, had become 100. And so I decided that the patient might
okay, let's take the audio.
I might need ICU care. I decided
Thank you. I think that's pretty much what we would be expecting anytime, especially when, during COVID times, we get lots of physicians and practitioners who are out of the acute care context to all be recruited in. And we are having a basic level of clear thought that, okay, here are the red flags. If these happen, we would be attending to it. If they go anything worse than this, we are now going to mobilize for them to get to an area of care where there is higher level of facility. So that was great. The fact that oxygenation is falling, is usually going to spiral something after that. There was an understanding that blood pressure does change. So most of the times we see these three big pictures: oxygen changing with normal blood pressure, oxygen changing with low blood pressure, oxygen changing with actually high blood pressure. So these big patterns, at least if like what you did rightly from the ward, Dr. Dimpy, you thought that, okay, let's keep our ICU or high dependency colleagues informed. There might be a way we have to take it from there. So that was, thank you, scene one. So from that point on, so this information is being relayed to the next level, but there is a patient communication which you thought we should make. So can we hear from the respondent who went to the patient relative, and can you describe us the conversation? It was very interesting for us to watch, and we could imagine in every way it could go. Yeah, can you just tell us about it? Thank you.
Dr. Dimpy told me we can shift the patient to ICU. There is a need to shift to ICU. So she asked me to inform the patient party. So I went to call the patient party because patient sister was out from the morning. So when I called, patient party was outside. I just explained what is the patient condition. She is little breathless. When she was admitted, she wasn't. So there may be a need of shifting a ICU. So in case if we are shifting to ICU, then patient party, that is the sister was out, her signature might be needed. So I told her, you be in and around, because if at all we are shifting to ICU, then I'll inform you and your signature is needed. But when I informed her, her response got changed. She became a little violent. She was just her voice raised, and it was looking like threatening me. She was asking if the oxygen is there or not in the hospital. If not, I'll take somewhere, like that it was. So I came back and I informed to the doctor. I felt like anytime, they can threaten to the doctor or the nurses over there. So I felt like to inform the doctor. Then I came back and informed one doctor.
That's great. I think you identified some parts there. And on your end, I mean, Dr. Naren can come in anytime soon to provide his input.
Thank you very much, Dr. Ashoka. Good job. Thank you very much. We'll go back to the first scene again. I would like to rewind a little backwards so that I saw something that was very important, which was kind of improves the patient outcome at the end of the day. I saw the patient lying down in a prone position who's breathless, but I see you approach Dr. Nurse. I think it was Nurse Wilma who was approaching the patient, and kind of you were sharing something. Can you take us through about that particular component and tell us the significance of it? Something about what exactly went through your mind, what was the reason behind it?
Patient in the morning, she had a little breathless. So I had started her the oxygen with the nasal drops. Morning doctors came for the rounds. Patient was all right. Then immediately patient started every 4 hours when I checked the SpO2 in the ward. So after 4 hours, SpO2 was dropped. It was 83% for the room temperature. This one. Then I felt that 83 is not normal, because even when I spoke to the patient was very breathless and she was so scared. So she was only asking that I can't breathe. So then I thought I'll put her to the prone position. I started the oxygen with the eye flow. Then I informed the doctor, because anything when we start something to save the patient life, I thought I can start it and then I have to inform doctor, because if there is any further orders, I can do that and I can help the patient to improve the condition.
That interaction was good. Second interaction which I saw was with the patient directly. So you just bent down, whispered something into the ear. I think probably it was not that much audible about it, because that is kind of, I will use the word I felt. Correct me if I'm wrong, because I'm just a person who's visualizing from the outside. Was that something like a reassurance or something?
Yes, she was comforting the patient, telling the patient that don't worry, it will be all fine, you'll be better. Okay. Not worry. She was comforting the patient.
Okay, how with respect to your work system currently that you're all in right now, does that mean much to a patient?
Patient will not feel that I'm alone. Somebody is there with me, because COVID time, the patient will be always alone in the ward. I mean, even in the ward setting, there won't be any relatives or patient bystanders. So they will be out. So patient feel that somebody is there with me. I can express something, or at least someone is observing me, monitoring me. So somebody is helping me out to get well soon.
Okay. Thank you very much. That was the first clip. Second, one more clip, probably I will take another 2 minutes of your time, in which Dr. Dimpy was saying that you need to convey this to the attenders, and the information was given to Nurse Wilma. So Nurse Wilma approached the attender and they had a discussion. So this particular process of informing the patient attenders, can you take us through with respect to your protocols in your hospital or current practices in the hospital and its significance again?
Whenever patient's condition is deteriorating, before we shift to ICU, we inform the patient party so that patient party is prepared. All of a sudden, when we are shifting the patient to ICU, patient bystander will not be in the panic condition if you tell well in advance the patient condition to the patient party. So when I informed the doctor told me it is better to inform the patient bystanders and keep, because in case if we are shifting the patient to ICU, meantime they'll be ready and we can take the signature, so that if there is any further clarification from the patient party, we can do that, because there will be a time gap. Information to shift.
Right. Thank you very much for that. The last one is the good thing that happened after that is you sent something while you described to the attenders. You came back and you alerted the doctor saying that the patient attenders were not happy. That kind of a thing is kind of, you're closing the loop actually. You have taken the information across, you brought back and informed the doctor that it has been communicated, but you brought a valid information with the current scenario that is happening where doctors are being kind of, I wouldn't use the word anything, I leave it ... So in order to avoid such kind of negative things happening. So it was nice on your part. Thank you very much. Back to you, Dr. Ashoka.
So how do you feel when a physician is asking you to make this conversation and you're stuck between the two? So how do you manage this in real life actually?
To real life to manage, I did not find so much difficult because I had worked in the wards and then I knew like I was in casualty and all. But now what happened is this situation is entirely changed. Patient or the patient, the bystanders are very aggressive because they will be informing everyone and then coming to the hospital. So it is little dangerous sometimes. So instead of going one person to inform the patient bystanders, always it is better that one male at least at the bystander next to the nurse or to the doctor, because always we need to prevent ourselves from the assaults.
Correct. So I think it may not be the context of today's workshop, but I would only say when you are informing, make sure the door exit is behind you and you are not at the corner of the room asking yourself to be cornered. So it's just that you can say there is an emergency to run and then you have to run. So you can go and save 1,000 more people while they want to do what they want to do to care for you, for the relative. Right. So that is great. There is we are looking at how this concept can be transcribed into safe communications. So let's move to the scene where we now have Dr. Jyoti from the nursing team who meets Dr. Prajwal. Okay, so can you explain to us, Jyoti, how were you then when you saw the scene and what was going through in your mind?
To tell what was going in the mind, being an ICU nurse, we when a patient is coming, you anticipate that the patient will be in a bad state and you have to be ready to intubate the patient. But before setting the bed and all that, like to inform the doctor and to be ready with all the equipment so that as soon as a patient is coming, we are ready with what we are supposed to do in the ICU. That was the first thing when the information came that the patient would be shifted. Then going to the doctor and informing regarding the patient, it was like any other day when you are supposed to anticipate that the patient will need a ventilator, keep everything ready, like be on your toes. That's all was the thought that I had.
Excellent. And so at that point, when was the physician engaged and what information were you able to provide to the physician in that scene?
Yes, I was informed that the patient's saturation is deteriorating and the patient is already on high flow nasal oxygen, so non-rebreather. So the thought was that if the patient is deteriorating with saturation and the BP was dropping, so that was the indicator that the patient will need on ventilator. So this was the only information I got and I had to give it to the doctor.
Excellent. So in that scene, maybe we can ask Dr. Prajwal, so what information were you receiving from the ward team and your first responders around you? And how did you go about the scene? Yeah, we also need a little translation from what was happening there. mainly because we have the PPE and the big hoods. So this was something we figured out last year when we had outbreak here in Singapore, is nobody hears anything. So then, and then, so phones are kept outside. So we had to figure out audio equipment, and it was quite a hassle at that time. So we could hear. We also heard the music of ICU, where you have the alarms ringing. Yes, transcribe that for us, please.
So the ICU nurse got the information from the ward nurse that the patient would be shifted to the ICU with the requirement stating that her oxygen saturation was deteriorating and also her blood pressure was falling at the same time. Okay. So the decision was, yes, she is a COVID positive patient and we would need to take the precautions and get ready for the intubation and also set up the ventilator when we accept. Right. That is what I communicated to the nurse in order to get the nurse to keep all the equipment ready.
Excellent. I think you just straight away put all things in perspective, where you're talking about preparing for the chaos, which would be respiratory support, having the equipment, identifying that this is a COVID positive patient with that threat of everybody being infected. So there's so much going on, and you rightly pointed out that this time it's not just the saturation, it's also the blood pressure falling. So that takes you into a few areas of even COVID itself. So initially when you saw that, I do see that you want to take control of the airway, and then there is hemodynamics, and then probably there is more to it. So when it comes to the airway itself, you were preparing to intubate, and we gave a very tough, hard mannequin with the face and the scope cannot go in. That was deliberate for you. So that was Dr. Lulu's way of pulling your legs. So eventually when you are trying to get the patient to have a tube and oxygenation, what was running through your mind? Because normally, even when you are an intensivist in the room, it is quite a hassle. And for me, like there are 4 intubations today. Every intubation is different, and we always have this worry, what if we cannot see something? And when we now recruit faculty from all parts of practice, and we get them to be part-time ICU training or full-time ICU training, there's so much anxiety which you must be going through. So how are you feeling when you were put on that spot to intubate?
Yes, thing is, I was very anxious. Like I have to, first of all, in terms of COVID patient coming in, I would be exposed, one thing, and then the procedure of doing an intubation in a patient is always makes an individual very anxious. Whether I would be able to get the tube in a first shot, because otherwise it is extra. I'm inducing trauma again to the patient.
Yeah, definitely. And when you mentioned that, can we hear from the ICU nurse, Jyoti? I think the ICU nurses many a times seem to work in and around the ICU, but you get physicians coming on and off. So Jyoti, you might have had some plans, and then you have a physician trying to intubate. So what goes on in your mind, and how do you speak up at that point?
Yes, asking to keep ready all the equipments is easy. You know that you have kept everything ready, but suddenly, you know, it's a COVID patient, and then the doctor tells you, you need to go out, make sure everything is set and you have to go out. Then you are in a state of, you do not know whether you have kept everything ready or not, or is it something she would need in between? Like, no, that state is very difficult to express. Like, you don't know whether you have done it and when she'll call you, where you have to wait. And then such.
Yeah. So it's like leaving a child in a primary school when you don't know.
True. Whether you have kept everything set is what you are worried about.
Yeah. There is an onus of managing it, especially now, I do feel that absence of nobody, a very difficult thing. So normally we are in an OT setup, not in the ICU setting. There is a scrub nurse, there is a surgeon, there's an OT attendant, and there are enough people around me. Now, all of a sudden, we are just 2 people, the assisting person and myself. And that's very eerie because nobody is there to help is one, and suddenly there's absence of this. Yes, it's difficult. Now, going back to the technical part of the scene itself, when the oxygenation falls, we want to take access of the airway. We do know one is intubation and securing, but there are times where you want to get the oxygen pumping into the lungs and fill up to have a reserve before we want to try technically. So if I can ask Jyoti there, does it come to your conscious thought that you want to oxygenate and bring the number up, or you want to allow the physician to intubate? Just a question.
Yeah, normally I would, like as an ICU nurse, I would start start ambuing or do something non-invasive because it is easier to manage a patient that way. But when it is COVID, you know that we are also, I'm also scared and thought that, okay, it is COVID positive. So such thoughts come to your mind. So intubating a patient would be much better and safer for me than not doing so.
Correct. So one of the points I was highlighting here is our classical learning of how we stabilize airway is all gone in the wind in the last 1 year. So now at the earliest we put the tube and then we seal the lung so that it doesn't escape. Everything is kept tight. You know, the physiotherapy and how you bumble the chest to get that secretion, everybody runs away first. And I agree that because that part of it is within the first 2 meters, it is going to be a concern when we are exposed. The longer we pump the positive pressure air into the lung, which leaks around, is a lot more exposure. It is known it can go up to 6 meters. When we talk about non-invasive ventilation, which was quite a practice before, in saving time before they became too sick, is actually debatable in many parts. How do we go into the templates of management? So let's say this patient is also having a low blood pressure while we are sorting out the airway. Dr. Prajwal, when you are intubating, we are focused on the task. So how do you think the patient as a whole, you would want anybody to manage while you are in the scene there? Because you are focused on the airway, and there's Jyoti with you, but would you have preferred if there's anybody by divine intervention can come in to do help more with what you wanted?
Yeah, I would really prefer if somebody else was also there at the same time. But then the situation is such that we are short-staffed and short-numbered.
Yeah.
Makes things a lot difficult.
Making a lot difficult. Okay. So, Dr. Naren, you have any thoughts or inputs at this point?
No, not at this moment. Thank you very much, Dr. Ashoka. Please.
Okay. Right. So, we could go on to discuss further into how the communications happen between the 4 scenes, which is the ward, the disclosure to the patient, the response that there is an angry mob waiting out there, and we better do what we have to do. To me, actually, that adds more stress. If you don't even say that, they might actually do better. But so from there, the scene moves to an acute care area. We don't always have all the professionals who have to do the acute care. And there is a trained ICU nurse, and she's also having to move between rooms and not always be there. There's an anxiety whether we're going to manage the situation the right way that we want. So let's say this scenario goes to the next, which we can mime through the discussion, that the blood pressure goes to like 40 or 60, and then there's a ECG showing a change, which I think Jyoti is noticing, but Dr. Prajwal is busy intubating. How do you go about, Jyoti?
You know that the airway is being maintained. So once the airway is maintained and you know that blood pressure is dropping, the first thing is that to inform the doctor so that we give some fluids, or we try to do something at that moment. Maybe the fluid resuscitation would be the first thought that would come to my mind to start with. Then to make sure that the doctor also understands that BP is dropping and the patient's monitor is beeping. So that she could order me to do something so that we don't lose the patient.
Okay, so the part there is while the airway, which is your area of focus, is happening, which you see that there is a priority for that to happen first, you might indicate to the physician that I am starting fluids, the ECG shows these changes. Most probably we'll have to call for defibrillator or medications or something that would come off. So this, I think, can I ask Dr. Prajwal, when this happens, does it make you allowed to focus more on the airway, or it might distract you, or how do you think that would be to you when Jyoti is definitely going to be loud and going to clearly tell you this? I can imagine.
It would obviously distract me and cause me to go more into a panic state. I am trying to do something, intubate this patient, and she's still further deteriorating. So immediately I need more hands. So I just tell her, patient is going into a failure. So I guess we need to call in our physician.
Great. So I think each one of us have our priorities and our conflicts on the inside. While the one at the head end who's taking the airway is like, am I confident in intubating? Will I get this tube in? Will the tube be in the right place? Does it go to the airway? I could see the relief on your face when you say, oh, CO2 is seen as like, wow, there's a mini celebration there, which is good. I mean, every one of us want the tube in. But for Jyoti, I think the point is I would not move from the place, as in Jyoti's feeling would be, I wouldn't move from the place unless the physician recognizes what I have seen. So that is called review and report. In the closed loop communications, we call this as call out. So call out is like the blood pressure is down. So that's like a first instance. And then when 3 times that Dr. Prajwal is not noticing, that is when you really go into an action. But there is a 3-level challenge or 2-level challenge. We call it CUS, C-U-S, CUS principle. I am concerned that the blood pressure is dropping. I am uncomfortable that you're still continuing to intubate. That is U. S is this is a patient safety issue that there is a flat line on the monitor and we are still trying to intubate. So, this is a 3-level challenge. Especially in Asian context, we have a hierarchy of I am doing this, I know this, I have 30 years experience in this kind of a thing. Okay, so yeah, great job. The scene went in the patient's journey from a ward setting. We discussed some principles of the patient being unstable and how we alerted that, how we established communication, the principles of how the sickness or the criticality of the patient is communicated to the relative, the party here, and the staff, that there is an anger in how the care is going. But that shouldn't deter us from what we do, which is acute care management. So Jyoti and team and Dr. Prajwal noticed that they need to take control of the airway. They established it. The hemodynamics obviously will be attended to after this. To complete the initial part, we were talking about low blood pressure and low oxygen, normal blood pressure and low oxygen, high blood pressure and low oxygen. So those are concepts which we need to know. So in this context, I think, Jyoti, if I can ask, if there is low oxygen and low blood pressure, you mentioned fluids. So in your mind, you are thinking of, would that be infection, sepsis?
Yes.
Yes, so yes. Most of the cases, that is where it is going. But then in COVID, we see high blood pressure and then low oxygen many a times. So does that also disturb you? Because it does not fit in the usual picture, right? Normally low oxygen will be with low blood pressure. Yeah, so that, I think people have mentioned that it is the autonomic changes and the hypertensive picture of COVID itself. But the classical, this time of the year when this is happening, is you are seeing acute coronary syndromes, hearts are failing, and we talk about the cytokine storm and so on and so forth. So yes, we can think about all this. So it was a lovely discussion. It was nice meeting all of you. Any thoughts from anyone? Is there anything you want to clarify?
Right. There ends the debriefing video, ladies and gentlemen. Then for the next half of the session, actually, I will go back to my PowerPoint again, and it'll be Dr. Ashoka who will take us through. To you, Ashoka.
Thank you. Yeah. So, audio clear, Dr. Nare?
Yes, Dr. Ashoka.
Great, thank you. I think before I go even to this slide, I would say it was so intense even watching it, though we were in the script and doing it. And I was like, okay, this movie is over. So can you just take a 5-minute interval break and then come back for the rest of it? No. Yeah, so that was good. And it was a scenario which was written and done actually extempo by Dr. Lulu and team from there in like 4 days time. Normally we would really go through an elaborate way of planning and dry run, and also do test run with a group of participants. And then we would go live on the day. We have templated scripts for each of us to note the scenario stage, the parameters, the expected responses, which if the participants do, followed by what actually happened on that day, and then followed by, is there a chance that this can be linked to expected guidelines and gold standards or expectations within the context. Like right now we're talking about Karnataka, and we are looking at being on par with the state of art. Now the faculty have to be well informed when they are engaging participants. And for that matter, anytime we have a topic we go in, we need to look at information which is up to date, align with the guidelines and systems locally there. So most of the times if they ask me, oh, so what's the latest? I would just say, go into this website. This is a lovely collection which is almost updated every 3 to 5 days by the public health team in National University of Singapore. And you see these 4 tabs. One talks about the entire COVID itself, and the other one talks about, you know, education as would be relevant to public, which is more simple language. And then you see the updated research, like May 2021 articles would be there, and webcasts or big time talks which we have every week, like changing topics. Previously it was which vaccine do you give, now which one do you run away from, and so on and so forth. So there is a lot in this which you could learn from, but that will be updated information. Today we are actually not going to go into discussing technicalities or medical bits of COVID, but we will focus on simulation from afar. Next slide, Dr. Mary. So as such, when you just throw simulation and COVID, you would see a big wealth of information. I think for the educationalists and those who have been doing simulation, this is a year one up, which kind of proved the 20 years of struggle that we have had trying to say that simulation is something and it is a way of teaching and training, because most of the exams happen online and had a simulation as a way of now proving that doctors can also be ready for exams, or there is a query to that, or healthcare professionals can be trained. But if you look at the templates, simulation for clinical benefits and simulation for processes improvements. So that would be the one on the left is for preparedness. Do we even know if we are ready? Like drills, we are looking at prediction and modeling. That was when will this wave go down, all the mathematical modeling. Then comes deliberate practice, which is like directly going to the drills, the personal protective equipment, the resource, and team training. We will come to that, which we did also, the one that we did. Maintenance of skills is like, it's like actually CPD. I was involved in this last year, and then we had 8 months of good time. I even watched lots of movies, and then the next wave comes. So I am like, hey, where is that? Pull it. Yeah. So we do start retraining, and that's the maintenance of skills. And the other part on the right side would be the simulation for innovation testing, which is processes. We are looking at validating some equipment. Let's say you have a new barrier screen, you test an equipment and do they get splash on them? Do they have changes in how things improve? We are also looking at continuing education, undergrad, postgrad, interprofessional. These can't stop. People have to continue. The academic calendar never stops. The years move, and a 12th standard student should have to become a first year graduate. And then for assessment, so that's a big thing. So next slide, please, Dr. Mary. So you could do simulation in any of your contexts. These were some things which we had done in our setup. So we had created a simulation room and an anti room. So what were the existing stuff, we just populated it around what is needed, looked at how many people are in the room. Do they even wear personal protective equipment? Do they do it in time? And we were publishing a few on this. The next one, please. For that matter, even orthopedicians, if you could imagine, got into this act of simulation. I think Lulu is smiling. Yeah. So if you could get them to do big time active simulation and not just, change the knees, that is great. So they actually were pretty up and about it. And that's an example of how if you do sincerely, you can get good buy-in. Thank you. Next one. Right, so this is, before we play the video, I'm just explaining how a code training within our context had happened. This is almost 1 year ago, and we're doing it again. So the glass door is the simulation room. The ones outside are people who are dawning up, and there's somebody actually watching like a hawk. How much time they take, do they touch any surfaces, which way they fold, what do they do? And I'll be playing it in time lapse in 20 seconds, just because we had a 45-minute simulation just now, to show that the first wave is the first respondents. The second one would be probably the core team, the physicians and the anesthesiologists and the intensivists coming in. Then the actual process of CPR happens, and how we go about it is all that said. Just play that for a bit, Dr. Nare. Right, they're donning the equipment, going in. Nursing team calls for more help. Further help comes. Okay, pause here. Right. So this is the part where the first call or the first respondents actually ask for the core team to be there to establish the airway. And this is where they have to wear this PAPR and respirators, which I think only few centers would in many contexts have it, but just for us to know which side to wear, what was difficult. So we had to have training even that for that to happen. Please continue. So all anesthetists were enthusiastic about it. It had to fit all sizes, and it had to happen in such a pause here. So you could see there was chest compression, there was effectiveness of it being monitored. There's a team doing the airway, one is managing the cardiovascular system, preparing for code, and so on and so forth. So this went in many cycles, can play, and it went on for a period of 3 months before the actual outbreak came. So there was a preparatory phase. Yeah, next slide, please. And when we, you can move to the next slide actually. Yeah, good, thank you. So what we saw, I think we bring to the attention is, you could do from being in the scene, or you could also do from away from each other, but eventually everyone, at least 60 to 80% of them have to go through training. If you just look at the purple line on top, is the time from cardiac arrest from 12 minutes to the actual successful intubation to 6 minutes. So it can half by the fact that you run one round of trainees to go through this of any sort. ICU nurses, physicians, we recruited surgeons to become intensivists. In the scenario, we had a biochemist and a forensic person bravely participating in the scenario, and that's hats off. Amazing work, and you can't tell who is who from how that happens. It's just a matter of time. The fire triggers, and we would do amazingly well. And then the other part is like the green line is like average time taken for the code blue respondents attending to. So most of it actually halves in that period. So when we say run 1 to run 6, we are down to 1.5 months. In 6 weeks, we are kind of seeing patient outcomes. Thank you. Next slide. And that's something which you should think of. And even now interstate district lockdowns and 5-kilometer radius has come. You really have to fall back on what is called simulation from afar, where you are looking at participants and then you are looking at faculty. The third component is the conducting the scenario, which is the place where it happens. So if you look at the scene that we did, so the participants were in 2 different rooms when they're doing in 2 different frames, but you are working as a module of interprofessional education. And we are talking about frames where there's communication, there is initial brief, there is reassurance, and then there is acute care, and then there is escalation and CPR and so on and so forth. So then we have debriefing as a concept, which is very much templated. We saw a larger elaboration for an 8-minute simulation. You had a 35 minutes, and Dr. Lulu had to cut another 15 minutes of me talking with all the happinesses and the emotions which are there. So it is a script and a song. But when we are locating from various places, we need to understand that there are observers in a session like this who are actually watching like how you are watching in the scene. Now, how do we engage them? So normally we would pause, run a Zoom poll or some kind of online questionnaire and asking them to say, okay, in this scenario, pause, what would you have done? Of the 5 available options, what is the best that we could do? Right? Okay, so next slide, please. So that's my last in my segment of it. All I'm saying is when we do these programs in person, through tele or digitally, from different synchronously or asynchronously, remember, we have to peg our outcomes to how does it actually change patient improvements? Like, does it cut costs? Do we save supplies? Can we prevent a healthcare worker being infected? can this mean that you could save a locality or a community outbreak? It's not about getting that to say, oh, we did simulation, the government knows. We think all of us are confident now. The knowledge level is better because a pre-test, post-test MCQ is no. It has to be translational outcomes which reach to show benefits. Okay, so that's Kirkpatrick's model. So thank you, and we'll take more questions. And Dr. Naren, over to you for your clarification of education. Thank you.
Thanks, Dr. Ashoka. I'm back, ladies and gentlemen. Now we have about 4 or 5 slides to go through. Now, initially, if you had seen me when I spoke, I was running like a bullet and you were wondering what is happening. And we had a video that was being played and then there was a debriefing that went on. Let me take you through what exactly that we did to come to this particular stage where we organized the whole thing, we ran the scenario, and what are the educational components that are involved in this simulation session, which I will take you through. If you look at it, we asked for your, what is that you want? What is the outcome? What is that you all expect from this particular workshop? That is the first thing that we did, which is what is called as, we wanted to know what the target audience wants. And so that we did what is called as a need analysis, so that we know this is what we have to do. That becomes your topic. Now, once you have identified the needs analysis, you have identified the topic, and now you'll have to come up with something what is called as the outcome or the objectives of it. Outcome is what they would want to carry and they go back for a long-term or a short-term benefits, and objectives could be multiple in number. So we did that as well. Once we have found the topic and we have listed the objectives and the outcomes, now we designed what is called as a lesson plan based on various things that we thought of. How many facilitators we have, how many participants that we bring, what kind of venue that we can use, what are the mannequins or the resources that we have, who are our facilitators, who are our technical support, what kind of reading material that we have to give them in order to get them prepared before they come to or for the simulation session. All was this brought in, and apart from that, once we have done that, then we had to script a scenario. That took a while, wherein which you bring in all the facilitators, you bring in all the subject experts in, and you bring in all the conference experts who decide that this is what has to be expected. We decided something what is called as a scenario. Once you make the scenario, then you will have to aid the facilitators who run the scenario or who monitor the scenario with a particular what is called as scenario guide, so that they know whether the outcomes of each and every step or the stage of the scenario has been achieved. So that is a kind of an assessment, would you call it, if it is an assessment part, or if you want to see whether the outcomes have been achieved. So whichever way that you want to frame it, you can frame. Then this will be followed by debriefing and how exactly it will be done. That was also scripted actually. And then we give them a feedback about along the way that it goes through. How did we go? What are we supposed to appreciate? What are we supposed to look into? The whole lesson plan was ready. Once we got the lesson plan in, and then we said, okay, let us do a dry run and see whether the technical glitches in place with looking forward for how exactly to change slides, how exactly to shift from video to PowerPoint, who speaks when, and all that. We had to script them all as a scenario outflow, and we did a dry run with that. Fingers crossed, touch wood, so far so good. And then we implemented the whole thing. It took a couple of days. Thanks to Dr. Lulu and Father Muller's team to support in all the activities, all the 3 videos that you all saw that. And then we will normally, what we do is, which we have not done yet, you need to do a quality control of your particular session. So you go back and reflect on your session, look every frame of it, see where you can improve. What are the things that can be done better in order to improve what you have done so far? So this is what is needed. Next, let me take you to the frame again. You saw the video on a brief video. You saw Dr. Lulu speaking here to all the participants in there, and there are certain things that you have to carry on while you pre-brief them about the scenario. First and foremost, you need to tell them, be yourself, do what you know. We are not here to criticize you. So you create a safe environment, and you gain the confidence of the person by chit-chatting and then breaking the ice, so that they become confident and they are willing to communicate their grievances and concerns, and then you set the scene now. Once you have done that, you describe about the scenario. You say where it will be done, what are the outcomes, what are the objectives, what is the information, or take them, run them through the whole scenario verbally so that they get comfortable with it, so that they can design their roles. Then you tell them what is expected of them based on the objectives and the outcomes of the scenario. What is the participants' expectations? What is the facilitator's expectations, so that that facilitator can debrief based on the scenario what exactly had happened, see where and miss and match what is happening, and that gives you a script for the scenario, for the debriefing itself. Now, once you know, you need to tell them during the pre-brief that they will be having a debriefing and what is the purpose of it and how it will be done, which you saw it was a video based here. And we had to tell, we wanted to share certain things that they have gone through and we wanted them to know. So the purpose is also being shared. Once you have done that, then you saw the simulation room. If you look at it, everything happened in the same room. There was nothing like we had multiple rooms to do it. Correct me if I'm wrong, Dr. Lulu. Then what equipments that we use, whether we use a standardized patient, whether you want to use a low part task trainer or you want to use a human patient simulator, what is at your disposal, go ahead with it. Once you have done that, then we have to get an informed consent and say, okay, this we are going to record, and it is for ethical reasons that you have to disclose this to your participants, and you say it is for educational purposes, the whole thing will be recorded. This is all about pre-brief. Let me take you through the COVID ward scenario clipping part. Here, what happened, the environment or the scene setup was a COVID ward. Next, who was your mannequin or the resource that was available? There was the simulated patient who was lying down on the COVID in a prone fashion. Then you saw them do what is called as a situation awareness, where they monitor the patient, see how what is happening to the patient. And once you saw that, once that particular situation awareness was identified, they saw that the patient was in distress, patient was already in prone, then it was escalated to the next level where the doctor was informed. Following ISBAR format, which is nothing but I standing for identity, wherein which you identify, when you hand over a particular case to a person, you identify who you are before you start doing it, identify, reveal what exactly is the situation, why you have escalated to the next person, you give them the background of the patient, then you disclose what is your feeling and assessment about it and what particular recommendation that you want. So this is how you generally hand off. So ISBAR format is one particular thing that we generally can look into. Once that is done, then it was another component which was nice, wherein which comforting the patient came into the picture as well, wherein which a little bit of empathy part also was checked upon. Then the doctors and the nurses made an assessment of the patient and they decided that it has to be escalated to the next level and patient attenders have to be informed. So again, ethical practice, informing the attender was shared, or informed decision-making component was addressed there. And then it was, and the ICU was also informed about this particular case. Now, informing the attender while it was being done, the nurse was able to pick up that the attenders were a little anxious, excited towards the other side, and probably that needs to be conveyed. The nurse came back to the doctor and closed the communication, wherein which an informed, saying that attenders are a little agitated about this whole situation. They were not very sure to what to do. So the whole communication loop was closed there at the COVID ward. The next scene, it was in the ICU. Immediately at the environment, it was in the same venue, but the mannequin was placed there. We used a high human patient simulator mannequin, which was there, where again, initial handoff was done, wherein which ISBAR is one format where we, as usual, which I told you earlier. Then again, monitoring the patient at the ICU, they decide on what has to be done, which is nothing but a huddle. And then the task was delegated. When you see the task delegation, there were two main tasks that was done. One is to escalate. As the patient condition was deteriorating, they had to decide whether the patient had to be intubated. And she called the nurse and she said, okay, I need all these, get ready or prepare for intubation. Second, find out whether you can bring in an ICU intensivist who can come and help us with the patient. Now, if you look at it, while the patient was being intubated, you had the nurse watching what is happening, and that is what is called as cross-monitoring. And the patient and the nurse informs the doctor saying that the blood pressure is falling, and that is what Dr. Ashoka mentioned earlier, which is a CUS it is two-step challenge where you inform the patient's condition twice while the doctor is immersed in a particular activity. But in fact, here the doctor caught it immediately. And that is what, again, is situation awareness again. And mutual support is doctor requesting the nurse for various help and doctor requesting the nurse to auscultate after intubation to see whether the tube is in place. Then I'm going to the last frame where in which there was a patient recovery component of it, where in which again monitoring comes into picture, and again the doctor delegates a task to a set of things that needs to be carried out, where she said prepare the patient for weaning the ventilator. Second, prepare the patient for discharge and inform the patient attender. But again, remembering what happened at the earlier where the bystander was a bit agitated and aggravated based on the ICU escalation. So she comforts the patient, brings in a moral support saying, don't go alone, go ahead with somebody else when you inform the patient. So this is what had happened. And these are the various educational components that came in the simulation activity. And we also we also brought in the interprofessional teamwork as such that was done in the scenario that you watched right now. Thank you very much. Now I will request Dr. Lulu. Over to you, Dr. Lulu.
Thank you so much, Naren. Thank you, Ashoka. So before I hand over to Varun to collate the questions for us, I can see in the Q&A that not many questions, probably post-prandial. I don't know if all are sleeping or all are, still excited with the popcorn watching our movie. But then before I hand it over, I would like to thank my co-facilitators and acknowledge mainly the JeevaRaksha Trust, which I'm also a part of. We call it the JeevaRaksha family, like how Dr. Ram likes us to call it. I thank the conference organizing committee members. Well done. The whole morning session, afternoon, very well done. Thank you, Varun, for moderating the session, scenario videos, my co-faculty and my technician for all the videos they've taken. Facilitators, I've already thanked them, can't thank them enough. And again, Bala, thank you so much, you and your Ladal team for supporting us. So over to Varun. If there are any questions, three of us are ready to answer. And if it's anything regarding COVID protocols locally, thank you for offering to address those questions. So is there any question, Varun? I think there were two in the chat box, which I think Ashoka has already addressed.
Yes, yes, Dr. Lulu.
Yes.
Thank you. What a fantastic way of depicting a real life scenario. I think it's really worth applauding the whole team, Dr. Lulu, Dr. Naren, and Ashoka for their efforts. Okay, this not only involved the managing the case as per the current evidence, but also stressing on interpersonal skills, communications, team dynamics. Very good. So we have a question. I think it was answered, but let me throw this question to the panelists. Any online courses for simulation for doctors in India and abroad?
I think Ashoka has replied about the abroad courses. So locally within, yeah, just to add on, I have worked, I've been a part with VC and his team during the simulation early setup. So we are looking under Rajiv Gandhi University to start up simulation educator courses. That's in the agenda, thanks to our Vice Chancellor. So in the state, it will be there. And as on a national level, we have two organizations, Simulation Society, SHS, Simulation for Healthcare Society, which I'm a part of, and Pedistas. They are also offering simulation educator courses. So this is what we know. And even there are local universities who are offering. You can just contact and browse on local courses. You will get to know them. Otherwise, please do email me. I'll see if I can help you out. The organizers have my email. I hope I answered the question. For abroad courses, yes, Ashoka and Naren are the right people you can contact.
Yes, thank you, Dr. Lulu. And I just want to know from the panelists, do we have any data which shows that there are benefits of simulation program in the real life? Is there any meta-analysis or any good data which tells us regarding the simulation programs in a medical field?
Dr. Ashoka? Yeah, you hear me actually?
Yes, we can
yes,
hear
sir.
you, Ashoka.
We can hear you.
Right. Video is frozen, and maybe Naren can unshare screen, or yeah. So at this point, we are looking at evidence of effectiveness of simulation, and the question was, does it improve patient outcomes? Is that what your question was?
Yes,
Doctor?
yes,
Okay.
yes.
Right. So till 2016-17, there was not enough information describing these. So from 2016 to 17 onwards, steadily we are hearing information about either the short courses or the longer ones, which is longitudinal courses, we would call it. So when we talked about shorter courses, information available talk about skill maintenance to 6 months to 9 months. And this is something which we most of us know that it deteriorates after that. But when people looked at longitudinal benefits, that is how first they have managed to prove it's non-inferior when you are proportionately increasing the simulation component. This comes from US-based literature. But when we look at Europe and
I think his internet is down.
Yes.
Maybe I can just take over from here.
Yeah, you can take over, Dr. Naren. Yeah.
What happens is there are a lot of courses which are available, and you have like a module-based course and you have a master's-based course as well. And masters are somewhere, most of it are UK-based or US-based, and some are Australia-based as well. Modules, they are being produced like a 3-credit module, 4-credit module. You will get a, I'm not sure it is worth a certificate, or it'll be just saying that you are being trained in simulation. That is one. There are some people who are offering PhDs as well, where you have universities in the UK, universities in the Australia, universities in the European. When I talk about UK and Europe, you need to come towards the middle part of the Europe, center part of the Europe, especially the Scandinavian countries. They do some, but the only thing is the language is a barrier. But I think post-graduation, it should be in English. So you have them as a module, or you have them as a PhD, or it's a part of a medical education. You need to explore and identify it as simulation masters on the website. You will have plenty of data. I'm surprised, I think there are some universities in the South Africa as well who have started it quite recently. So.
To add on to that, Naren, thanks. I completely forgot I'm also doing my master's in healthcare simulation. I gave him such a short CV. So yes, Varun, I got a scholarship in, just when he said UK, I remembered. So they are offering scholarship to Indian delegates, and it's a 2-year master's program, healthcare simulation and patient safety. Patient safety is my passion, so I wanted something on that. So there are options abroad. Yes, thanks for reminding, Naren.
Yes, welcome.
Yeah.
There Ashoka is in. Dr. Ashoka, would you want to top up?
Yes.
No, SIM card balance low. Sorry.
Yeah.
So
we missed you, Ashoka. You can take on the meta-analysis from Europe.
Yeah. Okay. So meta-analysis from Europe, like 2017 onwards, they are talking about educational outcomes. We have gone from non-inferiority to presence of like both interprofessional courses. Now from 2018, we see use of virtual simulation, game-based learning, and AI or Bluetooth enabled inserts, which provide prompts, and then what we call clinical deterioration prevention. So self-portrayal is, we also have a BME systematic review, which talks about this. I can just put it in the chat. So it's an area to watch, and it's really nice that we are now seeing the Kirkpatrick's higher grade simulations. Thank you.
Sorry, just I saw one nice message in the chat, which I think every audience will be happy to hear it. JIPMA offers PhD in simulation. This was an input given by Mr. Balaganesh Ladel. Ladies and gentlemen, JIPMA offers PhD in simulation.
Thanks, you, Bala. Thanks, Bala.
Thank you. Really great conversation. We still have a couple of minutes. I want to ask Dr. Lulu, because she's heading the simulation center in Father Muller's. Ma'am, how do you think is as a organizational aspects and how to go about simulation programs? What are the challenges you face during organizing a simulation program? Because it involves multidisciplinary things, and obviously the financial aspect will come at the start. But apart from that, there are a lot of other things because you'll have to involve many people from many different streams. That is the most challenging aspect. It's not all clinicians. So how do you, as an administrator, how do you think what should be seen at?
Yeah, thank you, Varun. I won't be discussing the financial aspect. We are a little privileged institute. We have a very proactive management who is ready to invest, and provided we show them the outcomes. So return on investment is a, you have to underline, if not in terms of money, at least in terms of patient outcome or educational outcomes when we say ROI. But coming to your question, I feel personally as an administrator, my asset is my human resource. My faculty, my learners, and my technician. You try to make them more competent. We do a lot of in-house simulation educator courses, faculty development, whatever I learn, and then I come and imbibe. I imbibe and then transcribe or translate it to them on how to do it. Buy-in in the beginning was very challenging. There was a lot of resistance. We're doing it with so many patients, and how to get in. It is quite difficult. Two things what we have done is for paid courses, we have started incentivizing the faculty. Not that it's a great amount, but at least something. And second, in terms of appraisal forms, being simulation educator or coordinator of the program. So our dean is very, very, dean is our boss right now, Dr. Jayaprakash Alba. He's also part of the Rajiv Gandhi University Committee. Very supportive and giving us opportunities for the faculty to grow, relieving them from their parent duties, discussing with the HOD so that they can come and do programs here. The main thing is you need administrative support. Interest, yes. Feedback from the learners, making the faculty do more. And all these learners who are faculty you have seen is actually PN Para. They are my JeevaRaksha instructors, Varun. They are, it's actually Shailaja, Karen are ECLS instructors, and Reena and Sandra are ENLS instructors. So I'm in, they are awesome. So these kind of courses and these kind of competencies, it need not always be clinical. So we kind of take one or two clinical staff as content experts who are willing to join, and we kind of upskill these educators who are interested and maybe have a little more time with them. So this is how we have started, and we are, kind of maintaining it. We now have around 100 adjunct faculty who are doing small courses. There is a free course on Coursera, Essentials of Healthcare Simulation, for somebody who wants to start. If you don't want the certificate, it's absolutely free. It's a 7-week course. You can start at that. Back to you, Varun. Okay. I hope I answered your question.
Yes. Thank you, Dr. Lulu. I have a last question to Dr. Naren. Now that we have seen a lot of simulation and we have well known what simulation works, what do you think the future of simulation is going to be? What do you think how the future is going to be for simulation programs, and what extra things what we can expect in the near future?
With the uncertainty in the picture, especially with COVID, nothing else can support than this at this point in time. You will have more of virtual stuff that is coming in as part of simulation, apart from hands-on as well. Never it is going to be like I've not gone into the campus and I've not brought in my students since last year, March. And imagine we are supposed to, students have graduated and they've missed a couple of semesters, they've missed a couple of programs. So we do not know where are we heading at this point in time, but things are going to improve, and probably this will become like a piece of cake like what we are doing right now. And then this will become outdated, and tomorrow will be something else that is coming in the picture. Probably if you ask our manufacturers here team, they will tell you what are they. They are updated with all that stuff actually. So that is where we stand at this point in time. Thank you.
Okay.
Dr. Ashoka?
Anything input, Dr. Ashoka, from your side, the future, how is going to be, anything which will come out of the box in respect to simulation programs?
2005 to 10, we were beginning to do simulations. But then from 2010 to 16, it took a long while before we could actually be where we are. So I think myself and Naren had visited in 2010, and I think 13 to 15 was Father Muller and Dr. Lulu. there are lots of private bodies which have gone on to bring this to a big level. The MCI and the government of India has taken a big initiative in making this formal. But it is about buying a MacBook and not understanding how to use Word document, So we need to be literate about the part, what is basic of understanding a learner, what's their environment, what resources they have, what technology is available with them. It could be a card game. I saw a board card game called Syphilis, and then it shows a lady with a snake around her, and then they have to understand this. If I had known it, I wouldn't have mugged that big name at that time. It would have been much easier. So understanding digital native learners, looking at the scope of their resources, and then pegging it to them. We cannot copy paste a Western model to where we are. We have to see the strengths of what our teachers did, and then seeing how the new generation is and matching it to them. So there is a 5,000 rupee mannequin which has done better in how they do dice training in the Northeast with a balloon and a clicking tick 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 sound, and that did better than any of the other mannequins. So looking at the future is differentiating to the context, and it's not just the metropolitans do better. We have to see for outcomes how it reaches at the level of the nursing, allied, and peripheral healthcare. Now I do see Indian school teachers teaching Philippines school kids through online, and it has united the world, and you have a big bank of information. So the world is open, and I pause here in the interest of time. Good luck, and thanks for making these initiatives happen.
Yeah. Thank you very much, ladies and gentlemen. Good luck for you all.
Thanks for the everyone for this. Thank you. Well, moving on. COVID has taken all of us back for a few years behind. That's what I feel. And not only we have to reconstruct the society as a large, but also reevaluate our medical education and what we were thought was right. Is it really right or wrong? So let's move on to the next most important part of our discussion. It's going to be a panel discussion, which is going to be with well-recognized experts nationally and internationally. And this panel discussion is on the future of healthcare after COVID-19 watershed. Moderating this would be our beloved and dynamic organizing chairman, Dr. M.A. Balasubramaniam. He is an advisor of community process and comprehensive primary healthcare, Ministry of Health and Family Welfare, Government of India. He is an anesthesiologist and a social worker. He, inspired by the teachings of Swami Vivekananda, joined with a group of his friends, medicos, and founded the nationally acclaimed registered non-profit organization, Swami Vivekananda Youth Movement. He is presently the secretary of that organization. He has pioneered public-private partnership initiatives, which are some of the current national modules in the sectors of health, especially in emergency medicine. He has been a member of various planning and policy committees at the national government and the state government and academic bodies by various universities. He is a founder managing trustee of JeevaRaksha Trust and a co-creation of Swami Vivekananda Youth Movement and Rajiv Gandhi Health University. Over to you, sir.
Good morning. Good evening, sir. And good evening, Dr. Varun. Thank you very much for that warm introduction. And really excited to be part of this one and really appreciate all of you in ensuring that, in fact, all the panelists, that we are on exactly on time. In fact, we are ahead of schedule. See, the panel discussion is expected to start at around 4:15 and we're just at 4:02 and we've been ready. And I would like to personally thank Dr. Sachidanand, the Honorable Vice Chancellor of Rajiv Gandhi University of Health Sciences, who have made all these things possible. In fact, the journey that he has enabled right from the days when he was the Registrar of Evaluation in 2013 to the current state where he is heading the university especially during this August period of the Silver Jubilee of Rajiv Gandhi University of Health Sciences, and have made these transformative changes possible. And he has heralded the new era for Rajiv Gandhi University of Health Sciences, is what I would say at this point of time. And especially in a very challenging last 2 years, where you could see COVID has actually challenged every one of us and helped us rethink on many of those issues. I also welcome Dr. M.K. Sudarshan. So I see all of them on the panel, and so I think it's probably it's time for we to start off. In fact, I was just thought that we could wait for this one. I'm just waiting for Dr. Soumya Swaminathan also to come on the line. Good evening, sir.
Yeah, very good evening. Nice to see you after some time. Thank you. You are in Delhi now?
Yes, sir. Right now I'm in Delhi, sir.
Okay, okay. Thank you. Nice seeing you. Thank you. Thank you for the invitation. Thank you.
So, meanwhile, I'll introduce all the August panelists. In fact, it gives me a great privilege and pleasure to actually be moderating this important session. And that too with such distinguished personalities. As I told you, Dr. S. Sachidanand, I don't think he requires any elaboration in the current scenario. He's a renowned dermatologist who has all along excelled both in curricular as well as extracurricular activities all in his life. And as a vice chancellor, probably he reshaped the university to making it very socially and morally relevant. And that is what I would say is a transformative exercise that he actually engaged in. He continuously has strived to make Rajiv Gandhi University of Health Sciences a center of excellence academically, and also enhance his social responsibility in bringing several stakeholders in the healthcare delivery system on a common platform to work towards development of various schemes that are socially relevant and reap benefits to community at large. And what great opportunity and challenge he was posed by COVID pandemic by itself, for which he is also the chair of the technical, I would say, scientific committee there. JeevaRaksha also, as I told you, was, I would say, nurtured by him during the last 8 years, though he was in and out of the health university system at that point, because in 2013, he was a registrar of evaluation who inaugurated the first JeevaRaksha training program at Bangalore Medical College. And now as and he actually propelled it in a very unique way by enabling trust being created, which gave an adaptability, flexibility, and autonomy to suit to the scale and speed that this program has to reach in terms of, I would say, reaching out to people and ensuring transformation of lives, transformation of the entire culture in the community and saving a lot of lives. I welcome you, sir, for this important panel discussion.
Thank you. Thank you very much. Thank you.
Thank you. Dr. Sudarshan, I think for the last 2 years is a household name in Karnataka. I think he is well known, very humane and a humble person. And though he is actually retired as a dean principal of the Kempegowda Institute of Medical Sciences, by himself a community medicine specialist, he has steered Karnataka all through the COVID challenges. And he has been the chairman of the Karnataka State COVID-19 Technical Advisory Group, a very accomplished person, very highly respected both in the public health field, academic field, and now also in the government sector too. And he being there, probably we would really get the grassroots level understanding as well as the action on the ground that he has been able to propel by translating a lot of policies into budgetary commitments and activities on the ground. The other panelist is Dr. Santosh Kumar. Has Dr. Santosh joined?
Not yet, maybe.
Okay. So, okay. I think being ahead of time sometimes is also a challenge. So at least I'm still happy that we are ahead of time rather than behind schedule, where it constrains a lot of, I would say, activities or probably discussions, especially in the academic framework. And we would be joined shortly by both Dr. Santosh Kumar and Dr. Soumya Swaminathan. I would defer the introduction of them till they join onto the panel. Well, going forward, I think most of us probably would be actually debating on the relevance of this at this point of time. And I think we feel greatly honored to actually be hosting this conference and talking about this issue of the panel discussion, which is Future of Healthcare After COVID-19 Watershed. My understanding of this is twofold. I think it is not just a public health challenge. It is a challenge and a transformative, I would say, factor for the entire human world. There was a time when man and machine worked. So the man continuously worked to enrich himself. So there was a lot of wisdom in him, lot of inner peace and inner joy. Then we got the machine in the industrial world. So the machine became more productive and started competing with man. So the machine ended up being more and more productive externally, but in terms of value, it started depreciating. Probably, you know, every machine, as it becomes older, it becomes lesser and lesser in its value. The competition for a man was to look at, while the machine is externally productive and internally depreciating, man had to challenge himself to look at how he can externally be productive, at the same time inner also has the peace, the joy and the evolution that can carry on. This tussle went on for quite some time. COVID has actually created another watershed. Now it is not man alone, then man and machine, but now man with machine. And that is what is helping us work together today also. So we are in this one to see how we can maximize the productivity and value of each other to ensure that we continue to move forward, because whatever we do digitally is not a depreciating action at any point of time, whereas it should be enriching mutually also. Ram, can you confirm Dr. Soumya Swaminathan's entry?
Madam is being contacted right now. Dr. Santosh is here.
Yeah. Welcome, Dr. Santosh. It's a great privilege to get you also on board. In fact, going through your, I would say, biodata, it's quite impressive in terms of the diversity of engagement that you've had, both in terms of the sector and science of medicine, as well as in terms of society and humaneness that you've been continuously being engaged with. I find you both in the last 27 years of your life, you have been continuously striving to work for the overall betterment of the human race. You have been an accomplished leader. You have been an excellent healthcare practitioner who has traveled across the world under the banners of MSF, International Red Cross, Save the Children, and almost you have visited 40 countries, and especially in places where there were conflicts, wars, riots, natural disasters, etc. And have been able to serve many, many people and save many, many lives. And this, probably this diversity of your exposure, being a deputy of medical superintendent in heading a department of orthopedics and being in the emergency medical department of Thiruvananthapuram, which was the first place, probably the Kerala was the first state which got the first COVID case also in this country. And even now, though your death rate is substantially low in terms of percentages, the number of cases, considering the population, is also still significant, and you have been battling it efficiently there. So you bring in a diversity of science and society to the platform. And I'm sure you are not only a very intellectual person, but a very passionate, empathetic person who would want to get engaged on an activist mode to reset the clock and reset the framework to become more and more human or humane in the action. So thank you very much for joining this important panel discussion. I think you're muted, Dr. Santosh. You're still muted. Yeah. It's very low in volume. Can you probably? Dr. Varun or Dr. Ram, can you confirm any challenge?
Can you hear me now? Hello?
Yeah, we can hear all the 4 panelists now. Thank you.
Yeah, can you hear me now?
Yeah.
Yes, Dr. Santosh.
Yes.
Yes, that's fine. So I'll talk like this. That's fine. So thank you, Dr. Balasubramanian from Mysore, and also the other panelists for inviting me. It's like a pleasant occasion to be here as a panelist. So how do we begin? It's like
actually the overall session would be structured like, probably we will be looking at lessons that we have learned from the pandemic all along, and how we are going to relate those lessons into the current and future of healthcare. And you would be taking more in terms of your frontline action, your perception, the community level, or the community behavioral issues, how the pandemic has changed people. So, because now as a healthcare sector, we have to respond to the people's needs. So we would like to appreciate what has happened on the people's side also. And the same issue when it comes onto the academic field, I would appreciate Honorable Vice Chancellor, Dr. Sachidanand, to speak about what are the lessons that we have learned from the pandemic and how we are able to leverage that, or how it has influenced the future of healthcare, I would say education of human resources for health. When I mean human resources for health, we are not limiting ourselves to only doctors. So, and we have I would say, being a Vice Chancellor of a university which is very unique, which has got all health sciences under your banner, with so many institutions, nearly 700 plus institutions under your armory. I'm sure you would be the best person to educate all of us and enlighten all of us on the way forward. And when it comes to Dr. M.K. Sudarshan, he has been in the thick of the storm. He has been a policy maker. He has been the person who actually has guided the government into various actions. And I'm sure there are lessons that are learned, and there are preparations that are being made for the future, not only to, I would say, control this pandemic, but also the probably target future pandemics that could be there. Probably it is not just century, probably this could even start recurring with 2030, 2040, like this. So how are we preparing ourselves? Probably that could be the dimension that Dr. M.K. Sudarshan made. So each of you as panelists would be speaking for about 10 minutes. Then there will be a short responses from this one. There will be a Q&A session where people can ask, and we would be engaging with them. And then subsequently, we would be, once all the panelists complete this round, there will be 20 minutes of general, I would say, a question answer session where we would be actually debating on other issues which might have cropped up from each other's words.
Dr. Swaminathan is here, Dr. Balu.
So, shall I begin now, or someone else is begin?
Good evening, Dr. Soumya Swaminathan.
Hello.
Very nice to see you here.
Nice to see you all.
Yeah. In fact, we are joined by the Honorable Vice Chancellor of Rajiv Gandhi University of Health Sciences, Dr. S. Sachidanand, Dr. M.K. Sudarshan, who is a public health specialist, as well as the chairman of the COVID-19 Task Force Technical Advisory Group in Karnataka. So he has been guiding the government of Karnataka, and he and his entire team. And Dr. Santosh is an orthopedic surgeon who has got a lot of experience working from MSF to International Red Cross, and worked around 40 countries, and now the Deputy Medical Superintendent in Trivandrum's Medical College, Thiruvananthapuram Medical College. He's an orthopedic surgeon who has got diverse exposure both on the medical scientific field as well as in the societal field. Well, it gives me a great honor and privilege to introduce Dr. Soumya Swaminathan. Probably, I think very few people don't know her in this world, if I want to put it that way. So, but it is a great honor and privilege that she is a person who has always been in the thick of, I would say, issues which has affected humanity in general. First and the foremost thing, when I met her in the 2005, she was the director of the ICMR's National Institute of Research in Tuberculosis in Chennai. From there, we have been able to get engaged and been able to track a journey into the ICMR as a Director General, then as the Secretary of the Department of Health Research, and then to the Deputy Director General in WHO, and now the Chief Scientist in WHO. She has been a very illustrious career. She is a pediatrician by training, but like her illustrious father, she has been always been there, translating policies into actual actions on the ground, influencing policies with great deal of scientific, I would say, understanding or evidence-based policy advocacy. So it gives me, once again, a privilege and honor. I welcome Dr. Soumya Swaminathan for this important gathering. This panel would be actually looking at lessons that we have learned from the pandemic and how that would be influencing the healthcare of the future. Is this I would say, transformative journey that the healthcare is going to have? Are there ways the globe has looked at this pandemic? Are there ways which has reset the whole thing, or actually looking at the entire journey in a different context? How we began, probably all of us know. Initially, we resisted, then we started assisting, and then we started tinkering with it. I'm sure there is a recovery that has to go through. There is an adaptive transfer, I would say, processes that we have to get engaged in. This could all herald a new transformation. So I was just initially discussing with the panel on the same issue, saying that man and machine had diverse approaches, and we had competing priorities. And while machine had productivity but depreciated in value, man had to compete with the productivity, still retain the enriching inner joy and inner peace and his own evolution. And I think we lost the race in between, competing with the machine. But today, COVID has reset the whole thing, looking at elements of collaboration, the collaboration which are nurtured by trust, etc. So I would request you to speak on your experience of learning from the pandemic and how you would visualize the future of the healthcare in the world at large and India in particular. Thank you very much.
Thank you, Dr. Balasubramania, and greetings again to all the distinguished panelists and colleagues. This is indeed a very relevant topic that you have picked up, and knowing your work, in Karnataka, and particularly, catering to the groups that are more marginalized. I think it's very relevant today to see what are the lessons that we have learned. We are still learning, actually. We have not come to the end of the journey, but we can already start looking ahead because we have identified now the strengths and weaknesses. And I should say that I can see from a global perspective, a regional perspective, and a national and a sub-national perspective, things which would need to be put in place. Maybe very briefly from a global perspective, I think when you're faced with a pandemic, by definition, that affects the whole world. I don't think any country, any individual today in the world has been untouched in one way or the other by this pandemic. And so you need rules, and you need certain guardrails, maybe you can say, which guide how the world should behave during a pandemic. As soon as a pandemic is announced by the World Health Organization, as you know, we have something called Public Health Emergency of International Concern. And once that is announced, then there are certain things which need to come into play. And for example, this will include, before a fake can be declared, you need certain things. And that is basically good surveillance and data sharing and data capture at a global level. Because without that, we will never be able to know where is the next threat. And we won't be able to contain that threat unless everybody is warned about it. So, in this case, on January 4th, 2020, the WHO did put out what we called a disease outbreak notice, which basically told the world that there were cases of atypical pneumonia in Wuhan and that further investigations were happening. So something like that needs to happen as quickly as possible, as soon as possible. And then a global alert needs to go out. And when that global alert goes out, every country needs to put in place certain mechanisms, which again have to be pre-agreed and pre-planned. Now, then we need the response. So one is the detection, then the prevention. Prevention is again by good surveillance and trying to shut down things which before they become out of hand, which means if you take our country, it means that we need a very good surveillance system down to the sub-district level. And at the district level, you need a team of people who have the understanding of epidemiology, who are working on the intersection of human and animal health. Because surveillance means it has to include now also animal and environmental surveillance. So we need it is known as a One Health approach, but it is very true that you need animal, human, and environmental surveillance to be really capturing the full picture. And then there needs to be analysis and action on that data. And this has to be at the lowest level of administration. So we need to strengthen. And one of the things I think, if you look at India, there are only a handful of states which have a public health cadre and a separate department of public health. So I would think that one of the first things to do is to set up a separate department within the Department of Health, a separate division of, not just a small division really, but it has to be an empowered public health agency who has direct control and coordination over the staff that come under the public health cadre. I look at the Tamil Nadu model and I think that it is a good model, because public health is not just about infectious diseases, right? It's more and more about non-communicable diseases. It's about many other threats to human health. It's about determinants of disease. It's about risk factors. It's about identifying what are those risk factors to health, whether it's a road traffic injury in one place, it could be suicides in another place, it could be diabetes due to poor diet and overconsumption of a carbohydrate-rich diet. So these are things which need to be identified by the public health team, because otherwise you cannot keep the population healthy. So that is a very big learning and a lesson. So surveillance, starting from the ground level, building up national and then global, which means countries have to agree on certain rules. Then prevention we talked about, and then the response. The response to a pandemic will be obviously different than response to an epidemic, which could be occurring in a localized area in one country or in one subnational region. So this is where countries will need to prepare. I think India did well as far as the Nipah virus outbreak was concerned, but we have many other outbreaks year after year, which we can neither investigate fully, or neither are we able to respond to properly. This includes things like the encephalitis outbreaks, which occur in eastern Uttar Pradesh, for example. So globally, what do you need? You need, again, some rules which will have to be now determined through the dialogue and negotiation between countries as to what should happen in a pandemic. In terms of rules around travel and trade, and what should be allowed, what should not be allowed, what are the measures that need to be put in place, all of those need to be agreed within the international health regulations. So I think those are being re-looked at now, and there are recommendations made to overhaul the international health regulations, or further strengthen them, I should say. And then you need real focus on the R&D, because we saw that when you have a new pathogen, you don't, when you start, you have neither diagnostics, nor therapeutics, nor vaccines. Now, we were very lucky, I think, that because of all the investments in vaccine technologies in the last 2 decades, that the scientists were quickly able to take the genome sequences and create vaccines. And we were also lucky that we were able to create an effective and safe vaccine or multiple vaccines. Not all pathogens we will be lucky enough to have a vaccine. Look at influenza, our vaccines are only 40 to 60% effective. And so we cannot hope always to get a good vaccine. So you also need to focus on therapeutics, on antivirals. And the WHO has a list of high priority pathogens, a list of 10 high priority viral pathogens, and also a list of pathogens which are in the antimicrobial resistance list. So we know that there are dangerous pathogens, but you can always have an unknown pathogen. But if you prepare for the known, then you can quickly adapt yourself to change to the unknown pathogen. Thanks to genomic surveillance, I think this time around, it's been a big difference that we were able to get the whole genome sequences within the first 15 days of January, and therefore both diagnostics and vaccines could be developed. So I think investment in genomic sequencing, we've seen how important it is now to track the variants, but it's also important for other infectious diseases. So it is worthwhile investing in a good network with every state having at least one center that can do high quality genomic surveillance, and then linked together, like we have the consortium now, to again share data. Data must always be shared, be made available as much as possible, and so that collaborative analytics is possible. In many countries, I should say, that data systems are siloed, they don't talk to each other, and they are not made available and open to people to be able to see what is happening and to use them. So I think public dashboards which show the situation in a regular basis on all public health priority areas would be a very good beginning, so that people can also see and learn what are the diseases that they need to worry about. Has there been a cholera outbreak in the district? Is there an outbreak of something else going on? Is there dengue? Is there malaria? So a dashboard of diseases, public health importance could be something that can be built upon the database, which we have now. I think mechanisms like the India Health Information Platform, the IHIP that's being developed. We need to do a bit more thinking and investment of how to best use those data platforms. Since digital technologies are becoming so widely used now, we need to think through carefully how best to use, what's coming out of that. So on the R&D side, I think, India has a very good pharmaceutical industry. And this time they have shown that their R&D capacity is also really advanced. We have vaccines which are being, for the first time, innovative vaccines being developed in India, DNA vaccines, other kinds of vaccines, inhaled vaccines, etc. So this is very good. So there needs to be a further support given. And what is needed is a public-private partnership to deliver these products for the health system. So in many countries, what happens is that the government invests a lot in R&D, especially in upstream R&D, which could be at the university and academic level. It could also be in the private sector, or ideally it's a combination of the two coming together. But then when the public funds are invested in R&D, then we have to see that the outputs are also made accessible and affordable to the public. So this is where I think there needs to be a guideline on how public investment, and particularly, of course, for a pandemic, but even for other diseases which are of public health importance, I think this model of the government investing a lot in R&D, but then also being able to get the fruits of that research, whether it's a new drug or a vaccine, at an affordable cost, so they can then make it available to the public at large, is something that for the future is something certainly worth developing and piloting it. And similarly, at the global level, it's being discussed that at the time of a pandemic, it's too late to start developing these things. So beforehand itself, the industry should work with other global agencies to develop platforms, like you have a diagnostic platform, therapeutics, broad spectrum antivirals, or these vaccine platforms, which can be very quickly repurposed so that within the first 100 days of the pandemic, you'll be actually able to develop some of these. I mean, that's a very ambitious goal, but that's the kind of goal that's now being talked about at the level of the G7 and the G20. So there's a lot of discussion globally on systems that need to be strengthened, but it's important for countries to also start thinking about where are the gaps. And I think that for a country like India, really the ideal place to start is from primary healthcare. It's already there within the concept of Ayushman Bharat. So there are two pillars to that. There is the health insurance platform, which is a national health insurance agency. And then there is a primary healthcare platform through the network of health and wellness centers. A lot of investment into that, into those health and wellness centers, into the primary care centers, into the health workforce, and into the training, mentoring, and development of the health workforce, which has to be an ongoing kind of a exercise, as well as the community engagement and the community participation in primary healthcare, where there is a trustful relationship that's established, where there is a two-way dialogue, where the public actually participates in the healthcare system delivery and understands what is expected of the public. If you see today, a public is being continuously told to do certain things, but there is a mixed response. You know, some people do it, some people don't do it. And the reason is that people don't have the trusting relationship with the authorities, where they automatically will believe and comply with instructions. And that has to be built over a period of time. And as we don't have to wait for another pandemic, we have enough of public health problems to really start addressing them. So again, primary health care as the essential pillar of universal health coverage, I think is absolutely the mantra that we should be following. And I have seen that countries that have invested in primary health care and low cost, in fact, they have not invested in big tertiary hospitals, but just in training community health workers and the kind of health functionaries who are constantly in touch with the community. They have also handled this pandemic better. If you look at the Southeast Asian countries, till now, they have been able to handle it very well. Recently, they're having some spikes because of this Delta variant, which is spreading. But it's not necessary that to have a good healthcare system, you have to spend billions and billions of dollars. So I think in the topic, you had mentioned what is the healthcare system in developing and developed countries need to learn from this. Many high-income countries also faced a huge challenge. They were not able to cope up. We can see from the data, from the mortality statistics, etc., that high-income countries did not mean that they were able to cope better. So I think it's again the public health response, the primary health care, and the level of preparedness which made all the difference. To some extent, Africa has done better. Possibly the population there is a very young population. The median age is around 18 to 20 years in many African countries. Could be the reason why the infections there could have been much milder and not that the health systems didn't get overpowered. But they also have good community health programs because of their TB, HIV, and malaria burden. Over the years, they have invested more into that rather than into tertiary care. So I think I will stop there and also say that finally that health is not only health care, though we often think when we are medical people, we think about the delivery of health services, diagnosis and treatment of diseases, but health is really, and well-being is much more holistic than that. And so really looking at prevention of disease and at health promotion, I think that is the next frontier for us. We need to invest. I've seen in Thailand, for example, they have a whole agency which is called the Institute for Health. I can't remember the exact name, but it is for health promotion. And they are funded by tobacco tax. So you take the tax on harmful products like tobacco or alcohol, and you fund it into an institution that is focusing on health promotion. And they do everything from road safety to tobacco control, to suicide prevention, depending on what the priorities of the country are. But the fact that there is an institution that works on health promotion, I think itself sends a very good signal that, you're serious about disease prevention, not only about curative aspects. Thank you, Dr. Balasubramania. Back to you.
Thank you very much, Dr. Soumya. In fact, that has been very, very educative, enlightening, and informative. In fact, audience also have started commenting on that issue. I think one thing that you're trying to, listening to you, it seems to be that by itself, COVID-19 was a great leveler. Developing, everybody is in the same boat. And in fact, distance also have got evened out, whether it's Geneva or Bangalore or Delhi, it doesn't matter today because it is as good as the neighbor also is as far as the Geneva today. So in that context, there has been a great leveler. So there are a lot of things that you have highlighted, which could actually, probably we should not say in the word reset, because traditional machine-like reset means going back to the old. But what we are trying to look at is probably go into a renewed, I would say, new platform altogether. So I think in that way, it is more not a reform journey or a reset journey, but a transformation journey is what we look at. So I think that's something that comes out. I would like to understand in terms of your perspective of what you have told in terms of community engagement there. There is a lot of mistrust between, because you said community has to be engaged, public-private partnerships have to come together, to be together, data transparency and data silos have to be together. They're all good intents and needed. But the greatest bottleneck for us is the government doesn't trust the private doesn't trust the government, the people don't trust either the private or the government. So how do we actually reset this framework? So is there this one is as healthcare functionaries who still retain an element of respect from in the community at large, in the society at large? What role do you envisage that we should be playing? And are there any lessons that have actually, or models that you have learned from the other countries also where something has actually happened? Because you spoke about Africa being able to manage with community health work.
I think that's a really insightful question. And I don't think there is an easy answer. I don't have a solution for this. But what I can say is that I think governments are responsible for public health. You cannot expect the private sector to take the responsibility there. Private sector could play a role for sure. But I think the overall governance and framework and rules have to be laid out by government and see where the private sector can play a role in a way which is contributing to the overall goals of the system, is not exploitative, and at the same time is sustainable. There is, I think, no doubt that in a country like India, the private sector does play and will continue to play a major role in delivering health services. But you see, it's distributed very unevenly. And while in the cities, you have a good private sector presence, in the rural areas, you don't. And unfortunately, there, the quality of the private providers is, I mean, mostly unqualified people in many states. So this is where I think the government needs to consider. Also, I think we have to think about the health workforce. And I know this is a debate that's gone on for a long time, that is it enough for us to keep on producing more doctors? Or is there an intermediate cadre of people that we need to deliver primary health care? And I feel that it is needed, that you need somebody in between a nurse and a doctor who can provide basic primary healthcare services. That's the only way to run our network of health and wellness centers. And then, of course, the use of digital technologies can be expanded significantly. The e-Sanjeevani platform, etc. Again, there's a scope there for private-public collaboration. Again, the rules need to be set, around privacy and confidentiality, but also around the practices and how remuneration is done, etc. And outcomes need to be measured. I think for all systems, we need to be monitoring, and evaluation is important. And then you need to constantly learn and adapt. And if something is working well, that can be scaled. If something is not working well, we should change it. So if you contract somebody to do provide a service, there should be a monitoring and evaluation of the health outcomes. I strongly believe that digital tools alone will not solve our problems. They are only, they can only be used as facilitatory tools. But ultimately, if you want to change health outcomes, then you need human beings there to deliver those services. On the R&D side, what I spoke about, I think there it's very clear you need the private sector to deliver. Without the private sector, without industry, you cannot have production of medicines and vaccines. But there again, for public health reasons, can we incentivize them to invest in developing products for tuberculosis rather than products for triglycerides or lipids or obesity or baldness, etc. I mean, that's where the big pharma of the West has moved towards products which bring back high financial returns. Their main goal is not public health priorities, but for governments, the goal has to be public health priorities, and you need to somehow attract the private sector into that by providing some incentives and then setting up some funding programs for that kind of work. Thanks.
Thank you very much. I think that was very insightful, looking at basic sustaining life and propelling life rather than looking at cosmetology as the core concern of people. We would again come back for a common panel this one. I would now request the Honorable Vice Chancellor, Dr. S. Sachidanand, to talk about how his university and overall in his understanding of the academic world is looking at the future in terms of educating people for being human resources in health.
Thank you, Dr. Balasubramanian, and my salutations to Dr. Swaminathan, Dr. Santosh, and Dr. M.K. Sudarshan. Whatever I would speak would definitely pertain to my university, that is Rajiv Gandhi University of Health Sciences, the largest health science university in the country. And whatever activity that we went through in the last 15 months would definitely can be extrapolated to any other university for that matter. Probably the same situation would be encountered by all the other universities as well. I would like to outline as to how we responded and what we did during these 15 months to combat the COVID-19 pandemic. No sooner in March 2020, March 2020, the national lockdown was declared. We immediately got into action. The last week of March itself, we got down to work. We said, as a university, our primary role is to, and responsibility is to see that we educate people. We give training to people. These are the two forte that any university should play a role. So we immediately got into action. We gathered all the specialists concerned with the management of this pandemic, and then tried to collect literature across the world, what has happened so far and things like that, and got into action. So the first thing that we started was online training of healthcare workers, because we need to, it was the primary responsibility of the university to pass on the relevant message, authentic information, and also counter any fake information that was floating around at that point of time, because the public at large didn't know what was happening. They're not even aware of the pandemic and the disease per se. Even the healthcare workers were in a lot of doubt, and they were not also well informed. So it was the primary responsibility of the university. We started online training programs. We targeted first the specialists and people who are actually going to manage COVID-19 in the front line. Probably we looked at anesthesiologists, we looked at ICU care specialists, pulmonologists, general physicians, and they were all trained because all of them had to have one thought. They should be looking at treating COVID in one common form. So that is what we initially started. The training started with these things. Then it spilled over to other allied subjects or ancillary subjects. All the doctors were trained in batches. And of course, all this happened online because there was only, we had to depend on the technology and then utilize the best whatever was available at that point of time. And thanks to the various platforms that was available at that point of time, which was provided free. I thank them all because at that point, they all came forward and helped us in reaching out to all these doctors across the state. And then the training went on. There were initially 5 sessions, 10 sessions. It went on to a century, and more than 120 online training programs were organized. Almost every day there used to be one or the other training programs. And with that, we could reach out to more than 2.5 to 3 lakh healthcare workers. Then we thought it is not only the frontline workers and the healthcare workers that they have to be trained. It is also the policemen, the ambulance drivers, the Safai Karmacharis, the public at large. So university expanded its horizon of training all those concerned in the management of protocol, COVID pandemic. This is one thing that we started. Then second thing, that important thing, that university with all its specialists available at its disposal, we thought we should lay down the treatment protocols. Though we had the guidelines from the WHO, ICMR, Government of India, we had to have our own protocols in the state. And so we not only depended on those protocols which are already available, but also designed and discussed amongst ourselves and set protocols which were relevant to our state. And then these were converted into government orders by the government. And then the clinical subject expert committee took on the role of designing protocols and then redesigning it as and when required. As we understood the disease more and more drugs were added, some were deleted. These are the important things that we need to. So far, we have around 4 to 5 versions of treatment protocols, and ensuring the same uniform way of treating patients across the state was also important. Be it government sector or private sector or even medical colleges or clinics for that matter, they had to adopt the same protocol throughout. So that is another important thing. And a third thing that we took up was auditing mortality, COVID mortalities. But then initially there was a trickling of cases, but then when the cases went out and became large numbers, it was difficult to handle by the state unit. Then we had to decentralize the whole thing, and we established task forces, task force committees in each district, which tried to analyze the mortalities in their own respective districts. So it was decentralized at the point of time. Another thing that the university could do at that point of time was to gather its human resources. Being the largest university, we had more than around 2 lakh students who were ready to come out and help us out in any form. Okay. But we had to categorize and pick and choose the students. We could not use everybody. So the interns, the final year students, they were all gathered. They were enrolled as volunteers, as COVID warriors, and wherever they were required, maybe it in COVID care centers or district COVID hospitals, DCHC, they were all deployed there. Some of them are also deployed for online monitoring of patients. For example, if they were in quarantine or in home isolation, we deployed the students to talk to them one-to-one, and telemonitoring and teleconsultations were offered. So this counseling process again was initiated for the first time by the government of Karnataka, and we chipped in with manpower. When as the pandemic went on, we all know that the schools and colleges were closed, and the students were all confined to their homes, and they had to be engaged. Otherwise, they go into all sorts of problems, depression and whatnot. And at the same time, the university had the responsibility of balancing the academic career, career of the students as well. On one side, they had to be engaged. Secondly, they had to be, the academic calendar also has to be adhered to. Examinations had to be conducted. So all these were challenges. So initially, when we started asking all the colleges to start online classes, it took about 15 days or even 20 days to all the colleges to establish these online classes. We had a lot of problems because many students were from the rural background, and their internet was a problem. Their reach was a concern, and many of them didn't have devices to access online classes as well. So they had to be addressed in a different way. And so all these issues were there, but in spite of that, I think to 70 to 80% of students were able to gather onto the online platform and learn a little. So that we had no choice. We had to keep them engaged. So this is what we did. Online classes were made compulsory. Attendance was recorded, and then that helped us to plan for examinations. So initially, when we announced examinations to curtail the loss of academic calendar for the students, there was a lot of resistance. The parents and the students thought, in the COVID, how can they come and write exams? But at least we had to go ahead with all the precautions, with proper COVID precautions and also COVID appropriate behavior, which was emphasized. We could conduct few final year exams. At least the final year students were, allowed to write exams. So the postgraduates wrote exams, and when they passed out, they were all again taken back to work to do COVID duties. Similarly, final year medical students and dental and Ayurveda students, they could get into internship. So they didn't lose much. So initially there was resistance. Students wanted, rescheduling of exams and things like that, but we could carry out and then conduct exams as well. This is one thing. And of course, they realized the importance of having completed the exams and then going on to the further course of their career. They realized that later on. Another thing that we planned with JeevaRaksha Trust, which is a flagship program of Rajiv Gandhi University of Health Sciences, is the COVID crash course. We planned COVID crash course for all the medical officers of Health and Family Welfare, the nurses of Health and Family Welfare and Medical Education Department. So we could give them COVID crash course, wherein within a short time, they were, educated to handle ICUs and patients in ICU, critical care patients and things like that. So this was actually in a hybrid model. Some of them were given online training, and a few of them were also given hands-on training to handle this situation. Going further, we are also looking at in the future to train more and more non-emergency departments like preclinical and paraclinical staff, also to develop as consultants in handling COVID patients in ICUs, outside ICUs as well, so that the burnout that they actually have set in for the doctors who have already handled it for more than 15 months could be handled by a second line of doctors who are ready to take over and establish the same protocols and ensure same protocols are being followed. And Rajiv Gandhi University of Health Sciences also looked at other angles. It organized an hackathon for medical students to come out with ideas at that particular point of time. And we incubated those ideas and then encouraged students to take up research, students and faculty also. We have funded few research programs. At the same time, we also gave permission to many medical devices for being validated, and many drugs. We were so many requests were coming from alternate system medicine like Ayurveda and homeopathy. They were eager to say that their drugs were working for better control. So we had to validate those. And those things were all handled by the university and of course with the help of a few affiliated colleges. The most important fallout of COVID, if I can say one, is the establishment of simulation labs. Thanks to the erstwhile MCI and also the present NMC, which has made it compulsory for all colleges to have its own simulation labs and skill labs. Rajiv Gandhi University of Health Sciences has come forward to establish the simulation labs for both undergraduates and postgraduates at all the government medical colleges in Karnataka. There are about 17 colleges plus 4 new. So around 21 colleges we are taking up to establish simulation centers so that becomes a mode of treatment, mode of teaching and training for not only undergraduate, postgraduate, but also faculty as well. So this is being established in a few months from now. And we have also made it compulsory for all students, both undergraduates and postgraduates, to undergo training, especially in emergency care, handling emergency care, which is essential in such pandemics, and save lives. So these are the things, various things that a university could do, and take its own role, play a major role in handling. So we are all Also looking at research programs with the co-sponsor or rather collaboration with IIT Madras. We are looking at establishing virtual reality, this thing, then augmented reality, and of course mixed reality, mixed programs as well. Through IISc Bangalore, we are looking at training, cardiac arrest training through mixed programs of both virtual and augmented reality. These are the things that are going to be in the future. I think COVID has given us a lot of opportunities to reset ourselves. Dr. Balu said reset is not the word. Restructure ourselves into a different platform than what we used to be earlier. Thanks to NEP, which had outlined earlier itself that future training would be all blended training, hybrid models of training, and we have already got into that. Whether we like it or not, we are into that. And the future would be both online training and offline training. And students have also now come to accept it in a larger sense. And gradually, I think the marriage of convenience between technology and academics has to be there. Medical education is not different from that. We have to blend ourselves and take up these challenges that COVID has thrown in front of us. And we have to adjust to the new norm. Thank you, Balsubramaniam, for the opportunity. And I would like to take up any questions that you would.
Thank you, sir. I think it has been a stupendous effort from the university side. The first and the foremost very impeccable point that came out was, I think COVID actually has broken the barriers of university world by saying that we will only engage with students and faculties of our affiliate institutions to going towards the society at large and meeting safaiwalas as well as community health workers on the field, and saying that even university academic world can actually engage with them and transform them and probably enlighten them in a different framework. So the other appreciative factor is by doing that, probably you're bringing in academic rigor even into a healthcare education program. It means not just healthcare as provider community in terms of the top level echelons, but it is equally important that health education, which is delivered by an ASHA or other community health workers, also stand up to an academic rigor so that the quality of transaction between her and the community will also get engaged. And I think that journey of university in that direction has been very commendable. And I think this is something that the whole world could emulate from your university actions. The second important thing that I thought would be relevant is, in this context, you use the word marriage of convenience. Well, it was a marriage of convenience at the point of engaging in a COVID pandemic when nobody knew what was supposed to be done and everybody was groping in the dark and grappling with whatever they got. And in that context, it was yes. But now I think there has to be a much more harmonious understanding of technology to use it optimally. As Dr. Soumya Swaminathan already highlighted, machine cannot replace everything. And I think the human interface cannot be discounted at any point of time. So how do you think your university is equipping the current generation of teachers who are already completely tuned up to the old scheme of face-to-face engagement to now becoming more and more blended approach of training, especially looking at skills as an important element?
Yeah, I don't find any problem with the younger lot of faculties, there is assistant professor level and associate professor level. It's at the professor level who are already, put in 15 years, 20 years of service are a bit, hesitant at initial thing. Any change that we would like to bring will always be met with resistance, but I don't think that would be a problem at all, because RGUHS is establishing Rajiv Gandhi University of Health Sciences Academic and Administrative Training Institute. This is a training institute which would focus entirely on faculty training and all sorts of training. Maybe it's education methodology or research methodology or even personality, career development. Everything will be handled by this institute. And we are also looking at models where the entire faculty can be trained within a short time. So those sort of things are now shaping up. It could be online method, also offline training programs. Offline, of course, it could be hands-on training for shorter periods, whereas online, it could be employed to sensitize faculty members within no time on a larger scale. And that is what we are trying to do that. This is the way forward. University should gear up to this sort of a thing, and we are looking at the prospects of establishing such institute.
Do you think this would also transform the way the university budgeting starts happening? Because do you require large structures and large areas of engagement with the community going forward in the future world?
As far as budget is concerned, we should not be really constrained. I mean, think about it. We don't have any constraints of budget, but every single penny that is spent on training and equipping and sensitizing our faculty is worth, worth in pounds. So spending penny and then getting pounds of benefit is really a wise thing to do. University should never think of spending or putting restraints on training its own faculty, because though the results may not be immediately seen, but there are lots of tangential benefits on a long-term basis. So definitely it's going to be a worthwhile investment.
No, I'm not talking about this one. I just wanted to re-clarify my question, sir. Basically, I was looking at, because now that there could be a lot more digital emphasis, and do you require the large areas that universities need in order to become a university at all? And creating, so is that, I would say, space required for running a university going to change? Because the university will be within human beings rather than in buildings.
Yeah, I agree to that point, because initially a campus of a university should have been very sprawling campus, large areas, infrastructure being built, much money spent on infrastructure and things like that. Now the concept is changing. Very recently, when NMC has emphasizing more on the built-up area rather than the campuses being, so much of areas restricted, 10 acres or 20 acres or whatever it is. I don't think that should be necessary in the future. We should concentrate more on training human resources, employing more of such technologies which are going to yield in long-term benefits.
Thank you very much, sir. We'll revert back to you again after the other two panelists speak there this month. Can I request Dr. M.K. Sudarshan to share his experience being the chairperson of the task force guiding the government? And probably I would say, I would look at this as a twofold benefit. First time, I would say the public health professionals have come into the limelight, not only in the eyes of the government, but also in the public eye, because people now start recognizing public health as an important entity and a specialist entity. And as again, Dr. Soumya Swaminathan emphasized, that public health cadre, which Tamil Nadu initially created and was probably the leader in the country, which the government of India is now trying to emulate by creating a public health management cadre, I think is something that has come into forefront. And you, as a person who has actually seen the old world of how the public health was looked at, even as MBBS doctors, when we looked at community medicine as a specialty, how many of us really opted for, and so were anesthetists, who were actually not considered as doctors from the outer world because nobody knew about what their role and responsibility was there. All of them have come into the forefront. That is one benefit. The second thing is, at least for the current, I can definitely say governments have started listening to technical people to start devising frameworks, policies, as well as actually ensuring budgetary allocations and actions. So can you share your experience on that, sir?
Yeah. Thank you, Dr. Subramania, for a very usual, wonderful, very jovial and a very smiling introduction about the subject and also about me. I take this opportunity to thank Dr. Ram K. Nair, the CEO of JeevaRaksha, and also Dr. S. Sachidanand for inviting me to this panel discussion. I also extend my greetings to the fellow panelists, Dr. Santosh, then Dr. Sachidanand, Dr. Soumya Swaminathan. Now I will come to my presentation. I have slides to share. Yeah, it is there. Yeah. So my presentation will be from a local perspective, that is from the perspective of Karnataka, and I will assure you that I will take 10 minutes. This technical advisory committee was formed on 17th April 2020 at the behest of Dr. K. Sudhakar, a medical doctor, the Honorable Health and Family Welfare Minister, and also Medical Education Minister. It was his idea, and he wanted a set of advisors to advise the government on this new novel viral disease. And so it is a group of 14 persons, and it consists of virologists, epidemiologists, community medicine, public health, internal medicine, and also Ayush. So it is a team of 14 persons, and we have been discussing many issues are referred to us for technical opinion. And initially we used to meet physically, but after June, I think we started meeting over Zoom. We were not able to, it was not advisable to meet in person. So because of the ongoing pandemic, and the issues were referred by the Honorable Minister, the Secretary, and the Commissioner, and Director, and MD&HM, and others. So my presentation will be to meet the requirements of today's webinar and the panel discussion. One is lessons learned in the last 1 year, 2 months, and also trend. Both may be overlapping, but I will be presenting it very in a simple narration. Though second wave alert was provided in November 2020 about its possible occurrence through a group of mathematical modeling experts, public health, and epidemiologists in the TAC, we call it TAC or TAC, Technical Advisory Committee. So we predicted it on 30th of November that the next wave will occur in February 2021. And of course, somehow I think we were very tired from the first wave, and we were just resting and slowly renewing our energy. And this somehow was missed, and later it was referred to. But you know what has happened between March and May, 3 months, and now as a result of the experience of the second wave, an expert committee now is constituted by the government of Karnataka under the chairmanship of Dr. Devi-Prasad Shetty to provide recommendations soon. It is expected this month regarding the preparedness of the state to address the challenge of a possible third wave. I just leave it at that. I will not go into the details. The sudden deluge of cases of the second wave that occurred in the third week of April to third week of May really taught us a lesson and to prepare for the worst in the third wave. Now, to plan and ensure unaffected non-COVID services, particularly medical, surgical, obstetric emergencies during the next wave or the third wave. So presently the non-COVID services are very severely affected, and the elective surgeries and all are virtually postponed. Most of the hospitals' clinical facilities were converted into COVID. So now we are slowly coming out of it, and based on this experience, at least in the next whatever is the time, we must make sure that non-COVID services remain unaffected. And another thing which, of course, go beyond the scope of the technical advisory committee, but we have come across this discussions, deliberations, that it is even Tamil Nadu is given as a ideal reference, that a non-political approach to this pandemic is needed, and it would be better to have committee of all political parties to address various issues during the possible next wave. I don't know to what extent this is possible, but this is one of the recommendations based on the current experiences. And also to involve philanthropists and religious heads in a planned way. See, this is we have been reactionary, but I think it is time that we act and not to react. To involve philanthropists and religious heads in organizing relief measures to the poor and needy, particularly in the rural areas. So their help and services are largely needed in the rural areas, which is very vast, and they have the religious heads have a greater say and influence in these areas, and we need to take them into confidence and ensure that they contribute and they participate in the relief measures in the coming days. And also to plan for restructuring and strategizing education of children following the second wave. See, what has happened is the children have not gone to the school virtually in the last 1 year and over. So their learning skills, and because the TAC, that is the Technical Advisory Committee, we are also consulted by other departments in the government, whether it is Ministry of Education or whether it is Panchayat Raj, and then also State Election Commission. So many other departments, they consult us, they will seek our advice, and we have found that this is one area which has been very badly hit, the education of the children, school children. So that is from the first standard to 10th standard is what I am referring to, has been severely hit in the first two waves, and particularly the most affected are the children of the poor and those in the rural areas who have no access to technology. And next is to strengthen the smaller private hospitals and gear them up by ensuring that they have sufficient oxygen beds and ventilators wherever possible, that will cater to the requirement of neonate, pediatric and adult with supportive medical manpower to tackle the possible next wave or third wave. To stock up adequate drugs and also ensure other supplies like oxygen concentrators and others, they are available, and we should not be scrambling at the last minute and also leading to various other malpractices like black marketing and hoarding, black marketing. So next is to orient and train in advance for preparedness of the medical and paramedical personnel for effectively tackling the third wave, and this process has already begun, and RGUHS will be the nodal agency, and they have already started acting on this. Now, as per our technical assessment, which we have informed the government, that a possible next wave or the third wave is expected during October-November 2021. So we have had a very detailed deliberations, and which also involved teams of modeling experts and our team of TAC, and we have informed this to the government. And general expert opinion is that in the third wave, more children may be affected. See, for reasons that they are not vaccinated and they were likely to get more exposed, and so it is not that it will be a wave of the children. So between the first wave and the second wave, we know that there has been a marginal increase in both the morbidity and the mortality in the children. So we expect this proportion to go up in the next wave, and when it comes to numbers, these numbers will be large, and we may not be able to easily handle these large numbers in the current scenario of expertise and infrastructure. So we recommended to plan for pediatric services in the hospitals in the possible next third wave. That demands for making provisions for the stay of the parents also, because when children get admitted and when they are seriously ill or when they are sick, the parents will be around and they would like to provide the care, and we need to factor in this component in the handling of the next wave. And to have more provisions for oxygen and to also ramp up for oxygenated beds. To plan and deploy skilled medical manpower to tackle the third wave, and this is now being worked out by Dr. Devi Shetty committee. Not to dismantle the readied infrastructure during the second wave, whether it is CCC or whether it is some government or private hospitals in the peripheries. They should not be, whatever has been readied should not be dismantled, and through suitable planning and certain assessments, so wherever it is needed, they need to be retained so that they can be used at a later date when the need arises. So because it also means that the system of centralized bed allotment, this happened reasonably better in the first wave, but it came to second wave because there was a deluge of cases. It took about 15 days for this to get again reactivated. In the process, in the meantime, there were very serious issues, including a bed allotment scam. So I think we should not give room for such scenarios in the future, and this is one thing which need to be kept in mind. Then community level triaging, they also came up very late. By then when they were almost in place and ready to work, the cases started declining. I think in the next phase we need to ready them and see that they are utilized right from the beginning of the wave, and not when the wave is plateauing or on the decline. And telemonitoring of home isolation also, this happened much better in the first wave, whereas in the second wave we had problems and it took off very late, very late. And to accelerate the vaccination program to cover the targeted population, this is easier said than done. Though not only Karnataka, most of the states have the capacity to vaccinate their people. The problem is availability of the vaccine, which we all know. So I think it is beyond the states, and also now Supreme Court has come into the picture, and some directions are also being given by the Honorable Supreme Court. So I stop here, and I have shared my experiences from the perspective of my working in Karnataka government for the last 1 year and 3 months. And if there are any questions, I will be ready to take on. Thank you.
Thank you, sir, for that very candid presentation of what happened during the course of the last 1.5 years, and what worked and what did not work, and what are the lessons that you have been able to this one. I think what is very, very obvious and enriching is the fact that being at the helm of affairs, you have been very, very candid in terms of accepting what did not go wrong also, and not just hiding this one. In fact, I think again, I reflect back on Dr. Soumya Swaminathan's comment saying that transparency is the first element of trust building exercise. In that way, for trust to get nurtured between stakeholders, amongst the stakeholders, it is extremely important that candid expression is ignored, because errors do happen and we are human to err. Okay. So in that context, thank you very much for that. I would definitely like to come back on questions with respect to the public health management, as well as the collaboration with medical education and how it can be harmoniously blended. That is something that I would definitely be seeking this one, because there is a question clearly saying that why doesn't public health and medical education and health and welfare be merged? So I'm sure you would have your answers for that. So in the interest of time, what I would say is I will take it up in the general discussion after Dr. Santosh also speaks his words. So can I request Dr. Santosh to share his presentation, and then probably we'll go for a common panel. Dr. Santosh, you may like to unmute yourself. There is an audibility issue. We are not able to hear you.
Okay, can you hear me now? That's fine.
Yeah,
right?
perfect. Perfect. Thank you.
Yeah, okay. Thank you, Dr. Balasubramanian. And also thank thank the co-panelist, Dr. Soumya Swaminathan, Dr. N.K. Sudarshan, Honorable Vice Chancellor. Let me directly go into the topic rather than speaking any introduction, because a lot of introduction has been already said about this, about the topic. So perhaps last year, this time, I was in Mumbai with the 150 volunteers from Kerala. It's like last year, this time was the peak of the infection in Maharashtra, which was like terrible. Maybe I think it was almost similar to a second wave which has affected us in other states. It was a similar situation in Mumbai and Maharashtra at that time. So it's like what happened was like that. There was a request from the Maharashtra government to the Kerala government to send doctors and nurses, because there was a lack of human resource in managing hospitals. So even at that time, the Kerala was also beginning to have the surge in the number of cases. So the government asked me, because I was actually engaged in many other activities like this. So to collect people, volunteers from the private sector or volunteers who are willing to go and to help the government there. So I just, it was a campaign through WhatsApp and Facebook, and it was astonishingly, I got a lot of requests or acceptance from a lot of people, very, very young doctors and nurses. Almost like 200 to 300 people applied for that, and I really took them there. So it's like the government of Maharashtra was so kind enough to give us all the hospitality and everything. So, but what I found in Mumbai at that time was really very, very interesting. It's not the human resource issue. It's not that they don't have doctors or people don't have the government doesn't, the whole state doesn't have doctors or nurses. In fact, Maharashtra is a state which has produced a lot of doctors, a lot of medical colleges, a lot of nursing colleges. And why has that happened? So it was really, very interesting to investigate on such a thing. So the findings are quite interesting. So that initially, when there was the infection started, many hospitals had patients, and many nurses got the infection, and they were not treated nicely. They were not given treatment. They were not given good place to stay. They were not given food. So a lot of nurses, especially many of them were actually from Kerala, they just fled back to Kerala. And suddenly what happens is that there was a very big panic. Parents wouldn't allow their children, young children of young doctors or young nurses, to go and work in the hospitals. So this became a phenomenon, and suddenly all the hospitals, the doctors were just not coming to work. Nurses were not coming to work. So that was the situation. It's a plenty of doctors and nurses there, but no one to work. So what made a difference? The first lesson we learned was that I was thinking, why did we come there? That's like the 150 doctors and nurses from Kerala. Why did all these young people wanted to go to such a place and work in a very, very, very difficult situation there? So the answer was quite interesting, because like when I talked to all these young guys, they said that like their parents also never they never allowed them to go out of. Many said that you can't go out. I'll break your leg, or I'll when you can't come back to my home, or so I'll commit suicide. All these were the answers of these were the conversations of the parents to the young doctors and nurses who were ready to come to Mumbai. But they just went out of their home and they came. The moment they got out of their home, they were becoming heroes. The whole media was behind them. These are the young heroes going to Mumbai to help the people out there. And they were all in the media. And moreover, the teamwork which we had, they had when it's in the hospital was a 7-hill hospital with all facilities there. Actually, the environment is much safer than the community outside. Always in a COVID, hospitals are best places to work without getting infected also. When you have enough PPE, when you have enough protective gears, when you have all this negative pressure ICU, everything you can stay there. You have the food there, so it's quite safe. But they realized it's safety, and they wanted to learn. They wanted to be in the front line. They wanted to take the challenges up. So that was the answer. So what we learn. So one thing we learned was that by that last year, by June. The Kerala was also just going to climb climb a peak, and we recognized that we would also fall into such a nasty situation. So when we came back in July and August, what we did was we talked with the government, we talked with the chief minister, we talked with the health minister, and we started a campaign. So the campaign was it's called COVID Brigade Campaign. So it's quite evident that when the leaders of the community, like the chief minister, the health minister, the sign actress, the chief justice, all these people came out and said, "Hey guys, young doctors and nurses, you are the people to save this community or the society in this crisis. So you have to come up and you have to work." And we trained them. We trained them with in all the aspects of the disease. We created a team of people, and we sent them to the places. So that's how we got to know that such a human crisis, human resource crisis, could happen, and it could be solved out. And now it actually worked in the second wave, where we could actually send out almost 25,000 doctors and nurses are being sent out to different places across Kerala from different locations, and they all work together. And this was one of the reasons which Kerala didn't have much human resource crisis. So this was one of the lessons we could learn from Mumbai. And what did Mumbai also learn? That's what's very interesting again. When 150 people reached there, it was so triggering for the whole government to campaign that you guys see this. They address their own society. See, there's a team from Kerala coming down here to work in this crisis. And why are you people sitting back home? It's not possible. So you have to come back and work. So that was a campaign the government started there. They compelled the people. They issued orders for all the registered medical practitioners to be in the hospital to work for at least 1 month in COVID, and it did work. So in the second wave, they didn't have much human resource problem. That's what I felt. So that was one success story or success lesson which we could learn. Second lesson which we learned was when we started working in this 7th hospital, it was it had almost 1,000 bedded ICU beds, and only 50 beds was really working there. So when we started the other ICUs and it went on, when we reached 100 beds, we saw that the oxygen was really in a nasty state. The hospital just had one liquid nitrogen tank, which was not possible because when you use this HFNC and all other high flow nasal catheters and non-invasive ventilation, the oxygen just evaporates. You can't work there with a single oxygen tank, liquid oxygen tank. So they had to bring in 2 other tanks, which was really, which made a huge difference. And we could actually increase the ICU beds from 50 to almost 500, which was really useful at that time. So the same thing which when we came back, we had a similar talk with the government on the oxygen requirement. So this is quite interesting because this is one of the lessons which actually failed, because we could actually implement the erection of tanks across this Kerala state in almost all medical colleges and all district hospitals. most of them have now at least 2 or 3 liquid oxygen tanks. But what happened is the second wave was something which is so much different, which we could never imagine. The tanks were really ready, the pipelines were really ready, but the factory was quite far away in Karnataka or in Palghat. By the time the truck reached here, the oxygen would have been just emptied. So it was not enough. The plan which we made for a first wave actually benefited, but it didn't benefit in the whole way which we intended to be. So we learned that we can't actually depend on liquid oxygen for the whole surge like this if we feel. So we had to go in for oxygen generation plants. We had to go in for almost now, we have like in Trivandrum Medical College, 1,400 bed hospital, almost like 750 oxygen beds, and almost like 360 ICU beds. If you want to run this huge system, you need to have at least, what we have now is like 3 liquid oxygen tanks, one generation, one oxygen generation plant, almost like 800 cylinders per day, and 200 oxygen concentrators. So only if you want to have a big challenge to take up, the big systems to run, you need to actually diversify your oxygen resources. Unless that was a lesson we learned from the second wave. The first lesson we learned was not enough for us. So this was something that is so much interesting to reveal on this. Third interesting lesson which we learned, which never worked out, was like the negative pressure ICUs. It was like a wonderful thing in Seven Hills Hospital. Almost all the ICUs were full of were really negative pressure ICUs, which was really protective for the doctors and nurses and staff who worked there. But when we came here, it was very on one hand it's costly, definitely costly, and it's not very easy to refurbish the present air conditioning system into a negative pressure ICU systems. And whatever we said, it was never going to happen, and it never happened at all. Almost like many of the hospitals have at least till now only 1 or 2 ICUs with the negative pressure, or maybe a 1 operation theater with the negative pressure, which didn't actually work out. But after the vaccination, it seems to be quite okay. The fourth lesson, which was interesting to learn, was like the timing of lockdown, which we are I think something which is where we have learned across the world is that something. We have a report from UK saying that in the first wave, if they could actually prepone the lockdown to 2 weeks ago, they could have saved like almost like 50,000 lives. That was one of the reports which came, and it is quite good to understand from this point, this time scale, now that we have a third wave maybe coming up, and on what point we really need to actually go for a lockdown. So what's most interesting is now we have a lot of softwares and tools which can actually predict the pattern of the wave which is going to come in the coming months. Whenever the number of cases rises, or the number of the TPR goes up, or the recovery rates comes down, or something like that, we can actually see that with all these parameters, a curve can be plotted, and when we look at the curve, when 1/3 of the curve, the point when the climbing, the ascending limb, the 1/3 of the time is the correct time to implement a lockdown. But what happens is that it's very difficult to convince a society that you need to go for a lockdown at that point, because the number of cases will be really less, number of deaths will be really less, there will be still more beds in the hospital, and whatever we say, people really won't believe. And it's actually making, what we understand is that we need to make a lot of planning health education and public education and policy makers education to make them understand that this is the point where we need to implement something as a lockdown, so that the peak, when we reach the peak, number of cases will be really less and our systems won't be overwhelmed. So the final issue is really definitely is going to be what we want is that we want less cases on the peak so that we can actually handle a situation in much better condition. So this is something which we are now trying to say to people, and I don't think how far we would be really useful. Maybe in the third wave, such a knowledge could be better useful. And the last lesson was one of the lessons which I learned from when I was in Sierra Leone way back in 2015 during the times of Ebola. That was one of the very toughest mission I had with the International Medical Corps there, because that was in Sierra Leone. Even when there's Ebola, there's big fighting in those countries, and all of a sudden, in the new town, there was a big fight, and almost 1,000 people had injuries, and we had to go with a special team because operating Ebola patients is quite risky and really difficult. So we had this very difficult, very different way of operations, different way of setting up theaters. We had different ways of actually operating also, because reducing the time of intervention is quite very important. So we had to, I was a part of the team, and after it was quite on one hand, the 21 days of quarantine in the new town, in the outskirts of Newtown, was really traumatic, maybe because without any connectivity at that place. But this after that, I had a very interesting session of 2 weeks with the management of the Ebola management camp, so hospital. So this gave me a great insight when we had a surge in Kasaragod district. So we were actually, in the Kasaragod district is quite near to Karnataka, and there's like, and that place is actually dependent on Mangalore for all the health facilities. And when the borders were closed, people were just stranded. So the number of cases was just rising. People had nowhere to go, and we had to build a hospital within because all the hospitals were really full. Just 2 general hospitals getting filled up with COVID patients, and even non-COVID patients also there. So building a hospital was quite. There was a medical college with an academic block, so we had to go there and build a hospital nobody knew how to build a COVID hospital at that point of time in the last year, April. So the lessons learned from Ebola was quite useful. So it's quite simple that when you go to a place, you just need to segregate the places into a patient area, the buffer zone, and also the service area. So with the available resources, we could actually start a hospital of like a 200-bed hospital in a single day with all the resources which we had. And that was really useful. The most important lesson learned was that it's not the hospital which actually made a difference. The team which just going there and erecting a hospital in 24 hours and admitting patients was a huge relief, and the panic just disappeared in a single day. So that was we had an experience that we can actually build a hospital in a faster manner, in a much easier manner, and we had a similar hospitals built across the state in all these places. So these are the 5 lessons. Maybe like we can have a talk when we have more questions when we discuss. I thank everyone for the patient hearing, and thank you all for this.
Thank you, Dr. Santosh, for bringing in real field experience to understand how people have reacted. What is actually coming out very strongly is that it has been still a very provider-driven initiative in the entire context of the pandemic management. And overall, if we look at whether it is an Ebola, whether it's a Nipah, whether it's a COVID, people's behavior are still not being substantially affected by anything other than, I would say, what has been pushed from the system. So to that extent, I think the engagement is what you're trying to highlight. So thank you very much for this one. And coming on to the common panel, I had definitely short of time, but I would still feel, because of the questions that have already come on the panel, both on the YouTube as well as on this, I would say, Zoom network, I would like to take a couple of questions there. One is, I think this is something that Dr. Soumya Swaminathan would be requested to intervene. The issue is with respect to, there has been voices with respect to both from the public health professionals in the task force as well as the Vice Chancellor. There have been initiatives from the public, and even Dr. Santosh's statement came in where traditional medicines and culture has also started influencing people's behavior and management. What is the guidance in terms of the World Health Organization? Because this could be true in all parts of the world, depending on their traditions, they have something or the other. How does it look at, and what should be the framework in which nations would be guided to take this process forward?
The WHO actually looks at traditional medicine as an integral part of the provision of universal health coverage, is keen to see the integration of traditional medicine into the provision of health services in an appropriate and evidence-based way. So and of course, there are many traditional medicine systems across the world, and this range from, herbal remedies to very well-established systems in different parts of the world. And what is needed, I think, is, or what is lacking, I should say, is an evidence base which convinces the modern systems to integrate this, in a way in which it is a win-win situation, and particularly in a way in which it benefits the ultimate end users, who are the clients, the patients, or people who are trying to stay well. So that is why, in fact, the WHO and the government of India actually have a proposal to set up a global center for traditional medicine in India. It would be one of the WHO global centers that would be focused mainly on the generation of evidence, and not just for Ayurveda or yoga, but for traditional medicine as a whole, setting the standards, because that is also, there are gaps there, definitions and, terminologies of how you handle diseases, which are different between the allopathic and the traditional systems, and then capacity building and training of the health workforce. So this would be the overall goals. And coming to COVID-specific approaches, again, there's been a lot of proposals made. In different countries, different types of traditional medicine have been proposed as being useful. What is lacking, again, is the testing of such remedies through well-conducted clinical trials. Because whether it is for prevention, one can promote the use of certain practices for overall health benefits. Like you say, if you do yoga regularly, you have an overall health benefit, which I think is very well accepted. But we cannot claim that it will prevent COVID unless you do an RCT to show that it has an impact. Similarly, for any medication that you may be taking, either as a preventive or therapeutic, I think the same standard should apply to both allopathy as well as to traditional medicine when it comes to specific claims for specific diseases. So even hypertension and all that, when there have been well-done studies, yoga has been shown to have beneficial effects, in many diseases. So I think there's tremendous scope, really, because we have such a rich heritage of traditional medicine in India. There's so much of knowledge. It now needs to, the streams need to come together. And when I was in the ICMR, I was trying to work a lot with AYUSH to see how this could be promoted. And we had started some trials, in fact, in Belgavi on dengue, Ayurvedic treatment for dengue, and whether that actually resulted in a clinical benefit or not. I've not seen the results of that trial yet, but it was a very well-designed trial. So I think we have to keep an open mind, and many of the medicines we use today have, of course, come from plants. So there is a lot of learning in traditional medicine and in herbal remedies. But what is perhaps damaging are when claims are made without the evidence base, and then arguments begin around those things. And like I said, the same applies to allopathy as well. There were many drugs that were claimed to have benefits in the early stage of this disease, which later on the large RCTs clearly showed that they were not. And there were other drugs which have been widely used, and which in fact, like dexamethasone, like corticosteroids, which in the past have been very controversial whether or not they benefit ARDS. But finally, when a large trial was done, it showed that there was a significant mortality benefit in that subgroup of patients. And again, in COVID, because it has different phases of disease, with early phase being more of viremic phase, and the later phase is more of an autoimmune and an inflammatory phase, which actually is the one that is damaging the body. One drug that works in the early phase may not be the best drug for the later phase. So now that we understand disease, and I think in medical schools in India, I think Vice Chancellor has said a lot about training. The difference between training in India and what I've noticed in other countries is really understanding the biochemical and cellular nature and molecular basis of disease, which today we understand so much more about. If medical students learn to understand it at the molecular and cellular level, then you can actually look at treatments also from a very rational point of view. So I think with all the simulation labs and so on, really looking at a disease from the point of view of what is happening at that molecular and cellular level, going all the way to the clinical manifestations, I think will help our future doctors also to be also more thinking about research in a much more holistic way. Thanks.
Thank you, Dr. Soumya. In fact, that is a very, very educative. This man, in fact, is very appreciative of that wholesome approach to take every science together and actually validate it as a science. I also welcome onto the, I would say, panel in terms of Dr. Ramakrishna Reddy, the Registrar of Rajiv Gandhi University of Health Sciences, have also joined the group. We welcome you on board. So going further, I'm talking about the issue of the AYUSH. There are two questions that have actually cropped up. One was with respect to the protocol of research itself. Whether the component of, because today when we are talking about health, there are two dimensions in which everybody talks. One is the dimension of anthropometric, going to this one and going on a reductionist way up to the molecular and this one, which is actually a very valid argument to put forward and an RCT to be actually supporting it. There is also a second component saying that there is much more to health than just a virus or a bacteria, looking at biological, mental, social, environmental, natural. So everything has got an intermix, and this behavioral component also is adding to it. So this is where the enrichment. So is there any redefinition of the way research designs are looked at, whether there is a scope for experiential learning, also taking into an experiential components of evidence? So how do we relate this to sciences? Experiential science, or what is the observed science? I would say both Dr. Soumya and Dr. Sachidanand could take up the question. I'm sure as a public health perspective, Dr. Sudarshan also might be interested to answer that question.
Madam?
Dr. Sudarshan, please, you can go first.
Thank you very much. Actually, I have also come from a background of medical education. But our traditional and present ways of teaching is compartmentalized. So we are not trained to go into the micro level, into the cellular and molecular levels, except it is confined to biochemistry, microbiology. So we think that it is their domain and they will do it. So now slowly integration is happening, and integrated research is also being promoted. I think the current generation, I think they should take up, and the current generation means those who are in the 20s and maybe in the 30s, now they should go beyond their domains of speciality and into these aspects, and also find the basis for generating the evidence, whether it is macro-medicine or micro-medicine. It is important that the foundations are well laid out by understanding the microbiological and biochemical and molecular basis of medicine. I think we need to go into this way of learning, and the current teaching must start working on this. Over. Thank you.
Thank you very much, sir. I think the important component of the argument is the fact that basically we are trying to look at how to engage the community, because community is embedded in their context and their culture, their belief systems. So how does science enter into that is my reason for this question, because ultimately we need to look at the traditional practices and the households look at, is there a dimension? Because there was one argument to look at, can we declare home as a fourth tier of healthcare and start peeping into it and collating those practices, validating it in a scientific platform, then instilling it in terms of a very validated science to say that those practices which are appropriate, very evidence-based, could be nurtured so that people also start accepting and respecting the science on the other side. At the same time, what is not appropriate could also be screened out. Is there a possibility? And this is how, because ultimately this whole context of behavior amongst the people, which Dr. Santosh also brought out, saying that provider were actually doing so many things, but the behavioral patterns are still the same. How do you engage with the community is the reason why this is cropping up. Can
I take something over this one?
Yeah.
Yeah. Hello. Okay. It's a really controversial issue regarding the evidence, the type of evidence and the pattern of evidence which we need to declare when a drugs or practice as something which is really scientific. So when we on one hand, we have always almost like when you look at the modern medicine, we start from the base of like what we learn in chemistry or physics or something like, which is really down to earth, with a reductionist way of looking at it. But experiences of a person, how it can be actually transformed into a scientific evidence is actually two-pronged. It is a double-edged weapon. On one hand, you can always say, we always take anecdotal experiences as something which is not at all scientific. But how we can
I think that is something that is a common narrative. I would like to ask Dr. Sachidanand, is the university looking at it in a different framework in terms of understanding it in the research framework? Because evidence building is the whole question. Is the research protocols being looked at in a different dimension to actually look at engaging the community and ensuring that community ultimately starts changing their behavior?
Yeah, the primary role of university is also to establish a research culture in its to build up an academic and a research culture. To that effect, what we should be doing is, what we have done, I can spell it out. We have introduced, research activities for undergraduate students. That is the time when, we catch them very young, inculcate the habits of, research bent of mind in their so that they can, as they proceed in their career, they can also take up research as a part of their, profession. So this is what we need to do, and this is already started here. And I'm proud to say that RGUHS is one of the first universities to start research for its undergraduate students, for all faculties for that matter, medical, dental, Ayush, and pharmacy, nursing, everybody. That is one thing. Secondly, to encourage research in medical colleges, we have come forward to establish molecular biology labs in all the government colleges. Here again, this is a step forward. We have laboratories in medical colleges, but they'll be catering only to the service part of it, for diagnosis and treatment of patients. But for research component, if we try to use the same laboratory, the researchers have to wait, and then it doesn't really serve the purpose. So we are trying to establish different molecular biology labs which are handled only for research purposes. So that will definitely give a boost to researchers and conduct research in medical colleges. So it will go a long way. Thirdly, we are also insisting that every college, both government and private, to set aside a fund for research itself. So only then we can think of going forward and creating that academic and research culture. Fourthly, because university is handling not only medical and dental, but also alternative system of medicine like Ayush and pharmacy, nursing. It is university should take it forward, like encourage integrated research, holistic research, and also where these two systems of three systems of medicine could come together and try to conduct research and create evidence-based protocols to treat patients. I think this is what we should do.
Thank you.
I could just add very quickly to that. I think what you bring out, what we sometimes call as self-care, where within the household, how do you take care of your own health and day-to-day practices? Some of them are traditional practices. But more and more today, we see that, the determinants of health are in the food that we eat, which is changing. We're going away from traditional diets to more of processed foods. It's in exercise, it is in the air and the quality of the air and the water, etc. And for all of these, you need community interventions. You need interventions at the household level. And that again goes, to science literacy and health literacy in the community, which is very limited. I mean, today, if you see the understanding of people about basic biological pathways, it's very limited. This goes back to education right from school onwards, building that scientific frame of mind in children, having a questioning mind, being able to differentiate between something which is plausible and something which is completely like a conspiracy. Those things only come with your exposure and your training. So it's also very good, I think, as a VC was mentioning about research in medical schools and in other kinds of colleges also, nursing and other, because research is something which is very neglected in our country. People don't think of it, but actually research is nothing but a documentation of your experiences. And nobody should be limited. I've seen wonderful research coming out of, basic health centers in remote tribal areas, for example, and wonderful research coming out of private sector also. So anyone who's interested can do research, but I think igniting that passion for research amongst medical students by exposing them, encouraging them to do summer internships in a research lab or attaching them to some mentors, bringing the research community in India closer with the practicing community, starting with medical schools, I think will go a long way. And, the Department of Health Research does have some schemes, these multi MRUs and MRHRUs, which are set up in medical colleges and in rural areas respectively. Really was, the goal is to bring research capacity right into the medical schools as well as into rural units like primary healthcare centers. It's a wonderful idea and initiative. It needs further strengthening and support. And I think addressing the issues of the community should be actually the primary, having a conversation with the community in their beliefs on disease causation. It's unless you understand their beliefs on disease causation, you can't begin to address those beliefs. Some of them may be correct, some of them could be wrong. And that's the way to change, behaviors towards more healthy behaviors and also to encourage good health seeking behavior. So both sides, I think providing the access to services is important, because telling the community that you should do this and that and your behavior should change without giving them access to services when they need it is also not good. So both, I think, has to be strengthened at the same time. And then I think you'll really start seeing the benefits. And there are states in India which have tried this and, have been successful. So there are models to learn from. Thank you, Dr. Balasubramanian. I think I have to log off now. Thank you very much.
Thank you very much. I think you did a great work in palliative care, and now palliative care is actually, because you got the definitions for various elements in palliative care as the leader in the research system there. In fact, very unique way. And today palliative care has come into the Ayushman Bharat Health and Wellness Center and reaching out to even household patients. Okay, I'm sure there could be some arenas where these research also start getting into every household in some way or the other. So we look forward to your, I would say, energies and support and guidance for various countries across the world. We are really proud and blessed that you actually have been part of this panel discussion. And we look forward to meeting you in person. So pandemic would allow us to.
Thanks to all of you. Thank you.
Thank you. Actually, going forward, I would say there are a couple of things that actually came forward too. I think primary care should get a boost.
Dr. Balu, I would like to add one more point.
Yeah.
Dr. Balu.
Yeah, please. Please go ahead and add.
Dr. Balu, I would like to add one more point. Community-oriented activity, what a university can do is, one more thing is, to bring out relevant literature through its Prasaranga. It has a publication wing wherein, the experts could contribute in the form of monologues or books or whatever. And if a university brings it out in a language which the vernacular language, and also in the way in which the community understands it, that has more value. I think that is another important aspect a university can take up. And I mean, this is one more thing that we can engage the community with the university.
Yeah. Thank you very much, sir. I think that was very important and I think very encouraging also. I think what has laid down, come back to this one, repeatedly these pandemics has pushed us to rework on one important element, saying that we need to focus on people and people's participation. The second important thing is primary care is the foundation. And probably if you want to unburden the system, as many people told, of the tertiary care and secondary care, you have no other choice but to invest on primary care there. The third important dimension that came in is peep in. Look at every component in a very scientific dimension, peep into every house, peep into every process, peep into every policy, and look at what can be done is something that is coming out as a research agenda for all of us. The fourth P is actually coming out very strongly is partnerships. I think nobody is actually above that, and unless and until we mature ourselves to accept and respect diverse opinions and educate ourselves to be finding the unity in that diverse opinions and diversity in totality, I think the way forward would be a little difficult. But if you accept it, it will actually give us a great energy to move forward. And the education would actually look at more relevance to the total public health at large, because all of us as doctors, when we enter, we have a large hope saying to serve the community. But when we go back, we started looking at where to open the clinic and what drug to prescribe and this one. So moving from prescription of pills to actually looking at working with people is something that this pandemic seems to be teaching us repeatedly. And the way we are going to focus everything, you should be people-centric. And also the policies will have to get tinkered with appropriate scientific data is something that has come out strongly. And this collaboration between the intellectual and the scientific group with the policymakers actually is actually very important. So I would say the peers should have to start working together, whether it's, we have to respect everybody as a peer. Then the second thing is we need to look at public as the central point for all our actions. Third, the policymakers have to start looking at peeping into all the data that the scientific world is able to provide for. And hence the pandemic could be controlled is what the message is coming out from the panel very strongly. And I thank each one of you for contributing immensely to this intellectual cause. And I'm sure this would not only pave way for the people who are actually engaged in this, because we had about 950 registrations when we stopped the registrations. And to that extent, both the YouTube, Facebook, as well as in terms of the Zoom channels have been active. They will be able to take it to every locality and place and people that they engage with. So with that message, I once again thank each of the panelists, Dr. Sachidanand, who has been with us all along, and Dr. Sudarshan, who has been a very humane, humble face at all times, coming out with very erudite, I would say, wisdom. Dr. Santosh, who actually brought out the energies from the field into the platform over here. Without your examples of 5 learnings, I would say the debate on people would have got lost out. I think you put people at the center of all the debate. So thank you very much for this one. So thank you all audience for your, I would say, committed participation and very engaging comments that you have actually sent forward both on the chat box as well as on the question answer session. So if there are some questions which are left unanswered, we would definitely revert back to you with the answers from the panelists. Thank you very much. Have a good evening and a good weekend. Anyway, weekend is over, but a good evening at least. Thank you.
Thank you so much.
Thank you
so much.
Thank you. Thank you so much.
I now invite Dr. Ramakrishna Reddy, the Distinguished Registrar of Rajiv Gandhi University of Health Sciences. Dr.
Good evening. Good evening, everyone.
Yeah.
Good evening.
And I also request Dr. Mahendra, the Curriculum Director of Rajiv Gandhi University of Health Sciences, to also come on to this one. And Dr. Ramakrishna Reddy, thank you very much to start off with. But for your support, energies, both as an internal person, as a trustee within the JeevaRaksha Trust, and as a pivot for the administration of registering Rajiv Gandhi University of Health Sciences. But for your enthusiastic support, we wouldn't have come to this way. And we actually looking at a valedictory, not in terms of saying that goodbye, but actually energizing ourselves to say that a lot of things went well. And I'm sure there are learnings for us to go for the next future. So you have laid the path for the first RGUHS-JeevaRaksha I would say, conference, that to an international conference, getting everybody proactively engaged. Thank you. So welcome to you on this important occasion.
Thank you, sir.
Thank you.
Thank you, sir.
I did not again. Yeah.
Good evening to all. I would like to congratulate all the delegates and organizers for the today's phenomenal conference. It has been a long but fruitful struggle for RGUHS-JeevaRaksha Trust to reach this point in its journey. The Karnataka government's initiative of 108 ambulance emergency response service in 2008 to transfer patients from emergency medical service was boon. However, an evaluation was done in this regard, but the average time to reach the patient is within 30 minutes. The CAG also noted that 108 service in cases of cardiac ailments, respiratory and stroke cases, though the time frame stipulated is 10 minutes, in several cases help reach much later. Even when the patient did reach the healthcare facilities, many healthcare staff they would not know what to do, which led to the death of the patients brought in. This even led to the violence on the doctors. When an assessment on the reason for violence on doctors was conducted, the assessment came out with the results of gap in knowledge and skills of the emergency medical care. It was this gap in knowledge and emergency skill that we sought to address. JeevaRaksha pilot courses were started in RGUHS medical colleges from 2013 to 14. The courses were found relevant and well appreciated by faculties as well as the students' fraternity. With the learnings we were shared with the RGUHS, the university felt these courses could fulfill this lacking. JeevaRaksha Trust was formed as a Rajiv Gandhi of Health Sciences, that is RGUHS special purpose vehicle, with its motto of saving lives, assuring the care. In late 2019, emerged as the world's first ever university certified emergency medical care courses. The RGUHS-JeevaRaksha Trust initiated ECLS for all the RGUHS affiliated medical college students of undergraduate as well as the post-graduation, and BCLS for the dental students, eye students, nursing students, and allied health and pharmacy students by issuing notification on making the course mandatory during their graduation. Recently, the RGUHS-JeevaRaksha was asked to participate in National Health System Resource Center training to build capacity of on emergency medical care to the national primary healthcare teams all over India on accessible emergency care training. JeevaRaksha trainers were invited to be the master trainers to train the other trainers across the country. 120 national master trainers were undergoing this training. The existing curriculum has been adopted and uploaded to the National Health System Resource Center, and the JeevaRaksha Trust is also collaborating in creating the course content for this training. Under the National and State Highway Improvement Project, that is a trauma care service along with highways, has been launched. The medical, nursing and paramedical staff capacity will be better equipped in life-saving care if they get trained in RGUHS-JeevaRaksha emergency courses, which will enhance the trauma care services at existing 140 PHCs facilities along with the national highways. Under the Pradhana Mantri Jana Arogya Yojana scheme, 24 hours emergency medical services are to be managed by technically qualified staff. There is where the RGUHS certified JeevaRaksha emergency courses trained, the medical and paramedical staff will play a major role with their enhanced skill and knowledge in medical emergencies. The RGUHS-JeevaRaksha as of May 2020-21 has certified over 2,000 medical faculties and students in emergency care and life support courses. It has also trained over 2,000 dental students, allied health care workers, police personnel, and essential workers and nursing students. The 152 nursing staff are already been trained in the same. I conclude by sharing that many young medical interns, after finishing their ECLS course, were able to save people who are brought with the snake bites, cardiac arrest, stopped bleeding by correctly by tying with the tourniquet till they reach the medical care centers. This not only ensures the good quality care for the citizens, but also empowers and encourages the budding healthcare workers to be confident and decisive team leaders during medical emergency. In the coming years, RGUHS-JeevaRaksha emergency course certified students from RGUHS affiliate college will be every part of the globe. These JeevaRaksha will save lives and share their knowledge. Sir, audible?
Yes.
These JeevaRakshas will save their lives and share their knowledge and skills with others. They will continue to make RGUHS proud in the global space by carrying forward this legacy of saving lives and assuring the care. Thank you, sir, giving opportunity for this conference.
Thank you, Dr. Ramakrishna Reddy, for this elaborate, this one of the current state of JeevaRaksha and its actions and the great efforts that Rajiv Gandhi University has made in terms of energizing it and also overall taking it to scale where it starts impacting people's life and also redefining the academic standards across the country. May I now request Dr. Sachidanand, the Honorable Vice Chancellor, to say a few words. And I would say we are immensely, I would say, blessed and feel privileged by your presence, sir. And all along, you have been a pillar of our support. And but for that, I wouldn't see this happening at all to this level after 7 years of a small, I would say, the snail pace initiation that it started off and the scale it has achieved. And probably there is a lot more hope that has been created because now even the Indian Nursing Council, the president has come forward and started speaking so highly about it that he wants to incorporate it into the national curriculum, the emergency nursing and life support course going forward. And that will be a big breakthrough in terms of this, the overall training program itself. And that would actually herald a new era for the nurses in the country itself because their ability and respectability both would immensely get influenced by getting absorbed in these sort of things. Second thing is there is also a great effort in moving forward to propel the JeevaRaksha app and the multidisciplinary team training for disaster management that has been already taken care of. So I think these things, and you already have highlighted the importance of augmented reality and the mixed reality issues that the education could take it, and JeevaRaksha and the emergency courses could be the pilot where all these experimentations can start happening before it moves into a scale. So I actually, even before inviting you, I would like to thank you for all your support, sir.
Thank you. Thank you, Dr. Balu. It cannot be overemphasized that, emergency training or training our students in emergency care is of utmost importance, because the level of confidence a graduating student feels when he's trained in emergency is something which is phenomenal, which cannot be expressed at all, because you have to hear it directly from their mouth. Many students have expressed that when they were passed out earlier, they didn't have this training, and the back end of this course, then the training was given to them. They said that was the best training they have received throughout their career, throughout their course. So that is the importance with which, and it instills a sort of confidence in every student. And why not? As RGUHS is of the opinion that every student who passes out from the annals of RGUHS, be it a medical student or a dental or pharmacy or nursing, whoever it is, if he is trained in emergency care, they'll be of use somewhere in some point of time. They can utilize their skills and save lives, and that is the motto of RGUHS. So with that effect, the flagship program of JeevaRaksha RGUHS combination with the support of University of Utah is a step forward in a right direction, and we have set the ball rolling right from 2013. And I'm very happy. Well, many others are still thinking of planning such a thing. Many others have tried and failed also. We have implemented at all levels, and rightly so. It's being appreciated not only at the level of the government of Karnataka, but also at the government of India and many others. The testimony to that is, many other countries are now asking us to train them in emergency care. So JeevaRaksha is here to stay. JeevaRaksha and RGUHS Trust would definitely last longer, has a bright future, a long and very important role to play in future in establishing emergency care in this country, not only for medical but also nursing students, as you rightly pointed out right now. And not only this, it has also created a wave amongst the public also. I have been approached by all taxi drivers association, the Karnataka State Road Transport Corporation, police people, ambulance drivers. They are also now they are aware of these things and they want to get trained. They say let us also learn and be aware of this so that we can save lives, because they are the ones who are there at the spot of accident or whatever, and they can do some justice to on that golden hour. They can intervene and make the patient comfortable and transport them to the hospital. So this is the goal of RGUHS and JeevaRaksha. I'm sure the app that has been launched today will go a long way in helping patients, saving patients, and also giving opportunities for doctors who have learned and are being trained in emergency care to show their skills and save lives. So that is what is the thinking. And there's a bright future for JeevaRaksha RGUHS Trust. It has to take up a stellar role, a more important role, and as it grows, it has to encompass in its horizon of activity more and more such things which can, go into the community and help the community also to take up this role. I thank this, opportunity provided to me, and also with the word that I will always be associated with JeevaRaksha Trust for whatever in the future activities. And thank you so much. Long live JeevaRaksha RGUHS Trust.
Thank you very much. Dr. Mahendra, the Director Curriculum, who has been a very creative energy. The time that he took over as Director Curriculum and being an ex officio trustee, he has been continuously providing a sort of, I would say, as you said, Honorable VC said, stellar support in the back end. He has been a spine within this, trying to get things done. And the innovative thoughts that he comes out with is something that is, and he knows exactly where the problem would emerge and what we should do to actually preempt the problem so that we will be able to move forward without, I would say, seamlessly move forward without any hurdles to face in future. So that sort of creative energies he actually brings in, that sort of foresight he brings into the discussions. I welcome him for this valedictory event. Dr. Mahendra, sir.
Thank you very much, sir. Respected Vice Chancellor, sir, and the rest of the trustees, speakers and participants. I was there till around 4:30 when I had to leave for another program of the Allied Health Sciences training, respiratory care training. So I apologize for leaving in between. And one comment I have to make, the quality of presentations was in fact extremely good. I'm sure the recording of this program will receive many views and many shares. My hearty congratulations to the organizers. The vision that you have had and the kind of skill that is being imparted, which enables people to save lives, because I think the philosophy of the organization is every life matters and every life should be saved. So with this, I thank the Honorable Vice Chancellor and the JeevaRaksha Trust for giving me an opportunity to work with them. It's been an invigorating experience, and I'm sure this is just the beginning and there's a long, long way to go. As they say, promises to keep and miles to go before I sleep should be the philosophy of JeevaRaksha. And I sincerely hope the many miles will be traversed very rapidly. Thank you so much. Thank you.
Thank you, sir. I think that was a words of wisdom, I would say pearls of wisdom. So in fact, it would definitely guide us all along. Yes, we have 12s to cross, and I'm sure we have got miles to go, and we'll definitely move forward in the Robert Frost way. So I would now request Dr. Ramakrishnan Nair, who has been the complete mover and shaker of this conference as far as the operations is concerned, right from the concept level to the current stage. And he has been in the thick of the storm, though smiling he is always. And he has taken the group across the globe to work on this platform. I request him to render the vote of thanks on this August occasion.
Thank you, Dr. Balasubramanian. It is an honor to start and finish a day, however hard and tiring it has been, in organizing and getting together such an eclectic bunch of senior doctors, nurses, allied health professionals, and experts from across the globe. We have been honored by the Minister of Health and Family Welfare and Medical Education, Dr. K. Sudhakar himself, in rendering the inaugural speech and inaugurating not only this conference, but also the JeevaRaksha app. As the Honorable Minister pointed out, this is a vehicle which will be taking the knowledge that we are all gathering today, as well as through multiple life-saving courses across to the community, so that the number of stories that we hear on a day-to-day basis about lives saved is going to be increasing geometrically. I would also like to thank our Honorable Vice Chancellor, and I'm quite proud to call him our Vice Chancellor. You know, there are some individuals who will stay with you for a very, very long time. And he is one of those unique individuals who's been associated with the dream of JeevaRaksha. Then he made it happen as a project JeevaRaksha. He was instrumental in making it a special purpose vehicle under trust. Sir insisted that all students deserve to have life-saving skills training and made it mandatory for the university. And by doing so, sir ensured that a few thousand students got trained across the state of Karnataka, which meant other universities heard about it. Now we've got multiple universities entering into memorandums of understanding with the trust in taking this course forward. We've had interest from different states, different countries, including our close neighbors on both sides. So sir's support, passion, and belief has taken this dream forward. And as sir is looking at further future destinations, sir is leaving us with simulation training in a big way across the state. As you might have heard mentioned in one of the comments, 17 government institutions are being left with skills labs and simulation equipment, which is the largest group of labs happening anywhere in the world at the moment. So a tremendous achievement as a Vice Chancellor, making sure that what Sir dreamt of, what Dr. Sachidanand spoke of, is actually making it happen on the ground. And students for decades are going to benefit from it. So thank you so much, sir, for everything and making it a flagship project of university. I would like to thank our panelists, Dr. Soumya Swaminathan, despite her busy schedule, to log in from far away in Geneva, 3.5 hours behind us. During a lunchtime, actually, Madam logged in and quite enthusiastically participated in the panel discussions. Dr. M.K. Sudarshan, again, a man with multiple meetings every day, being member of the State Task Committee, Technical Committee, etc. Dr. Santosh Kumar, again, wearing quite a few hats, doing multiple jobs at the same time, again, to come in and give us a frontline perspective. All our panelists, including those who joined us from across the borders, Dr. Ashoka, Dr. Narendra, Dr. Vijaya, came in at different time zones in their own home turfs, educated us about emergency care. Our own very enthusiastic, energetic Dr. Lulu Sharif, who coordinated a fantastic simulation session, which has got very high and good reviews. We had 2 streams in the morning, started by Dr. Aruna Ramesh as well as Dr. Sandhya. And it went on with great moderation from Dr. Rajshekhar Mehri and Dr. Marathi. And we had poster presenters, we had case presenters, we had talks by Dr. Vijay Bhaskar Reddy, Dr. Sita Raman, who brought us right down from augmented virtual reality to the grassroots and looking at how to build systems in the communities, in the rural communities where all these skills matter the most. Dr. Chandrasekhar, who came in and told us and taught us about how to recognize stress, how to recognize the early signs of someone who is in extremes of distress, how to look after our own colleagues, be it a nurse, allied health professional, or anyone who is working in the frontline team. So overall, even though it has been a hectic day, it has been extremely informative and educative for all of us. So for creating an academic phase, for giving us a direction through your expert panel towards the end of the day, where the enthusiasm of the panelists and the participants never dimmed, which shows the interest the community has shown in coming together for this conference. And at one point, we had 832 candidates logged in through either YouTube, Facebook, or through the Zoom platform. So thank you very much for all of you coming together from across the globe in making this a success. Very proud to call it a successful first ever Rajiv Gandhi University of Health Sciences and JeevaRaksha conference. Last but not the least, the guiding light who came from NHSRC and Government of India, who has been sitting silently and participating in the background and leading an excellent panel discussion on policies and how to take up the changes, looking at home as the center of health to start with, embedding the knowledge systems that are already there, integrating traditional medicine and modern medicine, looking at evidence. So a lot of balls were shown to us, summarized for us by Dr. M.A. Balasubramanian. Thank you so much for your presence, sir. And our JeevaRaksha family members who came in late and gave us a short but very inspiring speech, Dr. B.J. Mahendra and Dr. Ramakrishna Reddy. Thank you, sirs, for your presence too. I should also like to thank the lateral team, the technical support that have been provided by 3 very young men, enthusiastic, who've been sitting with us in the backside, as well as all of the JeevaRaksha family who came together today to support this conference. So if I have left anyone out, I do apologize. I hope I covered everybody without a piece of paper. Thank you so much for coming together, all of you, and looking forward to seeing you directly or through online platforms very soon. Thank you.
Thank you very much, sir.